appropriate descriptive statistics. Coming to the results, there were a total of 160 patients, and which included 104 patients who are low-grade endometrioid and 56 patients aggressive histology. So of these, 105 patients underwent sentinel lymph node biopsy with ICG, 33 with blue dye, and 22 with combined blue dye and technetium. So when we compare the overall detection rate with 3 techniques, the maximum detection rate was shown by combined usage of blue dye and technetium, which is 90.9, and ICG reached almost near with a detection rate of 87.6%. When we compared the bilateral detection rate, ICG showed perform much better, that is 64% when compared to the other 2 methods. Then the SLN mapping pattern, overall the most common location was iliac area followed by obturator area, and there were a few sentinel lymph nodes located in aberrant locations including parietic and common iliac area. When we compare the SLN mapping pattern of 3 different techniques, it is almost similar, showing majority in iliac area followed by obturator area. And when ICG was used, the location parietic and common iliac area also has lightened up and showed sentinel lymph nodes. And regarding adverse events, there were no adverse events noted in this period specific to sentinel lymph node biopsy. Coming to the analysis of patients who underwent sentinel lymph node biopsy with ICG, that included 105 patients, of which low-grade endometrioid was 63 and high-risk histology was 42, which constituted 40%. So when we took the number of lymph node mets, there were 16 patients out of 105 who had lymph node mets, which constituted 15.2%, of which 14 patients were diagnosed by sentinel lymph node, and all the 16 were diagnosed by SLN algorithm. And there were total 39 lymph node count which had mets. So of the total 39 positive nodes, 23 were positive SLN, 11 were non-SLN pelvic mets, and 5 were parietic mets. So the SLN algorithm identified 34 of these positive nodes. And there was 1 out of these 105 patients who had an isolated SLN parietic mets. And when we went through the patients who had lymph node mets identified only by ultrastaging, there were 8 patients, of which 7 had micromets only, and 1 patient had isolated tumor cells. So of the 39 positive nodes, 27 were macromets, 9 nodes had micromets, and 3 nodes had isolated tumor cells. Then coming to the performance of ICG, in aggressive histology, ICG showed an overall detection rate of 88% and a bilateral detection rate of 57%. And of the 42 aggressive histology patients, 5 patients were detected with the lymph node mets, that constituted 11.9%. So of the 105 patients, there were some patients who during initial period underwent complete lymphadenectomy along with the sentinel lymph nodes. So these were 37 patients who underwent SLNB with complete lymphadenectomy. So for these patients, we calculated sensitivity and negative predictive value. So of the 37, 7 patients had positive nodes, lymph node mets, of which 6 were identified by SLN, and only 1 non-SLN mets was there. So that gave a sensitivity of 86% and a negative predictive value of 97%. And when we did the subgroup analysis for aggressive histology, there were 20 patients with aggressive histology who underwent SLN biopsy along with complete lymphadenectomy, of which 3 had mets and all the mets were in sentinel nodes. There was no non-SLN mets in aggressive histology, giving a sensitivity and negative predictive value of 100%. Coming to discussion, so when we take the compare with the literature, Shrek trial, Centaur trial showed an overall, Shrek trial had 257 patients, of which 49% were high-risk patients, and Centaur had 156 patients, of which 81 had high-risk. In our study, 105 with ICG, of which 40% had high-risk patients. So detection rate of Centaur was 97, our study was 87. Probably the difference would have been because of the re-injection, which made a bilateral detection rate of 95 in Shrek trial. And Centaur had a 77, and in our study bilateral detection rate of 64. And lymph node mets detection rate of 21 was there in Shrek. In Centaur it was 17, and in our study 15.2%, and for which majority of patients underwent sentinel lymph node biopsy. and without full node dissection. And sensitivity, when we compared, Shrek showed 98%, Centaur showed 96%, and in our study, 86%. And negative predictive value was similar between all the studies. Shrek showed 99.5, Centaur showed 99, and our study got a 97%. So the strength of our study was we could comment on high-risk histology patients also, and the limitation was only limited number of patients underwent lymphadenectomy for us to calculate sensitivity and negative predictive value. To conclude, from our study, we got a better bilateral SLN rate, overall detection rate, good lymph node mets rate, even in aggressive histology. So SLN with ICG can be a good alternative for lymphadenectomy, even in aggressive histology. These are my references.
Okay, thank you, Sajita. That was a big study that you did, but it was a retrospective analysis. Yeah, so in this sentinel node biopsies, you did not do complete lymphadenectomy.
No, ma'am. Each technique, initial validation period, we did complete lymphadenectomy.
How many patients was that?
Complete lymphadenectomy was done in ICG group. 37.
How many?
37. 105. 37 out of 105.
Okay, because it's a little confusing. You've mixed up ICG, you've mixed up blue dye and technetium. You could have compared two groups like ICG versus blue dye and technetium. So how did you, what did you want to say in conclusion, which is a better dye to use, and you said you've compared various methods. But methods, we mean injecting methods into the cervix or into the fundus. You said you compared different methods. So by methods
different
you meant
techniques.
You meant different dyes.
Different techniques.
Techniques are different, right? Techniques would be where you inject the dye.
Okay, okay.
Different dyes would be which dye you used.
Okay, okay.
Okay. So there are a few flaws in your study which need to be corrected. So what would you want to use now? Would you want to use blue dye and technetium or only ICG? According to your study and whatever is in literature?
From my study, I got a better bilateral detection rate with ICG, and I got almost a good better detection rate for ICG, which reached 3% short of combined use of blue dye and technetium. And I got a 15% lymph node mets detection rate, which is comparable to the literature which is reported.
Okay, in another slide of yours, you said you had 104 patients with low-grade histology. So when did they become high risk? You said 40% were high risk patients. So this is post-surgery, you call them high risk?
Ma'am, out of the 160 cohort, 104 were low risk histology. And then my secondary objective was to study the performance of ICG. So I have taken the ICG cohort. ICG cohort was 105.
So this is post-hoc analysis. Because you had 100 patients with high risk. You said high risk. 40% with high risk etiology.
Ma'am, high risk histology.
But 40% was not high risk histology.
Ma'am, high risk histology. Of the 105, 42 were high risk histology. That was 40%. So my primary objective was to compare the three dyes, and secondary objective was to compare, find out the ICG lymph node detection rate and in high risk histology. So in the ICG group, there was 105 patients, of which 42 was high risk. So that contributed 40%.
Yeah, let Dr. Rupinder ask, and then we finish. Your time is getting over. Yeah, okay, thank you.
Yeah,
thank you. That was good.
Only thing is, how did you randomize patients? How did you decide which one to this?
Ma'am, this was a retrospective audit done in patients who underwent sentinel lymph node biopsy in our center from 2018 to 2023.
Yeah, it is retrospective, but I just want to know that even retrospectively, how did you kind of decide? At that point in time also, not keeping the study in view, you would have thought of something. Oh. What was your thought process that, okay, this patient should go, or was it just, whatever is available? Was it like that?
Ma'am, I have taken all patients who underwent sentinel lymph node, and while giving, during our practice last 5 years, initially we have started doing for low risk histology, and now we are doing for high risk histology also, ma'am. So that's why 40% of ICG patients I got high risk histology also.
Okay. Thank you.
Thank you, Doctor. Dr. Analyst.
Thank you, ma'am.
Next.
Good morning, everyone. I'm Dr. Annalise, and the topic of my paper is survival outcome of patients undergoing cytoreductive.
Dr. Analyst, can you just give me 1 minute, please?
Yes,
can we just set the timer?
Good morning, everyone. My topic for the paper is survival outcome of patients undergoing cytoreductive surgery for stage 4 ovarian cancer a retrospective study. As we know, stage 4 ovarian cancer includes distant metastasis with 4A pleural effusion confirmed by cytology and 4B, which is parenchymal metastasis and extra-abdominal inguinal nodes or peripheral node positive patients. According to National Cancer Institute, SEER, 5-year survival for stage 4 is 30.8%, and the standard of care for the epithelial ovarian cancer is a combination of cytoreductive surgery to achieve no residual disease and platinum-based chemotherapy. However, we noted in our OPD that a lot of these patients would come with early recurrences. So to evaluate this, we decided to put forward a research question whether cytoreductive surgery and NACT have a significance on the survival outcome in stage 4 cancer ovary, with objectives to estimate the overall survival and progression-free survival, as well as to assess the pattern of recurrence. We did a retrospective audit from January 2017 to December 2019 on the patients who underwent cytoreductive surgery after NACT with carboplatin and paclitaxel. These patients were followed up for 4 years up to September 2023, and the survival was measured in months and estimated by means of the Kaplan-Meier method, statistically analyzed by SPSS statistics. We found a total of 44 patients with a median age of 51 years, where 75% were multiparous, 65% were postmenopausal, 8 patients had family history of other cancers, 20 of them had comorbidities, diabetes being the most common, and the CA125 at diagnosis for 54.5% was within the range of 100 to 1000. Of these patients, 4A were 13 patients and 4B were 31. And as we divided them further, we found that 9 patients had supraclavicular lymph node positive, 9 had inguinal lymph node positive, 5 with umbilical deposits, 4 a cardiophrenic angle noted on imaging, rest all were 1 each with lung nodule, mediastinal lymph node, spleen and stomach mets. These patients underwent neoadjuvant chemotherapy with carboplatin and paclitaxel with a median of 6 cycles, and they had adverse effects in 9 patients which were peripheral neuropathy, 4 had hematological toxicity, whereas 31 had no major side effects. All these patients had a median platinum-free interval of 17.9 months. These patients underwent interval cytoreduction, all of which achieved a complete cytoreduction. When we calculated the LAT score for all their surgeries, only 1 patient underwent an anterior resection, so she was in the high risk. 38 of them were intermediate and 5 of them were low risk. Coming to our objectives, the progression-free survival for patients in our study was 25 months with 4-year progression-free survival of 36.3%. The overall survival median was 60 months and 4-year median overall survival is 47.9%. Coming further to the location-wise, we noted that the longest progression-free survival was for patients who had supraclavicular lymph node with 58.9 months and inguinal lymph node positive with 67.06 months. And the shortest progression-free survival was for 1 patient who had a stomach met and 16 months for a patient who had a splenic met. Overall survival for patients according to the location, we noted that supraclavicular positive, cardiophrenic angle on imaging and inguinal lymph node positive patients did not attain the median overall survival, while the patient who had splenic mets had the lowest overall survival with 15 months only. And all patients who had 4A pleural cytology positive had an overall survival of 44 months. Dividing further according to 4A and 4B, the progression-free survival was 39.6% in 4A and 41.8% in 4B, as we can see on the curve. And the overall survival was not much different in both 4A and 4B with 59.3 and 58.1. Our secondary objectives were to notice the recurrence rate. 33 out of the 44 patients recurred with a 75% recurrence, out of which 23 patients expired. The remaining 11 did not have any recurrence, and till date, 16 of them are alive and on follow-up disease-free. Only 2 of these patients underwent secondary cytoreduction. Recurrence according to 4A, 4B, 2 out of the 11 did not recur in 4A group, and 8 out of the 23 in 4B group did not recur. According to the site, we noted the most common site of recurrence was nodes, which is paratic or pelvic, followed by liver, metastasis, then lung, and the rest. Extra note that I would mention is that during the evaluation of this retrospective audit, we noted that patients, 9 of them, who had supraclavicular lymph node positive, 5 of them had recurrence and 4 did not, with an overall progression-free survival of 36 months and overall survival of 67 months. And amongst the inguinal lymph node positive, 5 had recurrence and 4 did not have recurrence, with PFS of 50 months and OS of 58 months. So to summarize the study, it's a total of 44 patients of stage 4 CA ovary who underwent NACT and cytoreductive surgery and attained CC0 with 75% recurrence noted. Progression-free survival for the patients was 25 months and overall survival of 60 months, whereas 40.44% of patients with extra-abdominal nodal mets had no recurrence. On comparing this with other studies, the JCOG 0602 conducted in 2014 with a sample size of 301, the progression-free survival was 16.4 months for those who underwent NACT and interval cytoreduction, and overall survival is 44.3 months with a recurrence rate of 64%. Whereas a more recent study conducted by Calif J et al. On stage 4 patients with inguinal mets, 562 patients, we found that the progression-free survival was similar to our study with 27.4 months and an overall survival of 67.6 months. However, they did not evaluate recurrence. To conclude, a better overall survival and progression-free survival in our study may be attributed to the platinum-sensitive disease with complete cytoreduction at the hands of a trained gynecological oncosurgeon, whereas these extra-abdominal nodal metastases classified as stage 4B may be considered in selected cases for NACT and cytoreductive surgery for better survival instead of palliative line of treatment. These are my references. Thank you.
So that's a nice study which you have conducted, even though retrospective. One or two things I want to ask. One is that you showed one patient had disease in the stomach and another in the spleen.
Yes, madam.
And these are the patients who had the least survival of all. So why was the splenectomy not done, or maybe partial gastrectomy or something?
Ma'am, these patients had received...
And then you showed that only one patient underwent LAR, which again is a little surprising, because most of these patients who are stage 4A, 4B, wherever the disease has gone, generally pelvic disease is extensive. And all the epiploiky and all are involved, and we generally have to do an LAR to get a CC0.
Ma'am, these patients, the disease was detected initially in the pre-NACT imaging. These were the metastases detected. So prior to the cytoreductive surgery, these patients did not have disease in those areas, and so we just went ahead with the routine cytoreductive surgery and tried and got a CC0.
That's a little unusual, because stage 3 and stage 4 patients will have pelvic disease, and LAR is required than other surgeries in patients with stage 3 and stage 4. The survival rates are good, but would you compare your 44 with they're comparable, but that's a small sample size compared to those 601 patients. So what is surprising is like what Dr. Rupinder said, in stage 4 patients, you didn't have much of pelvic disease, that you did not have to do LAR.
Yes, ma'am. Just one patient we went in.
Yeah, and 60 months is, just about amazing. I think, like what Shalini is saying, maybe that's because of the sample size. That's one. And also, what is also amazing is that of all the patients that you took up, all were stage 4, all of them seem to be having platinum-sensitive disease, which doesn't really happen, In a large percentage of stage 4 disease, you find platinum-resistant disease, which is what makes them stage 4 actually.
But did you use bevacizumab and PARP inhibitors maintenance? Maybe that may have been the reason also for the longer survival.
Ma'am, after only in 5 patients after the in completion of the chemotherapy, then we have used. Out of them, 3 are still disease-free with on that.
So out of those 44 survivors, Bev and PARP were not used except in 3 patients.
Yes, madam.
So I thought maybe you all used aggressive adjuvant treatment, and that's why your survivals were. Okay, thank you.
Yeah, and did you test for BRCA gene?
No, ma'am, not in these patients.
Okay, that definitely is a pointer, and you could do a subset analysis with that. Yeah.
Okay. Thank you, madam. Thank you.
Dr. Sudha, please be on stage. Good morning to everyone. I'm going to present my paper on the impact of COVID virus 19 pandemic on the management of epithelial cancer at our institution. It is a retrospective observational study. The COVID virus pandemic has affected the management of gynae cancers, especially the epithelial ovarian cancer, which requires a long duration of multimodal treatment, surgery and chemotherapy. And during the year 2021, second wave, the health services were worst hit. And because of the theatre facilities were shut down to conserve the oxygen supplies and ICU beds for the COVID-affected patients. So we aim to study the impact of this COVID-19 disease on the diagnosis, modified treatment strategies and treatment completion rate during this pandemic. We designed the study as a retrospective observational study in the Department of Gynae Oncology and Medical Oncology at our institution. The patients with the newly diagnosed epithelial ovarian cancer between the 1st January 2020 and 31st January 2022 were included, and they were grouped into three depending on the year of pandemic. First wave of 2020 and second wave of pandemic on 2021 and pandemic recovery on 2022. Analysis were done with the data retrieved from our electronic medical records, and it was analyzed using SPSS. And one way ANOVA were used to study the continuous variables, and chi-square tests were used for categorical variables. And our study patients, we totally treated about 378 patients over the 3 years, among which 49 were partially treated outside. So total cases taken for analysis were 329. In the year 2020, 90 patients, 2021, 124 patients, and 2022, 115 patients. With the baseline characteristics of the study patients, across all the groups, the median age of diagnosis was 51, and they were similar in the BMI and the domicile and the comorbidities. It was same across all groups. And most of them presented with the performance status of ECOG 1 and 0. Majority of them were presented in the advanced stage of around 75%, and the most common histology was high-grade serous histology. And the time between the first visit and to the diagnosis, which is calculated from the time from the first visit to the date of cytology, biopsy and surgical HPE report, the median time was similar across all the groups at around 2 weeks, which was not significant. We found that there was significant decrease in the primary cytoreduction surgery in the year 2021, and also our primary cytoreduction rate were very lower in the year 2021, with and the more of interval debulking surgeries in 2021. And regarding the perioperative period, we had more complex surgeries. We had done more complex surgeries in 2020, which was reduced in the following years. And we had, and also intraoperative complications were higher in 2020 when compared to the other years. And the primary treatment, the patients were grouped for neoadjuvant chemotherapy, where totally 184 patients were planned. And among them, only 162 patients we were able to initiate the therapy, and 22 patients lost follow-up, and which was very much lower in the 2020, but we subsequently picked up in 2021 and 2022, which was statistically significant. And in the primary NACT, the chemotherapy regimens we used, most commonly we used carboplatin, paclitaxel, 3 weekly regimens, and other regimens were though used, they were not statistically significant across the groups. And the treatment completion rate among the were significant in the 2021, though the primary surgeries were less, the NACT and interval debulking surgeries were more. So we had a significant completion rate in the 2021 group. And but the median duration of treatment were same across all the groups. And the primary, those patients who underwent a primary treatment as a surgery were total number of 145, and among them, there was no difference in the patients who were chosen for adjuvant chemotherapy. And the regimens commonly we used were carboplatin, paclitaxel, 3 weekly. And in the primary surgery group, we didn't find any significant difference in the treatment completion rates, and also in the median duration of treatment. But when we compare all the overall completion rates, taking along the whole study group, there was significant treatment completion rate in the year. It was lower in the year 2020, which subsequently improved in 2021 and comparable in 2022. And coming to my discussion, so with the study, I was able to find that there was no significant difference in the median time to diagnosis and the median treatment duration and the total number of surgeries we have done and the postoperative outcomes and the type of chemotherapy regimens we used. But there was significant difference in the primary cytoreduction rate we had, number of complex surgeries, and the treatment completion rates in the NACT group and the overall completion rates, which were significantly higher in the 2021 group. So this shows that there was a significant, though there was a decrease in the primary cytoreduction rate in 2021, we were able to achieve a completion rate in 2021. But this is reflective of our reallotment of health resources in 2021. And so I conclude that, so from this study, we have learned that we have to restructure our cancer policies to ensure health system resilience in the face of any disaster. And one more thing, the impact of this COVID-19 pandemic on the survival of epithelial ovarian cancer patients will be known with a longer follow-up, which we are currently doing. Thank you.
Thank you. Thank you. Yeah, you did an in-depth study, but I wanted to know how many cycles they received, because normally we operate after 3 cycles. You didn't mention the number of cycles they received during the COVID period, because it went up to 8, 9, and some people had complete response rates with only chemotherapy. So you did not study the cycles that patients received in each of these 3 years.
Ma'am, actually, I have this treatment completion rate in the NACT
It's not
group.
treatment completion. I want to know number of cycles of chemotherapy before you operated on these patients, because in the COVID times, it was easier to give chemo than to operate.
Yes, ma'am. So I have included in my this study those number of patients who completed all 6 cycles and cytoreductive surgery only I have included. I have excluded the patients who have received extra cycles of chemotherapy and those who
Why did you exclude them? Because that's what we want to know in
ma'am,
COVID, how many patients received more cycles.
Yeah, ma'am. Okay, ma'am.
Yeah.
So some
Yeah, and
patients.
also another significant point is which you might have analyzed is the time to diagnose and also the stage at which they were diagnosed. Because of a lot of them, definitely there was increase in time from the setting of the disease and when you diagnose it and the stage at which they were diagnosed. So there were many more patients who were diagnosed in stage 4 rather than stage 3C, which is generally when the stage at which these patients get diagnosed. And that impacted both the treatment as well as the survival.
Yes. So I included an actually advanced group as stage 3 and stage 4, ma'am, but overall it was
See, advanced, that's all right. But most of them get diagnosed only in the advanced stage. So
Yes,
if I were you, I would in fact have put the advanced stage at a stage 4 and the rest at stage 3. Because what is the percentage of patients of ovarian cancer who get diagnosed in stage 1 or stage 2?
they are
Less
very
than
less than
20%.
20%.
Isn't it?
Yes, ma'am.
So the rest was diagnosed in stage 3, are diagnosed in stage 3 and 4, right? Thank you so much. We'll take in the next candidate.
We finished? Yes. Very good presentations, everybody, and I think the quality of presentations has improved over the last decade. Definitely when we were, because we have been associated with EGOI for more than 25 years, and since I think the training programs have come in 2011, and many more centers are, gynae-oncology centers are treating patients. The quality of presentation has definitely improved, and the work that is being done in various institutions has improved. Yeah, that's definitely a change over the last 20 years that we've seen. Thank you.
Yeah, ditto to whatever Shalini said. And I'm so happy to see so many people here in the morning and so much of interest in gynae-oncology now. And in fact, this year I believe that some 6 seats are out in AIMS for MCH gynae-oncology. I hope all of you all get enough work, and I hope all of you all are enthusiastic enough after you all have finished your degrees. All the best to all the youngsters. Thank you. And thank you, Chitra, for having us here, and Lakeshore Hospital too.
Yeah, the beautiful venue, good hospitality, and Dr. Chitra, I think, has to be applauded for being the lead gynae-oncologist in this state and in the country. Yeah, thank you. I think all of you all are here also largely because a lot of people are inspired by Dr. Chitra and her work. Yeah.
Thank you so much, Shalini ma'am and Rupinder ma'am. Ma'am, with the 3 presentations for now, we have 4 more afterwards. So we'll be moving forward to the first session. You have the details. Okay. Invite the chairpersons for the first session. Dr. Lissama Joseph. Senior Consultant, Obstetrician and Gynecologist and Lab Surgeon at Ernakulam Medical Center. Ma'am, please.
Next, I'd like to invite Dr. Simi Raj. She completed her Agoy Fellowship at Lakeshore Hospital here itself and now is a consultant at Tisi Hospital in Kochi. Next, I'd like to invite Dr. Deepa Joseph. She's presently working in the Department of Obstetrics and Gynecology at ESIC Hospital, Ernakulam, and she also completed her Agoy Fellowship here at Lakeshore, Kochi. Our first speaker to kickstart today's sessions is Dr. Michelle herself. Ma'am is currently working as Associate Professor in Gynec Oncology at Al-Azhar Medical College and Kinder Multi-Speciality Hospital. And she has special interests in MIS and gynecology, malignancies and ovarian cancer and preventive oncology. Welcoming you, Ms. Ma'am.
Thank you. Good morning, everyone. Shall I start the presentation? So, topic for discussion is tumor markers in epithelial ovarian cancer, which is often regarded as a scapegoat. So, we'll be going through this session and seeing how we can rescue our tumor marker from being a scapegoat. I'll start with this statement, which is given by ESGO and the various gynec-onco bodies across the world, where they have released a consensus statement on the pre-op diagnosis of ovarian tumors. And they have mentioned that accurate characterization of an adnexal lesion is important to define appropriate treatment pathways. And they specifically say that any suspicious mass requires specialist care and must be referred to the gynec-onco center. Now, the basis for such a statement to be given is the fact that ovarian cancer is a deadly disease, and a major prognostic factor is the rate of cytoreduction. You should always aim for an R0 or complete cytoreduction or at least optimal cytoreduction. And data shows that the survival rates are far superior when you attain R0 resection versus an R1 resection. Now, I also have to mention that a patient who recurs and doing a very good secondary cytoreduction can in no way compensate for a badly done primary cytoreductive surgery. So every effort must be made to diagnose the case and treat the case properly. Now let us go through the available tools that we have at hand, readily available tools, not the other ones. So what we have with us is serum tumor markers and the imaging techniques. We are all aware of CA125, a commonly used marker. It's encoded by the MUC gene. Now, what we need to understand is, although CA125 is a marker for epithelial ovarian cancer, and it is advanced and increased in most of the cases, you tend to miss it in certain cases. So, in advanced cases, only 80% of the cases will show an increase in the CA125 level, while in cases of early tumors, around 20 to 50% of the tumors will not be having an increased value. Similarly, in mucinous ovarian cancers, you may tend to get normal values of the tumor marker. So the CA125 is not specific for an ovarian cancer. It can also be elevated in a normal individual, around 1%, and also other benign entities like endometriosis, fibroids, adenomyosis. It can also be elevated in other cancers other than ovarian tumors. So it is not specific for ovarian cancer, and if you look only into this marker, you will end up with false positives and false negatives. Now, the validity of CA125 as a screening tool has been evaluated by the PLCO trial and the UK trial, and they have shown the limitation of CA125 as a screening tool, and it is not an ideal marker for diagnosing epithelial ovarian cancer either. However, the UK trial has also shown that they did not use a fixed cutoff of CA125. Instead, they went on to the longitudinal screening with CA125. And they have shown that by using the longitudinal screening, by looking at the rising pattern or the trend of CA125 over time in the population, they were able to pick up cases with low volume disease So they were able to do a stage shift or downstage the disease. So diseases which would have been picked only at stage 3C, where we were able to pick it up at 3A and 3B. And this was the benefit of using CA125 as a tumor marker. And as you can see in the graph, when you have disease in the early stage, that is 3A or 3B versus a 3C, you are able to have a better cytoreduction. R0 resection rates are much better. That also translates into better survival for the patient. Now, the other marker that has also been evaluated is HE4, produced by the WFDC2 gene. It is similar to CA125 in the sense it is produced by most of the epithelial tumors. It is not seen in mucinous tumors. Unlike CA125, it is not expressed in the healthy individual or in benign cases. So, though the sensitivity is same, the specificity for HE4 is much higher than CA125. The other markers that are commonly used are also CEA and CA99. They were mainly markers for GI tumors like colorectal or pancreatic cancers, but it was found that these markers are also elevated in epithelial ovarian cancer. However, we should be aware that CA125 is still the highest diagnostic performer to differentiate the benign, borderline, or the malignant mucinous ovarian cancers. These markers can be used in case for distinguishing the different tumor types, or also finding out whether we deal with a primary tumor or a metastatic tumor. Now, for a disease like epithelial ovarian cancer, where the prevalence is not very high, the ideal test for diagnosing or screening purpose should have a sensitivity above 75% and a specificity of at least 99.6%. So this study had evaluated the accuracy of these tumor markers alone and in combination, and they also looked into the ROMA scoring, and none of these tests on its own or in combination were able to give an accurate result in terms of a diagnostic test. So this is a scenario where we usually, it's a commonly occurring scenario. You have a perimenopausal age group lady coming across to you with vague abdominal symptoms. Scanning shows vague findings, some irregular thickening. Tumor markers would be definitely in the normal range or mildly elevated. They would not have been advised anything, and sometime later on they would come back to you where the findings will be definitely suspicious and they would be definitely in the 3C stage. So how can we improve on this? If this is our present situation, what is available with us to improve on this so that we are able to treat them better? So I have two things when we looked into literature. One is called the symptom index by Anderson et al. So in this, he evaluated the symptoms, and he has mentioned that if you look into the specific symptoms of ovarian tumor, like increasing pain, size, satiety, and if you have these 12 times a month, these symptoms in combination with our known markers, HE4 or CA125, if you get a positive test in at least two of these indicators, it gives a sensitivity of 84% and a specificity of 98.5%, which is quite accurate. But they also add that along with this, you require your imaging studies as a second line screen to provide a good positive predictive value for screening. So now I come to the imaging which we have in hand. So adnex model, that is the assessment of different neoplasia in the adnexa. So this is the first risk model, and it helps in differentiating a benign versus a malignant tumor. And also you can subclassify your tumor as borderline, stage 1, stage 3 or more. You can also subclassify it as primary or secondary. Now, when they looked into the accuracy of adnexa or the imaging modalities, they have realized that adding tumor markers like CA125 or HE4 along with your assessment by your expert sonographer, it gave no extra advantage for the characterization of your lesion, and it also ended up to be more expensive. So they have come out with this flow chart to show how to go about a patient with an ovarian mass. So if you can see here, you have a patient who comes with symptoms. They may have some imaging. On ultrasound, if you are dealing with a physiological lesion, then that is well and good. But if not, you need to get it evaluated, find out if it falls into this category of ORADS. So according to this pathway, if it is an ORADS 4 or a ORADS 5, it definitely follows this for specialized care and treatment in the Gynec-Onco Center. If it is 2 or 3, you have to decide accordingly how to manage it. So what I want to mention is, in this pathway, for the diagnosis of a lesion, tumor markers don't come into play. You only depend on the imaging findings to decide the pathway of management, whether it comes here or whether it goes to the specialized care. So what is the role of your tumor marker? The tumor markers are actually coming here. Once it comes, a suspicious lesion is evaluated at the Gynec-Onco Center, you use your markers to decide what kind of disease you're dealing with. Are you dealing with a metastatic disease? Are you dealing with a borderline disease? Or something like an early stage versus a late stage? So definitely there is a role for tumor marker. You decide what kind of disease it is. You decide if it is going for if it can be operable, if you can attain R0 resection. After the treatment, you can see for the response, the biology of the disease, the chemo response. On recurrence, you can find out how it is responding. So this is where the tumor markers play a role and not in the diagnosis. So this is the reason why ESGO and the bodies have come up with this consensus statement stating ultrasound-based models are preferable to tumor markers since they are superior to distinguish between a benign and a malignant tumor. The markers are useful in a suspected malignancy to distinguish between the various types. I'd like to end by stating we doctors should not end up as scapegoats for missing an ovarian tumor. Thank you all.
Thank you very much, Dr. Michelle, for that interesting talk on the relevance of tumor markers in ovarian cancers. The discussion is being planned towards the end. May I now announce the next speaker? The next speaker is Dr. Sucheta S. Madam is additional professor at the Regional Cancer Center, Trivandrum. She has had the training in gynae oncology from Tata Memorial Hospital, Mumbai, IFCPC training in colposcopy and treatment of CIN in Cape Town, South Africa. IFCPC approved clinical trainer for IFCPC IARC online course on colposcopy, and her fields of interest include pelvic radical surgeries and laparoscopic surgeries. Madam has several publications in peer-reviewed national journals. Over to you, Madam.
Thank you, Dr. Amrita. Thank you, Chitra Madam, for giving me this opportunity to be here. So my topic for today is a video presentation on total omentectomy, the thread-bearing procedure. Omentectomy has been practiced for ovarian cancer surgery since 1960s, and omentum has got an immunological role by the presence of milky spots, that is the lymphoid tissue in between the fat tissue, and it is cytotoxic to the cancer cells which is circulating in the peritoneal fluid. And later in the process of the disease, later in the disease process, the immunological process will be overrun by the cancer cells. Then the omentum will become the primary nutrient source for the cancer cells, causing it to proliferate and getting deposited, leading on to development of an omental cake. So from 1960 to 1980, there were two observations which have shown that one autopsy data which has shown 43 out of 56 patients who died from ovarian cancer had omental disease in them. And the second observation was there was an improved survival in patients who underwent omentectomy when compared to patients who didn't undergo omentectomy. So then, after that, ample evidence has come with improvement in the survival with the cytoreductive surgeries, aggressive cytoreductive surgery to attain CC0. So that will support total omentectomy in patients with advanced stage endometrial cancer. Then what about the early ovarian cancer? When you do comprehensive surgical staging for patients who has disease confined to ovary, we'll have a 30% upstaging, of which 0 to 22% will be microscopic metastasis in the omentum. And if you look into the data in detail, you can see that the isolated omental metastasis is very rare. It is only 2 to 7%. And there are certain predictive factors given for microscopic metastasis, such as higher apparently early stage disease like 1C, then higher grade disease, especially the high grade serous carcinoma, and then presence of ascites and increased value of CA125. So why omentectomy is needed means, in early stage disease it should be done as a part of staging purpose, and in advanced stage disease as a part of cytoreduction to attain CC0 to improve survival in those patients. So now we'll see what does the guidelines says. In NCCN, it is given that omentectomy should be performed in newly diagnosed invasive epithelial ovarian cancer, which is apparently confined to pelvis or the ovary, and all involved omentum should be removed in advanced. This is the early stage, this is the advanced stage. And in pediatric patients, it is given comprehensive surgical staging should be performed but may be omitted in pediatric and adolescent young patients who are undergoing fertility preserving surgery. That is based on the pediatric surgical literature alone. And in borderline ovarian tumor, omentectomy should be done as a part of staging. And what does ESMO says is, in non-epithelial ovarian cancer, the staging procedure include infracolic omentectomy. So our practice is, whenever there is tumor confined to ovary, we will do infracolic omentectomy as a part of staging. And in advanced stage disease, we will go for a total omentectomy to remove all gross residual disease. And what are the omental procedures described? The first one can be an omental biopsy, but it is not being practiced in ovarian cancer. And this is the part where you have to remove in infracolic omentectomy, that is at the level of the transverse colon. And this is the supracolic or total omentectomy, in which the whole of the omentum should be removed. And to perform a good and safe omentectomy, you should know the anatomy well. Here you can see the anatomy. Omentum is a double-layered structure enclosing varying amount of adipose tissue, which starts, this is the stomach, this is the transverse colon. This is starting from the greater curvature of the stomach. The two layers will come down with the fatty tissue, and sometimes it is going anterior to the transverse colon, then the small bowel, and sometimes in some patients it will reach up to the pelvis, falls back on itself, goes up and gets attached to the transverse colon. And here the first layer will form the fourth layer, and the second layer will form the third layer of the omentum. And the first, second and third layer of the omentum should go along with the specimen. And the fourth layer will remain in the omental bursa, that is over the transverse mesocolon, that should be retained. And on the right side, it is attached to the first part of the duodenum. See, here is the first part of the duodenum, and here it is continuous. On the left side, it is continuous as the gastrosplenic ligament. Here the spleen will come, so the omentum will continue as the gastrosplenic ligament. And what about the blood supply? The supply to this is a rich vascular structure which is supplied from the gastric arcuate, that is formed by the right gastroepiploic artery, which is originating from the hepatoduodenal artery, a branch of celiac trunk. And here comes the left gastroepiploic artery, which is a branch of the splenic artery. Both will anastomose in between the two layers and form the gastric arcade, and you can get omental arteries. Usually 3 omental arteries will be there, one right, one left, and one middle, but this can vary, and this will form a omental arcade at the lower part of the omentum. So this picture shows a lesser omentum, which is not usually removed. Whenever there is disease in this lesser omentum, we used to remove this part. This is seen between the liver and the lesser curvature of the stomach. Here you can see the hepatoduodenal artery, which is continuous as the gastroepiploic artery, and you can see the one middle omental vessel here. So this picture shows the direction of the peritoneal fluid circulation in the peritoneal cavity. So the cancer cells which are circulating in the peritoneal fluid will get deposited easily in the mobile part of the omentum, that is the greater omentum, that is infracolic part. So this will be involved in the early part of the disease. And to do omentectomy, first you have to, so this is the transverse colon, this is the stomach, this is the transverse colon. First you have to free the omentum from the transverse colon at this point. Then you have to take up and you have to carefully take it from the transverse mesocolon. So this is a transverse colon, this is a transverse mesocolon. And then the omentum will be getting attached only to the greater curvature of the stomach. So after releasing these two areas, you can safely take out from this area, from the below the gastric arcade. So while doing omentectomy, you have to be careful in two areas. First one is the transverse mesocolon, because here it will come the middle colic artery, which will supplies the transverse colon. So if you injure the middle colic artery at this point, there can be a segmental ischemic necrosis, which may end up with resection anastomosis. And what about this area is, this is the splenic area. Here the lower part of the spleen, omentum is attached to this. So while tackling this area, if you give traction to the omentum, that part of the spleen will also come along with your specimen. Then there will be excessive bleeding, and that may end up with a splenectomy. So be careful in these two areas, otherwise it will be easy. So now coming to one short video. So you have to get an adequate exposure by extending the incision above the umbilicus, reaching up to the syphilis sternum. So good exposure, good retraction, and good illumination is needed for performing adequate surgery. And now we'll come across the falciform ligament that also dissected off to get a good retraction. Then you can see the anatomy of omentum subsequently. So here the omentum is coming down from the stomach over the transverse colon, coming down and folded on itself and going to attach to the transverse colon. So this is the fourth layer of the omentum, and it is getting attached. You can see transparency. And this is the mesocolon with a vessel. The right side is attached to this, is from the starting from the first part of the duodenum and extends to the left part towards the gastrosplenic ligament. You can see short gastric vessels at this point, spleen. 2 to 3 short gastric vessels will be there, and this is also part of the omentum. And now you can see the rich blood supply of the stomach. You can see the gastric arcade. And first you have to release it from the right and left side and then proceed with omentectomy. So this is a hepatic flexure. So you have to see the gastric arcade and start dissecting. So this part is being released. This is the gallbladder. It is attached to gallbladder in this case. It is being released from here. You have to dissect off the hepatic flexure carefully. And here we are releasing it from the abdominal wall. This side the omentum is attached. This is the left side. This is the spleen. It's being attached from the abdominal wall peritoneum. And after releasing from either side, you have to dissect it off from the transverse colon. So the transparent area you can see, since the adipose tissue is less, you can easily do it with a monopolar cautery. So you have to separate the fourth layer, which is attached here, and this fourth layer will go along with the transverse mesocolon. You have to take out the third layer along with the specimen. So here you can see the nicely taking out the third layer. Third layer is this one. This is going towards the specimen. And while dissecting, you have to enter into the omental bursa so that the omentum will gets attached only to the stomach. So gentle traction and counter traction is needed. Blunt dissection should not be used at this point. You just give gentle traction. So entering the omental bursa, you can see the dissection is proceeding. So the third layer is taking towards. Here the mesentery is being bared in this area. So take all this. Then going towards the left side again, we are dissecting it off from the splenic flexure. So further dissection is proceeding towards the splenic flexure. And if you continue like this, sorry. Sorry. I have to scroll it. Can you please help me? Sorry. So it is being dissected off from the splenic flexure. When you continue this dissection towards the left side, you will reach the gastrosplenic ligament. So after releasing it from there, you can start with the dissection of the omentum from the, so now it is only attached to the stomach arcade, so your stomach. So you have to preserve this stomach arcade and then start dissecting from here. Here the third layer, third layer is being seen along with the fourth layer, so it is being dissected off towards the specimen. So you can see the pancreas here. So little more dissection is needed to free this area. And then you can transect it from the stomach, that is just below the gastric arcade, preserving the gastric arcade. You can see some omental node here. So for this step, you can use either ligation or energy sources like this is a ligature, or you can use harmonic scalpel. So whatever is available, you can use. These energy sources will decrease the time of surgery. So this part, you can complete it. So in this area, since there was no gross disease, so we were trying to preserve the vessels. And the dissection is continuing towards the splenic part. So this is a little lateral because we want to see the bowel below that to secure that area. And then we will take this part also along with the specimen. Shall I take 1 or 2 minutes? No, it went again went. I don't know what is happening. Okay. Shall I take 1 minute, 1 or 2 minutes? Sorry for the inconvenience caused. So this is being proceeded, and again it is being released from the splenic flexure and from the stomach. Towards that you will reach the gastrosplenic ligament, and it is being removed. So now you can see the anatomy. This is the lesser omentum between the stomach and the liver. So here you can see at the base you can see the pancreas. So is there a risk for omentectomy? For while doing infracolic omentectomy, the complication rate is 0. And whenever there is extensive disease in the omentum which is infiltrating the surrounding areas, you can get injury to transverse colon, stomach, spleen, and middle colic artery. And another question I wanted to, another issue I wanted to put is whether to remove the perigastric arcade along with the total omentectomy. There are 2 small studies which has evaluated the incidence of micrometastasis in the perigastric arcade. Those two studies, one is an Indian study which has shown a micrometastasis of 36% when even if the other part of the omentum is normal. So whether to remove this is a question. There is no complications reported with this procedure, but delayed post-op recovery and gastroparesis. And future research is needed to answer this question. Thank you. I want to thank Dr. Natalis, Dr. Arun, Rema for providing me the iPhone, and Dr. Madhu for selfie stick, and Dr. Shiva for editing, Dr. Arun and all. Yeah.
Thank you, madam. It was a very interesting and informative presentation. As a gynecologist, I have a doubt. Is this omentectomy has any role other cancers, uterine cancer, endometrial cancer, or other cancers, any role for omentectomy,
So
in spite of this ovarian cancer?
in endometrial cancer, whenever there's serous histology and carcinosarcoma, you have to go for a infracolic. We will proceed with infracolic omentectomy. In NCCN guideline, it says ovarian clear cell carcinoma, carcinosarcoma, and serous carcinoma, you have to do omental biopsy. That is what NCCN says. But there is no data comparing the omental biopsy versus infracolic omentectomy to say that which one is better. So we used to do infracolic omentectomy for serous and carcinosarcoma. In
Even though they say that you should do just to take a biopsy, it's always better to do intracolic omentectomy. It's easily done.
Sir, uterine cancer also.
I'm talking of borderline serous ovarian cancer.
Ovarian. I am asking about endometrial cancer.
Yeah, yeah, what she's saying is quite correct. See, normally the thumb rule is when we do mentectomy that for gross disease you should do a supracolic, and for no gross disease do an infracolic. However, whenever there is a serous histology, a clear cell, or a carcinosarcoma of the endometrium, like she's saying, we do infracolic omentectomy.
Thank you. Thank you, ma'am.
Even though like she said, NCCN says omental biopsy, but how much biopsy and what biopsy and all that, nothing is really specified. So better to do off an infracolic.
Thank you, madam.
Yeah, that's from the biopsy, isn't it? Endometrial biopsy will tell you, no? So that is why we say that when we do endometrial biopsies, it's nice to do an IHC on it upfront.
Thank you.
We welcome the next speaker on stage. The speaker is Dr. Priya Bhatti. She is an MCH in Gynae Oncology and currently Professor, Department of Gynae Oncology with the Institute of Sciences. Welcome, Dr. Priya Bhatti.
Good morning to everyone. Thank you for this opportunity. So I'll be talking about risk-reducing salpingo-oophorectomy. So why RRSO? It sounds like a radical step to remove an organ to prevent a cancer, but in ovary we know that advances in treatment strategies have resulted in only a small impact on survival over the last 3 decades. And trials on screening have as yet shown no conclusive mortality benefit. Hence, unlike in breast or cervical cancer, screening programs for ovarian cancer are not recommended. And primary prevention strategies remain the most proven method in reducing the population burden of disease. And in ovarian cancer, this translates into primary surgical prevention. So we have some indications which are backed by strong evidence, like in patients with pathogenic variants in BRCA1, where the absolute risk is 39 to 58%. Patients with pathogenic variants in BRCA2, where the absolute risk is 13 to 29%. Lynch syndrome, MSH2 and MLH1 specifically, and patients with pathogenic variants in BRAP1, RAD51C and RAD51D genes. Now this figure puts across quite precisely what are the indications, and this is in line with the NCCN and ESGO recommendations as well. So the x-axis shows the level of evidence to support the increased risk of ovarian cancer and RRSO, and the y-axis shows estimated cumulative lifetime risk. So generally 4% risk threshold is taken as a minimum threshold to offer a risk-reducing salpingo-oophorectomy. The population risk is 1 to 2%. If somebody has a first-degree relative with ovarian cancer, the risk rises to up to 4%. And there is no recommendations for RRSO at this time in this group. In the gene mutations of BARD1, and NBN, and ATM, there is insufficient data to recommend, although the risk falls in about 3 to 4% of category. In PMS2, PALB2, and MH6, the data is controversial. In BRAP1, RAD51C, and RAD51D, the risk is high enough, up to 20%. And the recommendation is to offer RRSO at the age of 45 to 50 years. In MSH2 and MLH1, it is recommended to offer at completion of childbearing, but not earlier than mid-30s, because the risk is very low before that. And in BRCA1 and BRCA2, the age is 35 to 40 years in BRCA1, and can be referred to 40 to 45 years in BRCA2. So what is the reduction in ovarian cancer risk by doing RRSO? So there are only prospective observational studies and a meta-analysis, and what they have found after all this is that there is an 80% reduction in ovarian cancer and 68% reduction in all-cause mortality. But the continued risk of peritoneal carcinoma is still there, which in different studies have been found to be anywhere between 1.7 to 4.3%. The causes for this have been given as an occult malignancy which was already present at the time of RRSO, or some exfoliation of the cells might have happened, or some part of the ovary or tube might have been left behind during the RRSO. So all these are reasons which have been put forward, and the risk is found to be highest in BRCA1 carriers, especially in the patients who are found to have STIC during the RRSO. So what is the effect on breast cancer risk? Earlier, the data on breast cancer risk reduction was supportive, but the latest data has called it into question, especially for BRCA1 carriers. So now, there is a large study which showed that it has a non-significant trend to reduce risk of breast cancer in BRCA2, but not in BRCA1. And finally, now, overall, the data says that RRSO reduces the risk of breast cancer in BRCA2 if done prior to age 50, but not in BRCA1 carriers. So when should it be done? In addition to the lifetime risk, a critical factor is the age when the risk of the cancer begins to rise. For BRCA1, the risk begins to rise at 35 years, and the risk is only 2% below age 40, and it rises to 5% if 2 or more first-degree relatives with ovarian cancer are there, and it becomes even more significant after the age of 40. For BRCA2, this risk does not begin to rise before 40 and becomes more significant after the age of 45. So here it's important to remember that you have to balance the drawbacks and the side effects of acute surgical menopause with the benefit, with the supposed benefit it may give to that patient. So RRSO doesn't need to be undertaken before 35 to 40 years in BRCA1 and can be delayed till 40 to 45 years in BRCA2. And ovarian cancers not linked to pathogenic mutations are more likely to present after the menopause, with risks beginning to rise after 50 years. Preoperative evaluation should include a screening for an ovarian malignancy with the sonography at least, and a baseline serum CA-125. Counseling should include counseling for a staging procedure if malignancy is found intraoperatively. And while HRT can ameliorate the negative side effects, it cannot completely alleviate all consequences, especially sexual dysfunction. And these issues, along with a 3% reported surgical complication rate should form part of the informed decision-making process. So the surgical procedure involves, usually MIS is preferable, laparoscopy is very convenient. A systematic survey of the upper abdomen, bowel surfaces, omentum, appendix, and pelvic organs should be carried out. Peritoneal washings are taken. An omental biopsy and cytologic smear of the diaphragm can be done as well to detect any occult disease. And suspicious areas should be biopsied with liberal use of frozen section so that we can proceed to staging if any malignancy is found during the frozen section. All ovarian tissue should be removed. And if adhesions between the ovary and other peritoneal structures are present, the entire adhesion should be resected with the ovary. The ovarian artery and vein should be clamped and cut at least 2 centimeters proximal to the ovary. This is to make sure that the entire tube and ovarian tissue is removed, and preferably at the brim to avoid leaving any ovarian tissue behind. And as much of the fallopian tube as possible should be removed. Complete femoral resection is important, but complete cornual resection to remove the intramural portion of the tube does not appear to be necessary. So what about concurrent hysterectomy? In patients with Lynch syndrome or patients with coexisting uterine pathology, it's a straightforward decision to make. Or in patients planning to take tamoxifen for chemoprophylaxis of breast cancer, it makes sense to remove the uterus. Or in the patients who wish to take unopposed estrogen therapy for relief of menopausal symptoms. Estrogen alone appears to be associated with a low breast cancer risk. So in that case, it might be better to remove the uterus to prevent any malignancy of the uterus because of the estrogen. Pathological evaluation, multiple 2 to 3 millimeter longitudinal sections should be taken of the resected ovaries and tubes. And CFIM, the sectioning and extensively examining the fimbria protocol is used. In this picture, you can see that the fimbral part of the tube is cut longitudinally, whereas the rest of it is cut transversely. So how to follow up these patients? Follow-up as in immediate post-op follow-up. If there is an occult malignancy on pathology, surgical staging has to be done. And chemotherapy may or may not be required depending on the final histopathology. Observation alone with or without CA-125 testing if there is no invasive cancer is found. In STIC, the role of surgical staging and chemotherapy is not clear. There is not enough evidence to recommend for or against it. And the surveillance for peritoneal cancer, there are no recommendations, but an annual pelvic examination and serum CA-125 can be carried out. So what are the adverse effects? So generally, overall good quality of life has been shown in studies after RRSO, and there is reduced anxiety regarding cancer. But there are the obvious side effects of acute surgical menopause, physical vasomotor symptoms like hot flashes, night sweats, sleep disturbances, decreased sexual desire, vaginal atrophy, osteoporosis and arthritis. Cardiovascular health is affected. Asthma and COPD also have been reported to be higher. Here the side effects are much more acute and more pronounced because it's a very acute cutoff of the hormones rather than a natural menopause which happens gradually. What are the HRT options post RRSO? Short-term HRT up to 3 years doesn't negate the protective effect of RRSO on development of the subsequent breast cancer. Alternate treatments for vasomotor symptoms like venlafaxine and gabapentin should be discussed. And the genitourinary symptoms can be treated with local estrogen. So now we know that tube is, for a large number of ovarian cancer, tube is the origin. So the concept of interval salpingectomy with delayed oophorectomy has been proposed. So we have studies showing that it has better quality of life and better menopause-related symptoms than compared to RRSO, but whether it's safe and whether it's effective in preventing the cancer is yet to be studied, and there are ongoing trials which are studying that. So these are the TUBA and WISP. These are the trials which studied quality of life basically, and they have found better quality. TUBA WISP 2 it's a prospective preference trial, And it is investigating whether salpingectomy with delayed oophorectomy is non-inferior to RRSO. So to conclude, despite the drawbacks, RRSO remains the best available protection for patients during the interval salpingectomy with delayed oophorectomy are currently not recommended outside of trial settings. Age at RRSO should be tailored according to the estimated risk and family history. Usually, if there is a strong family history, it is recommended at 5 to 10 years earlier than the youngest member with the cancer. And options for fertility preservation should be discussed with the patient if they have not completed childbearing, and oocyte preservation is an option. Menopausal symptom alleviation is very important. And counseling regarding the need for continued surveillance for other cancers associated with the carrier mutation should be done. Thank you.
Thank you, Priya. We'll take the questions during the discussion time.
Thank you so much.
I'd like to invite the next speaker, Dr. Amrita Ramachandran. She is additional professor of ONG and gynecologist at Government Medical College, Wayanad. She's also done at Amrita Hospital and also a fellowship at Roswell Park Center. Over to you, Dr. Amrita.
Thank you, Dr. Michelle. At the outset, I would like to thank Dr. Chitratara Madam and other office bearers of AGOI for having given me this opportunity. The topic given to me is, do we do salpingectomy or BSO during a hysterectomy for benign diseases? Is it actually a false belief, or does it actually produce relief from this disease? Now let us revise the pathogenesis of high-grade ovarian cancers in the beginning. High-grade ovarian cancers, or type 2 cancers as we all know, is the most common histological type, and it accounts for about 3/4 of all ovarian cancers. And it is known that certain genomic analysis of high-grade cancers have identified alterations like TP53, BRCA1, 2, P10, and other genes. Now, with this background, we will proceed further. New pathological evidence has come. This was all part of the salpings and ovaries which are removed as part of the prophylactic surgery, prophylactic RRSOs, as spoken by the previous speaker. So there are potential precursor lesions of high-grade lesions which were identified in the fimbriae of fallopian tubes, and they were removed as part of prophylactic surgery. Now these lesions include P53, which is a P53 signature, which is actually a mutant single layer epithelial layer, and also the stick lesions. And actually immunohistochemical and targeting sequence analysis have shown that fallopian tube lesions harbor the same P53 mutations as the surrounding ovarian cancers. Now, this is the picture of a P53 lesion. On the left side, you are seeing a single layered series with no apparent aberrant morphology. In the middle, you are seeing P53 overexpression, and on the right side, a low Ki67 labeling index. Now, this is typical of a P53 signature seen as a precursor lesions, and this might be there in the high-grade ovarian cancers as well. Now, serous tubal intraepithelial lesion. Here, in the H&I hematoxylin and eosin slide, you are seeing moderately apparent morphology. For instance, you are seeing some stratification here. In the middle, you are seeing, P53 overexpression, and again there is a low Ki index. The next slide is the immediate precursor, or the stick lesion. H&E showing definite aberrant morphology. You are seeing stratification here, but it has not gone into the stroma. P53 overexpression and a high Ki index, labeling index. So these are some of the precursor lesions, and this is the argument behind which we always say that, we now say that the precursor lesions or the fallopian tube is probably the reason why some of the patients are going in for a high-grade ovarian cancer. So this is the tubal pathway following this particular hypothesis. There are serous cell outgrowths, which then become tubal intraepithelial lesions, stick lesions, and then a high-grade invasive cancer. Now this is the hypothesis which which I've been talking about today. P53 signatures initially becoming a stick lesion, and there might be seeding. And the ovarian stroma forms a fertile soil for these malignant cells to grow and proliferate, and then they can produce distant metastases. So with this background in pathology, let us go and see what the clinical evidence is saying. Does it actually give release from disease? Now the first important study which threw light was this study from Sweden by Henrik Falconer. He did a retrospective cohort study for a large population. It was a population-based cohort study where women with previous surgery, benign indications, about 2 lakh in number, were compared with the unexposed population, which was 54 lakhs. And this was a long period between 1973 and 2009, and analyzed with Cox regression models. And surprisingly, this was the result. Please see that with salpingectomy, the number of ovarian cancers in person years with the salpingectomy was 81. Even with the sterilization, it was 284. With hysterectomy, it was 278. And most importantly, the unexposed, without any surgeries, it was 30,700 odd ovarian cancers in person years. Now, what was the pattern like over the years? This is the pattern over 0 to 4 years, 5 to 9 years, and 10 plus years. Again, you see that salpingectomy, the number of ovarian cancer person years is only 13. Even with sterilization, it was 15, whereas the unexposed, a large number, 3,818. Now, this is incontrovertible evidence that salpingectomy confers some sort of protection against high-grade ovarian cancers. So the results were a statistically significant lower risk for women with previous salpingectomy, so also with hysterectomy, with sterilization, and also hysterectomy with BSO, which confers the biggest reduction in risk. So with this knowledge, now this study came out in the previous study, Falconer study came out in 2015. Even prior to that, in 2013, the SGO had come up with a clinical practice statement, which said that salpingectomy may be appropriate and feasible as a strategy for ovarian cancer reduction. Now with 2015 and Falconer study, it became confirmed. So that is how the ACOG committee opinion came about. And in 2015, they said prophylactic salpingectomy may offer clinicians the opportunity to prevent ovarian cancer. Again, it was modified in 2019, where they said opportunistic salpingectomy is the strategy for epithelial ovarian cancer prevention. So the current recommendations are that salpingectomy at the time of hysterectomy or as a means of tubal sterilization does appear to be safe and does not increase the risk of complications like blood transfusion, readmission, etc. Ovarian function does not appear to be affected by salpingectomy at the time of hysterectomy. Now this is important because a reduction in ovarian function during salpingectomy may produce premature ovarian depletion, ovarian failure-like symptoms, and menopause-like symptoms, plus long-term issues like increased all-cause mortality, coronary artery diseases, Parkinsonism, etc. So the surgeon and patient should discuss the potential benefits of removal of fallopian tubes during hysterectomy. Now these are the recommendations. And counseling of women who are undergoing routine pelvic surgery should include discussion on salpingectomy and BSO. Now the risks and benefits of salpingectomy also to be discussed whenever patients desire permanent sterilization. The only thing is that the performance of an opportunistic salpingectomy should not alter the intended route of hysterectomies. For example, if you're planning to go ahead with a vaginal hysterectomy, now just because we should do a salpingectomy, we need not convert it into a abdominal procedure. Now this is another study which, in addition to the Falconer study, shows that there was another study from Denmark as well as from USA which confirms our studies of risk reduction by several percentage, 77, 42, and 65%. Now, the strategy was included by various gynecological societies, and how has it affected the outcomes? So in 2023, outcomes from various procedures performed was studied and tabulated, and this is one particular study in British Columbia, Canada, where they compared opportunistic salpingectomy on 25,000 patients and compared with 32,000 other patients, and these patients were followed up till 2021. And surprisingly, the number of cancers, the number of expected cancers in the opportunistic salpingectomy group, serous ovarian cancers, the expected was so much, but none were observed in the other arm. Epithelial ovarian cancers, we had so much of expected, none in the observed arm. Surprisingly, breast cancer, there was not much difference, maybe because we have retained the ovaries, and not much difference in colorectal cancer as well. Does ovarian salpingectomy cause early menopause? It is a concern, and it was examined in detail in this particular study, where they evaluated whether early menopause can follow an opportunistic salpingectomy, again from British Columbia. And the conclusion was there is no indication of an earlier age of onset of menopause among those who underwent hysterectomy or sterilization. Now this was measured by the number of physician visits for menopause-related symptoms, or the number of patients who started HRT following a salpingectomy. So we can rest assured that there is no early menopause following an opportunistic salpingectomy. So when do we choose BSO over opportunistic salpingectomy? As the previous speaker said, salpingectomy should not be offered to women with a BRCA mutation or a history of breast cancer. In such patients, the therapeutic benefit of oophorectomy is increasingly recognized and should be done. And we know that bilateral oophorectomy produces certain long-term effects on women. So BSO before the natural age of menopause, I have spoken previously, increases overall mortality, coronary artery diseases, dementia, Parkinsonism, osteoporosis, mood disorders, sexual dysfunction, so not to be offered. The current recommendations BSO for women without a genetic mutation or a family history of ovarian cancer suggest that prophylactic oophorectomy is not recommended for women under 40, but routinely recommended for women above the age of 55. Now recommendations vary greatly between the age 40 and 55 years, which is a gray area, and we have to individualize according to the patients and their individual features. So I come to the end of the speech. The key points to be taken is that for women without genetic mutations or a family history of ovarian cancer, opportunistic salpingectomy is recommended. This is new. This has happened in foreign countries, slowly percolating to our place. Opportunistic bilateral salpingo-oophorectomy routinely done for women over the age of 55 years. Thank you very much for your patient listening.
Thank you, Dr. Amrita. Now, the first session is now open for discussion, and I request all the speakers to come onto the dais.
Dr. Amrita, from your presentation, I didn't get how many cancers were prevented by opportunistic salpingectomy done over 1 decade. How many years did they study, the Canadian study?
The second study, madam?
The Canadian
first
study,
was the
they were the first one to start, right?
Yes, Falconer was the first one. It was a retrospective cohort, and here they actually studied 2 lakh patients with salpingectomy
Yeah.
and around 50 lakh people who were unexposed. Without.
So how many did they prevent? They've analyzed how many years later?
I think around 2014, 2015. So they had that much of
so
years.
how many cancers were prevented?
Cancer, I have given only a risk reduction in terms of percentage and also the number of ovarian cancers years.
No, because you said none were observed in the ones which
That was the
salpingectomy.
second study, madam. That was the second study, the Canadian study, where they had 2 cohorts. One was around 20,000 patients who had surgery, opportunistic salpingectomy. The other was who were unexposed. And I don't have the numbers, but I have only the graph.
We want to know those
Yeah.
statistical figures. How much have been prevented? Because left, right, and center in the last 2 decades, even in India, we've been doing it. So, but we've not seen any reduction. So, is there any
So
hard evidence that
the
it has
second
really
study has
reduced?
got a limitation in the sense that it was the time follow-up was little. I mean,
So, we
not
still
that.
don't have data.
Yeah, we have only projected data.
As Madam mentioned, both the cohorts, the opportunistic salpingectomy cohort actually had no serous ovarian cancers, whereas the other had 5. That's how they have mentioned. So that is the risk reduction that they have mentioned regarding it. It's a retrospective cohort, but then over a decade, and then they followed them up. And in those patients who did not undergo salpingectomy, over that, it's out of 20,000 plus, you had 5 in them and 0 the opportunistic salpingectomy. So that is what they have commented. Yeah.
Yes, thank you, Deepak. I did not
Because we are
include them
doing
in my
it in
slides.
large numbers nowadays, so we have to, when gynecologists ask us, does it really help? Because we've been doing it routinely. I think everybody does it for benign disease. But we've not actually seen hard statistics. He said out 5 were prevented of high-grade serous. So that's good even if 5 were prevented, because you're removing an organ which is anyway not required after a certain stage. Yeah. Thank you.
Dr. Michelle, you told that CA125 will increase in benign and malignant conditions like fibroid uterus, endometriosis, like that. Is there any cutoff value of CA125 to distinguish between benign and malignant, whether 500 like that?
There is no definite cutoff. There were studies which looked into increasing the cutoff ranges, especially in the premenopausal age group. Some studies used hundreds. ACOG at one point asked for 200 cutoff, but none of them could accurately, the sensitivity, specificity, the positive predictive value was not really altered by increasing the cutoffs. You have to trade between missing cases and overdiagnosis. So you don't want to increase your overdiagnosis, neither do you want to miss a case. So even by changing the cutoffs, we are not able to exactly determine which cutoff would be useful. Like there was a study which tried 75 as a 70 as a cutoff, especially in the premenopausal age group. But none of these studies could categorically state that this is a good diagnostic marker or a value for which you can confidently say a lesion is benign or a lesion is malignant. And that is why ESGO came out with the recommendation stating that when you have a imaging, you have simple rules. So you don't need an expert sonographer to tell you whether a lesion is benign, malignant, or inconclusive. Using simple rules, you can do it. So they have taken away tumor marker as a diagnostic test. But still, that is why I did mention about the UK trial, which showed that serial longitudinal, when you look at the patients serially, you can identify low volume disease. So tumor markers are not to be removed off as an entity. It should be used, but you should know how to use it and use it accordingly with your imaging and your symptoms. That is why I put in the symptom index as well. So one cutoff that could be used probably, as ACOG has once said, 200 value is one. But again, you cannot really depend on that one value and say for sure. You cannot afford to miss a case. Even a couple of months, a type 2 malignancy can change over. So we really cannot afford to miss that. And that is why this has come.
Can I make a comment on this? Yeah, I think CA125 values are not alone used for diagnosis. They are prognostic markers, because 50% of stage 1 and stage 2 will still have normal CA125 levels. But they are very good markers for postmenopausal women, in which it is usually never more than 30. In premenopausal women, you can have a range of benign diseases which can have high CA125, including tuberculosis, where it can go up to even 8,000, 7,000. So it is not really a diagnostic marker. It is a prognostic marker, because you can see the fall in levels after your treatment. You understand? And a lot of people go onto the net and then look at 70, 80, 100, 200 and say we have cancer. So maybe it is, especially in stage 1 and 2, only 50% may be raised. And still you have malignancy. So you can't just go. It has to be corroborated with your imaging findings, symptoms, CA125 values. It has to be, you can't go by one parameter for diagnosis.
Definitely not one parameter, ma'am.
In pregnancy also,
If I can just add to that, all of that, what has been said is quite pertinent. The best role of a CA125 is actually to diagnose a recurrence. That is actually the best role. No? So if the markers have been, you've been following the marker, and subsequently on follow-up, if there is a rise in that, then perhaps you have to be vigilant, though it does not, again, just a mere rise in CA125 does not mean that you have to treat the patient. No, you have to follow it up with that.
in pregnancy also, this early pregnancy, 18 scan, they will give an ovarian cyst, a corpus luteum cyst or something, 4, 5, 6 centimeter. How we can follow that? Early pregnancy with the ovarian cyst, in scanning they will write 4 centimeter, 5 centimeter, maybe corpus luteum cyst like that. What you have to do then?
Can I take that? See, that is why, madam, I have mentioned in the end I did mention about ORADs, where you have to say whether it's 1, 2, 3, 4. And if you look into certain models, they are taking away all these subjective assessment like vague thickening, a little bit of vascularity. You have to be very specific. If you have papillary projections, you mentioned the number of projections, the thickening, everything is very specific. Objective and subjective methodology is done with. So if you have a lesion even in pregnancy, you have to, even if it's a unilocular cyst, you should categorize the cyst as an ORADS 1. And depending on that, you manage it. Just because she's pregnant doesn't mean that the characteristics of the ovarian lesion is going to be altered. Maybe vascularity could be there due to the pregnancy, but we can still find out what type of lesion we are dealing with. Not subjective assessment by the sonographer.
And Michelle, there are newer biomarkers also, tumor DNAs and microRNAs, which are upcoming. Your comments on that?
Yeah, I didn't put that in my presentation. There are a lot of new markers coming up, like DNA methylation is one of the markers which can help in the early diagnosis of ovarian cancer, especially when CA125 is normal. This can help, but it is not. And so whether we
Yeah, trials are there, and probably these will come and replace CA125. It has been there for a long time, and it is not still.
Yeah, because RNA markers and DNA markers are there, and they are non-invasive and they are quite accurate for the diagnosis.
MicroRNAs in germ cell tumors are really upcoming.
Can I ask a doubt? This elevated CA125 usually causes a diagnostic dilemma, especially in young patients like newly married, unmarried ones without children. They come with bilateral ovarian cyst with thick septae, and sometimes they show some mural nodule kind of thing also. And the radiologist will give an ORADS of 4. And we have some 3-4 patients in which the CA125 was in thousands. One, it was around 3,000. So there is a diagnostic dilemma, especially when you plan for a frozen procedure also. Whether we should plan for a cystectomy and frozen and proceed, or an oophorectomy. So does any of these other markers like HE4 and all help in like sorting it out?
The advantage for is it's quite complementary to a CA125. HE4 is not elevated in the physiologically it is not elevated. It is not elevated in benign conditions. So if you have CA125 is high and you are suspecting it to be benign, you can look into HE4. So if HE4 gives us a normal value, you have to look at other parameters as well. The imaging findings, the symptom findings. So alone, that is why I showed you one study which had looked into these markers on alone and combined with it. They looked into CA125, HE4, they looked into Roma, they looked into combining 3 markers, 4 markers. But we could not get the accuracy of the test to what we want for determining or diagnosing an ovarian cancer. So you will have to look into the whole picture as such. And from the, as of now, with what is readily available, other than markers that madam had said, like DNA methylation, cell-free DNA is one method to diagnose an ovarian tumor. It is really effective. And if it comes into practice, definitely yes, it might be a changing practice for us.
justified in doing a cystectomy and frozen? Like might be rupturing and upstaging.
In
Because young
Birad's 4,
patients,
Without
Orat's
rupture.
4 in
Without
thousands.
rupture. The madam is speaking about that. Whatever you do, it should be without rupture.
As a family planning, any role of embryectomy to prevent this ovarian risk? Family planning, we are doing partial or ring application. Then I am thinking whether embryectomy is the more important factor and any role routinely we can employ that to prevent ovarian cancer in the world.
Madam, total salpingectomy would be best, but their
Procedure, I am
procedure, as a
asking.
family planning procedure itself, it is producing some risk reduction, but better reduction would be a total salpingectomy.
So in a patient with family history of ovarian cancer, can we counsel when she is undergoing LSCS with sterilization or PPS, can we counsel her for
No,
that?
this salpingectomy procedure which I mentioned was for those
With
without
genetic-
a genetic history or without a genetic mutation or a family history of ovarian cancer. If there is a strong family history of ovarian cancer, I think she should be evaluated and we
Genetic
should
screening.
suggest risk-reducing salpingo-oophorectomy.
But in OBS, we see a lot of patients where the mother has a history of ovarian cancer with no genetic screening report, and the daughter comes for LSCS or PPS with for sterilization. So then how?
Ma'am, I think we should not offer ideally without evaluating, because it can produce long-term morbidity. A young patient
No,
during cesarean
salpingectomy
we can do, but RRSO we should be careful in a young patient, because
After
unless we do not have real evidence that she is a genetic carrier or that she has a history proven.
No, salpingectomy we can.
Total salpingectomy we
Yeah,
can do.
can I just mention, I think we'll have to follow Government of India guidelines for family planning. So you can't offer it like in Canada, it has become a law that they offer salpingectomy for sterilization of for family planning procedure. But in India, it is still not the law. So you can use it in specific cases when you want to do, but don't write PPS then. You can't write postpartum ligation. You have to write, we did a salpingectomy because she had a family history.
We have to document the counseling and then.
Counseling.
Yeah, also
You're
right,
correct,
because
madam.
I don't think
So
it's a
we
law
have to
yet in
change the
India.
It's not. Only
Madam,
the
once-
modified pomeroid
Yeah,
is the
because then you
accepted
should not
procedure.
get into trouble because it is not a law. In Canada, it is a law.
Madam, we have
but
to
not
change
here,
the law. As a
not to do.
gynecologist, we have to change the law.
We have to change, but then it has to come from the Government of India. We can't make ad hoc changes whenever we feel like.
Counseling is
Or-
required.
yeah.
Counseling is the key here, and proper documentation also about our conversation with the patient and that they have opted for total salpingectomy.
It should not give a false sense of security to the patient, but that just because her tube is out, ovarian cancer will be prevented. So she might fall into that false sense of security, which is, if she has a risk, that risk should be determined and a solution should be offered accordingly. Instead of, opportunistic salpingectomy is an option, but we don't know whether it really prevents.
So actually, we may be reducing risk to some extent, but then she'll have the risk of the general population, like whatever other risk factors they are not removed. So you reduce the risk to a certain extent by removing, because that is the thing.
Yeah,
but
we don't know how
like
much is
the
the risk
risk, yeah.
reduction, yeah.
Even for BRCA and all, when they say BRCA is negative to any woman, for any woman, they say you now have the risk of the general population, risk of developing a cancer.
Yeah, if the family history is also negative. So family history itself confers a certain amount of.
That's my doubt, ma'am. Many patients come where the mother has died of ovarian cancer. We
So
don't
see,
have
there are
any data
ACOG
available.
and gynae oncology group. They have given a set of patients with a certain family history, like this many number of family first degree relatives or second degree relatives, or breast cancer, ovarian cancer, or age at onset. So based on that, you can put these patients into two categories: the patients who have up to a 5 to 10% risk. So these patients will benefit from a genetic testing rather than randomly offering them anything. And there are patients who have a stronger family history. They'll fall into a 20 to 25% risk. They have categorized into two. So those patients should definitely be offered a genetic testing. So it's not very widespread, it's not available, the receptivity is not very good, so we are not able to do it. But just doing a salpingectomy we should not say, we have done, that's not enough, but definitely.
How much is the cost of this genetic testing?
No, but you can't do it in every patient. The
Yes,
index
ma'am,
patient,
yeah.
it has to be done. Then you find a mutation. You can't just offer it to every patient.
Especially I'm from
You
a
have to
government setup.
know
Most
the,
patients will not be affording the genetic test.
Yeah,
also.
it's no genetic test of the mother. Then there is sense. There's no otherwise at random you go get your blood, that and the other. That doesn't have any sense at all.
Thank you so much for that brainstorming session. There's one question from the audience. This is directed to Dr. Sucheta. Ma'am said that in the early part of ovarian cancer, the omentum is protective by being cytotoxic to the cancer cells. Then why do we remove it if for staging in the early stages?
In early stages, so you will get micrometastasis so that the patients will get upstaged and we have to decide upon the adjuvant treatment. Whenever the tumor is confined to ovary, and you have to prove that it is only 1A disease within high-grade serous carcinoma so that the patient can be kept for follow-up. So to find out the micrometastasis in the omentum, which is seen in 0 to 22% and isolated metastasis in 2 to 7%. To identify that part, you have to go for an infracolic omentectomy in early stage. And in those patients who are getting adjuvant treatment, in the sense it is high-grade serous carcinoma, the high-risk histology, anyway, they will receive chemotherapy. In such patients, we can argue that the omentectomy has no survival benefit. So those patients who are not getting adjuvant treatment as per our pre-op and intra-op assessment, they should anyway go for an infracolic omentectomy.
Thank you, ma'am. Now we close the session, and thank you so much to all the chairpersons and the speakers. We will now have a coffee break for about 10 minutes, followed by the inauguration session of KLSC Agoy.
ഒന്ന് ഓർഗനൈസ് ചെയ്തോളൂ, ഇത് കാണിച്ചു കഴിഞ്ഞിട്ട് കയറുന്ന രീതിയിൽ. കുറച്ച് ബുക്ക് കേരള മേലോട്ട് കേരള
വെച്ചിട്ട് വേണം അത് കഴിഞ്ഞിട്ട് വേണം ഇവർ ഇനാഗ്രൽ സെഷനിലോട്ട് ഇരുത്താനായിട്ട്. ഇല്ലെങ്കിൽ പ്രൊജക്ടറിലെ കണ്ണിലോട്ട് പിടിക്കാൻ
We now request all the delegates and faculty to make it back into the hall. We'd like to start the inauguration ceremony of KLSC Agoy. We now request all the delegates and the faculty to come back into the hall. We will now start the inaugural ceremony of KLSC Agoy. I request all the faculty and delegates to return to their seats so that we can start the inaugural ceremony of KLSC Agoy.
Welcome back after the. We now have to start the inaugural session. The inaugural session with a small prayer.
First is Dr. Machita Chitra ma'am. You can move. Call somebody for the prayer. The prayer needs to come, right? The prayer needs to come. End. Comes on the screen. Or you can ask your friend Anupama. The prayer from the MD needs to come, right? The prayer nota parallel. You know the order? ഞങ്ങൾക്ക് ഓർഡർ അറിയില്ല. I think both of you can handle it. Be with me. You be here. We'll tell you the order. നിങ്ങൾ പറഞ്ഞു. പറഞ്ഞു.
Good morning all. Welcome back. Now we'll start with the official inauguration of our Kerala State Chapter of Association of Gynec-Oncologists of India. Our MD, Mr. S.K. Abdullah sir, has obliged to become the president, do the presidential address and officially inaugurate. So, sir, we welcome you to the dais. Kindly, please, on to the dais. Chitra madam, please, along with my sir. Dr. Amita Maheshwari, the madam, AGOI president, kindly join them on the dais. Dr. Rupinta Sekar, Madam, AGOI President-elect, Madam, kindly join them. Dr. P.K. Shegaran, Sir. Dr. U.D. Bafna, Sir, kindly join them on the dais. Dr. Shalini Rajaram, Madam, kindly please join them on the dais. Dr. Gracie Thomas, Madam, kindly join the dignitaries on the dais. Dr. Pavitran, Sir, kindly join the dignitaries on the dais. And Dr. Elizabeth Wallikad, Madam, will join us soon. Rema, Madam, our AGOI Kerala State Chapter, kindly join the dignitaries on the dais.
Thank you all. We'll start the session with a prayer song. Thank you. I would like to now invite the founder president of KLC AGOI, Dr. Chitra Tara, to give the welcome address.
Good morning to one and all. I'm profoundly honored to have this opportunity to do the welcome address on this auspicious occasion of the inauguration of Kerala chapter of Association of Gynae-Oncologists of India. Advocate Abdullah Sir, Honorable MD of Lakeshore Hospital, has kindly consented to preside over this function. Over the years, he has become the central pillar of the hospital. By hearing central pillar, you should not think that he is static. He is a very dynamic person with a clear vision. Every nook and corner of the hospital knows him instead of telling vice versa. He is fondly called as or known as charismatic leader. On my behalf and on behalf of KLC AGOI, I cordially welcome you, sir, to the function. On seeing all the stalwarts in the field of gynecology here, I remember one slogan from Bhagavad Gita. Anyeja Bhavashura Madarte Tekta Jividaha Nana Shastra Praharanaha Sarve Yuttha Visharadaha O Sarva Eva Maharadaha. That means Madarte Tekta Jividaha. They are ready to sacrifice their life. For what? All of them lived, living, and will live for the cause of gynecology in India. They are primary care physicians of gynecology. In addition to that, they are skilled surgeons, good administrators, and committed leaders, committed teachers. Kerala State Chapter is registered as the 8th chapter of AGOI. The inauguration of this KLSC AGOI is a long-awaited one. And this will pave the way for collaborative work and academic and research platform for younger talents. For this inauguration, we have here the benevolent president of Association of Gynecologists of India, Dr. Amita Maheshwari. She is a legend in this field, and she is from the Pioneer Cancer Institute of India, the Tata Memorial Hospital. She is an ardent orator, and with her charming personality, she could conquer the minds of oncologists nationally and internationally. Hearty welcome to you, Dr. Amita. Dr. Rupinder Shekhon is a renowned gynae-oncologist and a robotic surgeon. She spent her initial years in Indian Air Force. Nobody can question her valor. She can vanquish enemies not by her by the weapons, but by her wisdom and knowledge. She is the president-elect of AGOI, and I take this opportunity to wholeheartedly welcome her. Good book is equal to hundreds of friends, but one friend is equal to a library. This is Dr. Shalini Rajaram to any person who knows her. She is an eminent scholar and an academician, and her passion in gynecology could fetch her position among the top. She is the immediate past president of AGOI. An affable welcome to you, Dr. Shalini. Dr. Elizabeth Olligad she has come, and she is a woman of great determination and strength. She doesn't like all these things, I know, but she is, of course, she is an iron-willed lady, and she is played the key role in establishing gynecology in Karnataka and thus South India. I welcome you with great pleasure, Dr. Elizabeth. Dr. Bafna is guru and role model to many young gynecologists working all throughout the world. He is also instrumental in popularizing the specialty. He faces things with optimism and simplicity. I sincerely welcome you, Dr. Bafna, for this function. Dr. Shekharan is former professor and HOD of Government Medical College, Calicut, and he is one of the most adorable teachers. He shot into international fame by his contribution in the field of gestational trophoblastic disease. Sir, along with his wife, Madam Radha Devi, is participating in this function. Welcome you both. Dr. Gracie Thomas is president of Cochin Obstetrics and Gynecology Society, and she is the founder president also. Her leadership has made the society one of the best societies under the Federation of Obstetrics and Gynecology of India, and bagged several medals. With immense pleasure, I welcome you, Dr. Dr. Pavitran is the president of Cochin Oncology Group. Dr. Pavitran is a prominent medical oncologist and attached to Amrita Institute of Medical Sciences. He is a noble person, always with a smile. I extend a warm welcome to you, Dr. Pavitran. And Dr. Rema is secretary of KLSC AGOI, entrusted with the vote of thanks. She is currently HOD and professor of Gynae-Oncology, RCC Trivandrum, the premier cancer institute in Kerala. She is known as RCC's Queen of Pelvis. Welcome you, Doctor. I welcome the organizing committee members, especially Dr. Sanam, Dr. Anupama, and the respected scientific chair, Dr. Sujeta, who all of them worked day and night for the best outcome of the program. I extend a red carpet welcome to all the delegates. Their willingness to enthusiasm to participate in the CME as well as the inauguration played the key role in the success of the program. I wholeheartedly welcome distinguished guests, invited faculties and chairpersons. Especially I have to welcome few, Dr. Sean is from Chodi Hadanak, and he is here for the inauguration. I think I have to tell each and every person it will be difficult. Dr. Agnes, Dr. Usha, so many distinguished faculties are here. I welcome all the supporting department and persons also, and once more I welcome each and everyone to this inaugural function and the CMA.
Thank you, ma'am, for the very delightful words of welcoming each and every delegate over here. And now I would like to invite the Managing Director of VPS Lakeshore Hospital, S.K. Abdullah sir, for the presidential address.
Very good morning. I mean, you might have got all the information about the dignitaries sitting on the dais. And if I again describe them with my presidential address and address them in those words, it will take another 10-15 minutes. And you have got so many scientific sessions to follow after this one. Anyway, I'm very happy to welcome all delegates and faculties outside Kerala to this God's own country, and those delegates and faculties from Kerala to this beautiful VPS Lakeshore Hospital auditorium. We are always, thank you, we are always delighted and thrilled to conduct this type of academic sessions, one after another for the last 3-4 months. We have got many CME sessions and workshops in this hospital, Kerala level, national level, and even international level. Today, this is the function to declare the inauguration of the EGOI chapter, Kerala chapter. So, Dr. Chitradhara, who is the backbone for this institution and this organization. Let me congratulate Dr. Chitradhara for this wonderful achievement. Of course, again, as she only admitted, it cannot be possible without the support from the national level and other faculties level. So on her behalf, as my colleague here, on her behalf, let me congratulate and let me thank all the faculties and the presidential, executive committee members of the national level. I don't want to extend or prolong my speech. I'm very happy to be here with you and to enjoy the session and this inaugural function. Let me close my presidential address with all the best for you, all the faculties and the delegates. Thank you very much.
Next, we have the inaugural ceremony with the lighting of the lamp. We request all the dignitaries on stage to come ahead for the lighting of the lamp.
ceremony has been officially inaugurated. We have one more event, and that is the release of our logo. It will be shown on screen. I invite Rupinder ma'am for the release of the logo. If we can just have the yeah, thank you. Logo release, ma'am. Yeah. We'll now have the logo released by Dr. Rupinder Shekhar. You want to say it once more, ma'am? Thank you, ma'am. Can I request the dignitaries to kindly be seated? I would like to now invite Professor Shekharan sir. Sorry. We now proceed with the inaugural address by Dr. Amita Maheshwari, the President of AGOI.
So, thank you. Dignitaries on the dais, off the dais, and friends, it is indeed a great honor to stand here on behalf of our association, the Association of Gynec-Oncologists of India, on the occasion of inaugural meeting of Kerala State Chapter of Association of Gynec-Oncologists of India. And on behalf of all of us, Dr. Rupinder, Dr. Shalini, and the entire AGOI, I would like to congratulate Dr. Chitrithara, Dr. Rema, and the entire executive committee and membership of Kerala State Chapter of AGOI for this much awaited initiative. So a big round of applause for the team. So I'll just give a little brief on AGOI. It was established or started way back in 1991 by a handful of like-minded people. And in last 3 decades, AGOI actually has really grown in leaps and bounds to its current strength of 1,614 members, life members, and 9 state chapters. So that shows how our association has progressed. And this, I think, is also an indirect reflection of the recognition and establishment of the subspecialty of gynec-oncology in the country. So because of, we have a dedicated branch of gynec-oncology, people are interested, and that's how we are seeing more and more members are joining. In fact, the first MCH gynec-oncology was started in 2011 at Tata Memorial Hospital with one single candidate. And for many years, we actually had only one seat. But today we have 11 centers, more than 24, I think 24 seats across the country, which shows again everybody is recognized the need for a specialist gynec oncologist. And in 2019, National Board of Examination further strengthened this course by starting DRNB course. And again, we have 11 centers and I think 16 seats per year. So I think future of gynec oncology is very bright, and we are seeing more and more patients are treated by a specialist gynec oncologist, and that's so very important for the outcome of these patients, because we know that patients treated by specialists have the best outcome. So in the interest of our patients, it's so important that youngsters who are interested in gynec oncology seriously consider joining one of these courses. AGOI also offers a fellowship course for 1 to 2 years, and it's, which was started in 2014. It was Lakeshore under the mentorship of Dr. Chitratara, was one of the centers who took up this and is still continuing. So thank you so much, Chitra, for showing great faith in association. And I know Sukanya is currently a student. Yesterday she said that she couldn't, for whatever reason, clear the NEET exam, but she is so passionate about gynec oncology. She came all the way from Chennai to this place to register as a AGOI fellow. So that shows passion and interest youngsters are showing in the field. So this initiation of a chapter in Kerala state, I think it's going to further strengthen both service, education, and research activities in the field of gynec oncology. And on behalf of AGOI, I promise whatever help and support is required is always available. So thank you so much for starting this chapter. Thank you, and wish you all the best.
I would like now to invite Dr. P.K. Shekharan sir for the felicitation.
Dr. Chitratara, the founder president of the state branch of AGOI, Dr. Amita Maheshwari, the state president of AGOI, Dr. Shekon, the president-elect, Dr. Shalini, who was the past president of AGOI, our chief guest, the managing director of Lakeshore Hospital, my respected colleagues, Dr. Elizabeth, whom I am seeing for after about a gap of 5 years, fighting fit. At the same time, she will be always complain that I am old, but she looks all right. And my dear colleagues and friends, we must congratulate and thank Dr. Chitratara for her sincere effort to start this chapter. We were all hoping to have this chapter because we wanted to have the national. I think the national leaders should see that if it is given to us, the national conference, we are ready to do it under the leadership of Dr. Chitratara. And we are confident to host you and the conference with the beautiful facilities in Cochin area or any other part of India, Kerala. We are ready to do it. And so we are bringing up. We haven't done it so far, so hopefully the leaders and the members of the Central Executive will give us a chance to show our solidarity with the National Association as well as our capability of doing it in our own way, the Kerala chapter. So I wish all the best for the venture, and I am sure that we'll do well in the Kerala chapter and the functions of the, it started with the bang. The Ovarian Cancer Conference and inauguration. That shows the enthusiasm. And I remember the days which we were struggling at that time. There was no oncologist or onco surgeons or gynae oncologists, and we were doing everything. And we will not touch upon those patients. If any such patient comes, we are now confident that it can be given to the specialist, and it has to be so. We should not touch such patients, I am very sure. But at that time, there was none. So I wish all the best for the state chapter, and hope that the AGOI will help us to come up, and also promise you that we will be able to do the national also. Thank you very much. Thank you.
Thank you, sir. Can I now invite Dr. Rupinder Shekhan to give a few words? Ma'am, please.
Mr. Abdullah, the Managing Director of Lakeshore Hospital, Amata, Shalini, Bhavna, Elizabeth, Chitratara, and so many other good friends. I'm so happy to be here. A very, very hearty congratulations on the inauguration of the Kerala State Chapter. We have so many stalwarts sitting here who have been doing so well in all our conferences, and I do hope you get the bid for the next conference. Thank you so much for having me here, and congratulations once again. Thank you.
Thank you so much, ma'am. We certainly look forward to seeing you all next year. I would like now to invite Dr. Bhavna, sir, for the...
No, I would just like to say best of wishes to Dr. Chitratara. I'm sure she is a very dynamic person. I've been coming here for DNB and fellowship examination. I think I've come here 2 times or 3 times here, and I've seen this entire hospital, Dr. Abdullah's hospital, very nice hospital, very busy hospital. In spite of being a private hospital, it's a very, very busy hospital. And Chitratara has been doing excellent work. I'm sure that she will take gynec oncology much forward in Kerala state. All the best.
Thank you, sir. We certainly are guided by ma'am, and she has been a real helpful hand to all of us. Now I'd like to invite Shalini ma'am for a few words, please. Shalini ma'am is the past president of AGOI.
Yeah, I think after so many stalwarts have spoken, it'll be a repetition of everything. But yes, Dr. Abdullah, the hospital is beautiful. And I congratulate Dr. Chitratara, Dr. Emma, and the entire team, EC team, for starting the Kerala chapter of gynae oncology. And I think Kerala was already a little forward compared to the rest of the states in terms of oncology. They were definitely leaders. But now I think gynae oncology has taken off, and we'll be seeing better and better work in gynae oncology. As per the presentations this morning by the youngsters also, there has been a vast difference in what we saw maybe a decade back and what we're seeing now. And patient care has definitely improved, survivals have improved, and wishing the Kerala State Chapter a grand success. And we do hope to come back next year for the national conference. Thank you.
Thank you, ma'am. Can I invite Dr. Elizabeth Bollicard, ma'am, to say a few words?
You know, over 41 years, I systematically avoided getting onto this position of having to do this. And I've systematically avoided getting into all these kind of things where you judge competitions. And where is Chitratara? She made me do it this time. I don't know how she caught me. I have dodged it very successfully, but this time she has. So I congratulate all my colleagues on the dais and on the floor to take this step forward. I'm not sure whether you all are going to like me after my talk today, but let's see. Okay then, best of luck.
Thank you, ma'am. Ma'am, we love you actually. Can I now invite Dr. Gracie Thomas, the president of Cochin Obstetric and Gynec Society, to give a few words?
Dignitaries on the dais, off the dais, and my dear friends. I'm very happy and privileged to be part of today's function. Dr. Chitratara is a long friend of mine. She is a very hardworking and proud member of Cochin Gynec Society.
She has held many good positions in our society. She has started Chitradara Award for Best Oncology Paper in our annual CME of Cochin Gynae Society. And like this, she has done so much work for our society. And I was also working with her for some time just to know the realities, or just to get to know something about the gynec patients, gynec onco patients. That time I came to know she was a very strict teacher. She used to shout at me and angry with me. Even though I am a senior person to her, she used to forget that. But anyway, I appreciated all that. That time what I found in her was the best. She was a best surgeon with the healing hands. And today I have seen her logo, healing hands and helping hands. That is Chitradara. She has both healing hands and helping hands. She is ready to help anyone, any of the patients. I have seen her so many, helping so many patients, poor patients, even to get them married, she is ready with the sari or whatever she wants to give to the patients. So she is always ready to help. And today I am also happy to share with the stage with Dr. Vallikad. I don't know whether you will remember me. She is 1 year senior to me in St. John's Medical College. I don't know whether you remember me. Yes, we studied together in the same college for 5 or 6 years. And of course, I was a hostelite and she was a day scholar. That time, and even now I think, she was the most beautiful lady in St. John's Medical College. And being a Malayali, you know, St. John's Medical College, the students are all from different parts of India and abroad, and very few Malayalis there. And she was born and brought up in Bangalore, but she is a Malayali. So that way we were very fond of her, always looking at her beauty, you know, most of the boys especially. And so today I'm so happy to see her after so many years. I think I met her in 1970. You remember? You can calculate the number of years of friendship. Anyway, she was a very good student. She made she became a specialist in oncology and in Kidwai Hospital in Bangalore. She was a very famous and proud student of St. John's Medical College. So I am happy to see her again. Of course, I wish Dr. Chitradara all the best, because I know the amount of work she has done for last so many years. You know, she was consulting with me also because I founded the Cochin Society, and I used to share with her all the difficulties of starting a society. And she was working for so many years to start this society of oncology, gynec oncology, and today it has come to reality. I am really proud of you, Chitra, and I wish you all the best. Thank you very much.
Thank you, Dr. Grace. It was a delightful talk, actually, bringing us down. And Elizabeth, ma'am, you certainly are beautiful. I would like to now call on Pavitran, Dr. Pavitran, the Cochin Oncology Group President, to give the few words.
I'm very happy and proud to be here on the occasion of this formation of Kerala State Chapter of Agoi. And my congratulations to the visionary leadership of Dr. Chitradara and Emma and other members for starting this Kerala chapter. And usually all the associations do educational work, but I request our team to concentrate more on collaborative research also, because that is a way we can move forward, and this will help because the pattern of gynecological cancers that we see here are changing, like decrease in cervical cancer and increase in endometrial cancer over the last few decades. So this way it will help to generate data and improve the patient outcome, and also a leadership for the country to move ahead. Thank you.
Thank you, sir. And as you rightly said, research is the way forward. Can I invite Dr. Rema, Secretary of our Kerala State Chapter Agoy, to give the vote of thanks?
Our respected dignitaries on and off the dais, it's my honor and privilege to render the vote of thanks in this auspicious occasion. This is really a dream come true. This has been due for many years, as Amita madam said, but finally we could do it. Because it's long time that we did it, because the state is, the cancer is like a pandemic in our state. Gynecological cancers are on the rise. Incidence of ovarian cancer is highest in the country. Endometrial cancer, it is more than doubled in the last few decades. And we have the target of eliminating cervical cancer. We should be the first in the country for that. It's a competition, madam. And so keeping that, we started all the training programs way back in 2011, and now we have MCH programs along with the fellowship programs. We have 4 MCH seats and 2 DNB seats in the state. So with all this work power, we requested the office bearers of Agoy, and with great support from Amita madam and Dr. Bhagilakshmi madam, she couldn't make it, but with all support from them, we could materialize this dream of having a Kerala chapter. And I wholeheartedly thank on behalf of all of us, the Agoy office bearers, for all the support we received. And today it's my duty to thank the Managing Director, VPS Lakeshore, Abdullah sir, for helping us host this event and for gracing us with his presence. And I must thank the icons of oncology here, Amita Maheshwari madam, Dr. Rupinda Shekhan, Dr. Bafna, Dr. P.K. Shekharan, Dr. Vallikad madam, Dr. Shalini Rajaram. Your presence here is such an inspiration for us. My words can't express the thanks for all of you coming here for this, and all the efforts you have taken to travel all the way to our state, which is partly submerged in rain. And your inspiring words today, all the support that we need and we are getting from you, and your presence and in the coming academics also, all your talks are all, your presence here is an inspiration for all of us, and all the young generation are looking forward to you. I must also thank Dr. Gracie Thomas madam, Dr. Pavitran sir, for gracing us with their presence in this occasion. And most importantly, Chitra madam, she is our inspiration. She is a mentor for all of us, including me. All of us guided and mentored by madam, and all the efforts that she's taken in for getting this chapter, and hopefully the next AgoyCon. We look forward for that. And I must thank the entire team of Lakeshore and RCC who are working for this event. How beautifully they have done it. Thank you, all of you. So I hope and pray that the Kerala Association will go ahead and, and all the supporting staff who are doing the work for us. Thank you so much. And I hope and pray the Kerala Association will go and flourish and befit our patients with all the healing that we intend to do. Thank you so much.
Thank you all for being here with us today. We're winding up the session. And we'll now have the national anthem. I request all of us to kindly stand.
Janagana mana adhinayak jaya he Bharat bhagya vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Okay. Yeah. Yeah. After the inaugural session, we are going on to the session 2. We welcome onto the dais chairpersons Dr. Agnes Matthew, Dr. Serena Gilvas, and Dr. Tony Augustin. Dr. Agnes Matthew is an MBBS and MD from Christian Medical College, Ludhiana, Punjab. She is currently consultant OG at MCSH Muvatupara and former professor, head of the department and dean. Madam has got 3 fellowships, published articles in several journals. She is a charter president of Malanadu ONG Society and an active member of all societies. Dr. Serena Gilvas is professor and HOD of the Department of OBG, Jubilee Mission Medical College Hospital. Her fields of interest include high-risk obstetrics and gynecology, plastic work in gynae-oncology, laparoscopic surgery, and she's an ardent teacher. She has several achievements, several awards, and presented and published several papers nationally and within Kerala. Dr. Tony Augustin is MS OBG DNB FMAS, Fellowship in Gynae-Oncology, AGOI, and Doctor is currently Assistant Professor, Department of OBG, MES College, Perinthalmanna. We now invite Professor Amita Maheshwari Madam, Professor and Head, Division of Gynae-Oncology, Tata Memorial Center, Mumbai. Madam, as we know, is the President, AGOI. She has authored 20 book chapters and published in more than 120 scientific journals. She is the Principal Editor, Journal of Gynae-Oncology, India, Principal Investigator for many ongoing research trials, RCT and otherwise. She has delivered several orations and many guest lectures, member of palliative care work groups, education committees, co-editor of several books. Madam's primary area of interest is gynae-oncology surgeries, including surgeries for advanced ovarian cancer, robotic surgery, and oncofertility. On to you, Madam.
So thank you very much for kind words and a very good morning to all of you. So at the outset, I would like to thank scientific committee for selecting such an interesting and contemporary and controversial topic, MIS in malignant ovarian tumors. There's some problem with the connection on. And also sincere thanks to Dr. Chitra for inviting me and wonderful hospitality. Thank you. So ovarian cancer is the 3rd most common cancer in Indian women after breast and cervical cancer. And unfortunately, the incidence is on rise, as we know that majority women present with advanced stage disease. And the standard surgical approach is laparotomy, the open approach. However, with the advancement in minimal access surgery, both robotic as well as laparoscopy, and more people getting trained in advanced minimal invasive surgical procedures, ovarian cancer has also been explored by these people. And there are some reports suggesting the role of MIS in early stage as well as in advanced ovarian cancer, both for the purpose of diagnosis, operability, as well as interval debulking surgery after neoadjuvant chemotherapy. as well in a recurrent setting, both to assess operability as well as to do secondary cytoreductive surgery and of course risk reducing surgery, which we already learned in the morning. So advantages of MIS in oncology essentially are same what we see in benign cases, essentially early recovery, shorter stay and better short-term quality of life. But when we talk about cancer, what is the most important endpoint in cancer is survival of the patients. And there are some concerns when we talk about minimal invasive surgery in ovarian cancer patients. So what are these concerns? There is risk of port site metastasis, although reported incidents are low, less than 1%, but we have seen many. There are reports suggesting that use of carbon dioxide pneumoperitoneum may accelerate spread of malignant cells. There is, ovarian cancer essentially it spreads through peritoneal surfaces. There is limited ability to have tactile feedback during MIS surgery. There is limited visualization certain areas which we would routinely explore in cases of ovarian cancer surgeries, like undersurface of diaphragm, behind the liver, lesser omentum, and all of these are very difficult to access at laparoscopy or robotic. As a result, surgeries are often inadequate. What we have to remember, ovarian cancer surgeries are not just limited to pelvis. The equal amount of surgical work done in upper abdomen and in retroperitoneum. And MIS has many, many limitations in that area. And of course, there is a risk of intraperitoneal tumor spillage and upstaging of the disease. So if you have large masses, which we often see in ovarian cancer, it's impossible to remove them intact. The way to remove them at MIS, either to aspirate, morcellate, do piecemeal debulking, or eventually deliver through a small incision. So whatever these procedures you may undertake, they are going to give rise to rupture of tumor capsule. Early stage disease will become upstage to at least stage 1C1 as a result of rupture. And also there are many studies suggesting that outcome of these patients where tumor rupture has happened intraoperatively, it is compromised and it is inferior to patients where we are able to remove tumors without rupture. So as I said, oncology is the survival hardest endpoint, better quality of life, early quality of life, that's not really the main goal. So we do see, because I think many general gynecologists are getting training in advanced laparoscopic surgery, we do see a lot of patients coming with inadvertent laparoscopic surgeries. In fact, the number has increased. We see nearly 4 to 5 new cases every week. And some of them, they come with their videos, and I'll show a short video which I have taken consent from patient. These videos have been great learning for us as a clinician. First you learn what to do, and second phase of life is what not to do. So these videos are essentially learning for all of us to remember what we should not do. A young lady, a large mass, this was laparoscopy diagnostic initially. There was some fluid, a large mass, but this is what we must never do, rupture the mass. So because mass was so huge, it wasn't possible to even assess it completely, so multiple openings were made, and there was some issues with fertility, so some partial cystectomy type of thing was done. The remaining ovarian parenchyma was reconstructed. At the end, mass was put in an endo bag with great difficulty after chopping it in the peritoneal cavity. So what is important when we get these reports, it will be controlled aspiration, removal of mass in endo bag, but when we see these videos, we realize what was done. This is another young lady, fertility was a concern, so complex adnexal mass on pre-operative imaging. So some fertility preserving procedure was attempted, but look, you place the entire tumor in the peritoneal cavity. Later putting it in an endo bag really doesn't serve the purpose. You have already spilled it all over. And you'll also appreciate that these are very subtle cases. There are no overt signs of malignancy in these patients. So these are very early stage disease, young ladies, where fertility was actually a concern. Now here someone thought of putting it in an endo bag up front, but that it doesn't work. I think cancer doesn't follow our orders. So you'll see, although it was put, but already there was some spillage, some tissue was dropped in the peritoneal cavity. This is another patient who had completed family. And these are just, I'm showing few representative videos, but we have many, many of them. So adenexectomy was done instead of cystectomy. But again, because mass was very big, it wasn't possible to remove it intact. So again, it was opened in the peritoneal cavity, tumor was removed, sucked, and spilled all over. This is another small video clipping of a patient who had adnexal mass which was stuck in pouch of Douglas. There were some adhesions. So again, the same thing, however thorough lavage wash we give at the end, it's not really going to compensate what we do during surgery. So the other big no-no is morcellation of adnexal masses. So this was a young unmarried girl who had a large ovarian mass, largely cystic with some solid areas. On preoperative imaging, tumor markers were normal. We discussed in the morning limitations of tumor markers. So first cystectomy was attempted, but later, looking inside the cavity, the surgeon thought of doing salpingo-oophorectomy. But after doing salpingo-oophorectomy, look, what was done was morcellation. So, it's nail and hammer kind of story. If you have a morcellator, doesn't mean morcellate every tumor. So this ovarian mass was morcellated. And I don't know how, it's very hard for pathologists also to give any opinion on these kind of masses when they are morcellated and sent to them in bits and pieces. So at the end, of course, everything was sucked out, but whatever cells you can not remove each and every cell what you have spilled during surgery. So the thing is, how do we then manage? I can't say that laparoscopy has no role in the management of adnexal masses, but what precautions we should take and where to draw that line. So what is very important to have a detailed pre-operative evaluation. I see gynecologists or surgeons are generally in hurry to place or to put the patient for surgery. Please don't do a proper thorough evaluation. No limitations of imaging as well as tumor marker. Best of pre-operative assessment can give you the benign versus malignant to the tune of 85%, not more than that. So in 15% you may go wrong, and there what is important, intraoperative assessment and a pre-operative counseling and taking consent that if it turns out to be malignant during surgery, if we feel any feature of malignancy, we may convert to open surgery. These masses should be assessed carefully during surgery and should be removed intact in an endo bag without morcellation and puncturing. We have to really realize that any puncture or any spillage, it adversely affects the patient's outcome. So it's not that if you have done morcellation, outcome will be the same. You can give chemotherapy. No, it doesn't work that way. Ideally, frozen section facilities should be available so that a complete surgical plan, surgery can be executed then and there. So I have another video. This is again done by a very famous gynecologist in Mumbai. It's a doctor patient, in fact, young lady, complex mass. So what I think may be an ideal laparoscopic procedure for a suspicious or early stage disease. So first, collect the cytology, be away from the tumor, do not manipulate it. IP was taken away, and there is hardly any manipulation of the adnexal mass. It is removed intact, detached completely without manipulation, and that's how it should be put in an endo bag, not after morcellation and puncturing. And removed it through a small incision, or if your hysterectomy is planned, then from the vagina. So what is the literature? What does literature suggest? So there are very limited studies available on the role of MIS in early stage ovarian cancer. Most are small series or retrospective review in highly selected patients where they may say that outcome is same as with open surgery, but we have to really read these reports and see how the patients were selected. This is a very recent review published in June 2023. So when we talk about early stage ovarian cancer, I think literature is very limited on the safety of MIS in early stage ovarian cancer. There is a systematic review by Cochrane group which said that there is not enough evidence, and if we want to do, it has to be by a very trained minimally invasive surgeon who can follow all principles of oncology. Then only MIS should be implemented in the management of early stage tumor. Coming to advanced stage disease, I think one definite indication of MIS is as a diagnostic procedure in advanced cases where we are not sure whether upfront surgery should be offered or we should give chemotherapy. There, I think MIS has some role in giving an idea about the extent of disease and operability. It can be either subjective or we have more objective ways like Fagotte scores. The other area which MIS surgeons are exploring is doing interval debulking surgery after neoadjuvant chemotherapy in patients with advanced stage therapy. This is from Tamil Nadu actually. So okay, how very innovative marketing strategy. Okay, so again there have been small retrospective series and studies, case series, and this is a systematic review and meta-analysis of MIS to laparotomy in neoadjuvant interval debulking setting. Most studies showed that there is equivalence between MIS and open surgery, but what we also have to see the quality of these studies. Most of them are retrospective, highly selected patients, and there are many limitations of these studies. So what are major concerns, and those of you do surgery for advanced stage ovarian cancer, even in after neoadjuvant chemotherapy, will realize that we do see lot of peritoneal disease in the upper abdomen, under surface of diaphragm, lesser sac, all of those areas. So there is genuine concern that MIS, we will usually underestimate the disease and will leave some disease inside. So we do need further studies before we can really implement MIS in this setting. And currently, the laparoscopic cytoreductive surgery after neoadjuvant chemotherapy trial, LANCE trial, which is a phase 3 randomized non-inferiority trial, which is comparing MIS to open surgery in patients with advanced stage disease who had either complete or partial response to neoadjuvant chemotherapy and normalization of CA-125 levels. So this is in a very selected group of patients under trial setting. Unless we get results from this trial, I would say the role of MIS is experimental. Of course, this is one area where MIS can be used in risk-reducing surgeries. But there also we have to be careful not to remove ovarian masses intact, because there have been cases of occult disease in these ovaries. So we have actually patients where ovaries were not removed properly and patients had disseminated disease later. So whenever we are doing for risk reducing, please put in endo bag or remove through vagina if hysterectomy is also planned. So to summarize the role of MIS in ovarian cancer, according to me, open surgery in the form of laparotomy, it continues to be the standard approach in the management of epithelial ovarian cancer. MIS may be offered by an experienced MIS surgeon in highly selected patients. However, patient must be informed that there is limited data about the prognosis and oncological safety of MIS in this group of patients. Diagnostic laparoscopy, yes, that can be used. Role of MIS at interval debulking surgery is under investigation and it's experimental at this point. It can be used for risk reducing surgeries. So what is also important, I think, to highlight that because early ovarian cancer doesn't come as cancer, they will go to generalist as complex adnexal masses, and whenever we are dealing with complex masses, please do keep the possibility of cancer. And anything which doesn't fulfill the benign criteria, please think of the possibility of cancer. And morning we learned about the limitations of imaging, limitation of tumor markers in early stage ovarian cancer as a diagnostic test. So normal tumor markers, imaging not showing overt features doesn't mean that mass cannot be malignant. So with this, thank you very much.
Thank you, madam, for that very important topic. Several take-home messages for the audience on what not to do in minimally invasive surgeries. We will have questions towards the end. Next, we invite Dr. Rupinder Sekon for the topic, MIS complications, tackling the worst. Dr. Rupinder Sekon is formerly educated in PGIMR, FICOG. She's got diploma in laparoscopy and hysteroscopy from Germany. Madam has completed fellowship in gynae oncology from Kidwai and memorial.
Yeah, thanks a lot. Can you just have the presentation? Okay, so good morning, everyone. And once again, it's my proud privilege to be here. And a very big thank you to Chitratara, the Lakeshore Hospital, and the Kerala State Chapter for having me here. I just plan to show you a few videos. Dr. Amita's talk was absolutely very lucid as to what are the pitfalls of doing MIS in ovarian cancer. But I have just to show you some videos telling us about the pitfalls of doing MIS at all. So this is a 10-year report card of robotic gynae surgery, where the increase in injuries reported was 455, 177 malfunctions, 30 deaths, approximately 50 lawsuits, which are so important, and of course a very high cost to the patients as well as to the hospital. So when we talk about robotic assisted surgery, serious events reported complications in 2005 through March 2014. As reported to the Pennsylvania Patient Safety Authority, we find that you can have complications as small as a retained foreign body, which is up to 4%, to an unintended laceration or puncture, which is actually the most serious, which can be as much as 43.5%. Of course, other things like bleeding, hemorrhage, infection, so on and so forth are common to most other things. Now, complications in robotic gynecologic surgery, they occur in 0.1 to 10% of all cases. The risk factors, of course, being prior abdominal surgery, endometriosis, pelvic infection, bowel distension, large pelvic masses, adhesions, cardiopulmonary disease, diaphragmatic hernia, so on and so forth. So these are actually, though it is labeled as robotic, but it's common to laparoscopy as well. So in my presentation, I'll show you complications related to both laparoscopic surgery as well as robotic surgery. So to start with, we have trocar entry complications. The overall complication rate of gynecologic laparoscopic surgery is 0.6%, with the mortality rate estimated at 1 per 30,000 patients. Direct trocar entry and open Hassan techniques seem to be associated with less complications. Initial gas pressure of less than 10 millimeters of mercury is the most effective test to verify intraperitoneal placement of Verey's needle. Please do not try to put in needles and trocars if the gas pressure is less than 10 mm. There is no advantage in favor of any particular entry techniques to avoid complication. If you're not trained enough, you do not have enough experience, you can complicate anything at all. See, as you can see in this video, entering the trocar from the epigastrium, it's like you've gone straight into the liver. And then, of course, we're trying to sort it out, trying to see how much is the bleed. If it is a small bleed, you can generally just let it be. You can just put some gauze there, you can just put some fibula there or something. But many times you would require to seal this with a bipolar. And rarely you might even require to open this patient, because a liver bleed can be something very serious. So this is through laparoscopy. Next we have bladder injuries. The probability of bladder injury is about 0.2% to 20% in laparoscopic gynecological surgeries. Most common site of injury is the posterior surface of the bladder. So always remember to put in a catheter there. So see, while you're separating the bladder from the hypogastric ligament, you think that's a very safe place, so you just carry on regardless. You're trying to push the bladder down, separating it off from there, and then let's see just what happens. So as you're confidently proceeding ahead, trying to excise the hypogastric ligament, which actually gives you a very good access to the obturator fossa. There you are. You have gone right into the bladder. So once this has happened, it's quite okay to trying to make sure that it is indeed a bladder injury. Try to separate out the edges and look inside to spot your follies and the bulb. There you are, you can see them. And then, if you are a beginner, it's better to open and repair this injury. If not, and if you have expert health at hand, then you can easily stitch up the bladder with either a PDS 30. So this one is going a little further than that. And actually handling the follies, you need not do that. So what is the lesson learnt? Don't go from above below, but from below above, so that you separate out the sigmoid and separate out the fat related to it from the hypogastric, and then try to repair the bladder. So I'm almost 19 minutes gone, I'll just proceed. So then it is easy enough to stitch up the bladder. You can do it in 2 layers. And whether you're doing robotic surgery or laparoscopic surgery, accordingly you can stitch it in 1 layer and then bury that layer and carry on. Of course, you would need to leave the catheter in for at least 14 days. Some people want to put it there for 21 days. Next are trocar site hernia. Incidence of trocar site bowel herniation is 0.02%. The use of trocars larger than 10 mm at extraumbilical site increases the risk, and facial closure is recommended. Symptoms include the presence of a bulge that may be painful, nausea, vomiting, and abdominal distension. So even if you get the momentum through this and not necessarily the bowel, you can still have these kind of symptoms. Treatment is of course surgical correction of the defect. Ureteric injuries incidence varies from 0.4 to 2.5%, as reported in different studies for benign conditions, but can be as high as 30% for malignancies. About 75% of ureteric injuries occur during abdominal gynecological procedures, with incidence of 0.5 to 1% for abdominal hysterectomy, compared to 0.1% for vaginal hysterectomy. Incidence of ureteral injuries reported in association with robotic hysterectomy is about 0.7%. Types and cause of injury: ligation, crushing, transection, angulation, ischemia, intentional resection during operation for malignancy, so on and so forth. Here, a word of caution: be very sure how you are using your electrical and thermal instruments. Bowel injury: in a study by Van der Voort et al., the overall incidence of bowel injury by minimal invasive techniques is around 0.13 to 0.22%. Small intestine is most commonly injured. Bowel injury is usually repaired primarily. In case of a larger thermal injury, resection and anastomosis of the segment may require to be done. Vascular injury can be 0.04 to 0.5%. Compression is the first line of treatment, and not to panic is actually the first line of treatment. Clamp your vessel. If you can't clamp it, just slap it across the pelvic wall, take a deep breath, and then get your sutures ready, get your blood ready, and then start off trying to repair it minimally invasively. If you can't do that, do not hesitate to open the patient. So after that, increase the pneumoperitoneum to 20 mm of mercury and quickly change to the needle holders. In case of venous injury, this action will stop the bleeding, allowing for repair. Now, I'm all for letting the youngsters get on with docking the robot first of all, but this is what happens when we let one of our youngsters do. So the monopolar went right through in between the external iliac artery and vein. And she called me, ma'am. And so I just sat there and took a deep breath, wondering what to do. Fortunately, I was able to remove that. We looked at that segment which looked slightly, injured, though fortunately the surface was fine. And we observed for some time and let it go. But every time we might not get so lucky. Okay, so then this is a small video which will to showcase all the injuries that we have caused during our robotic surgeries. So this was while we were trying to do lymphadenectomy, and there you see the internal iliac has been injured. So the whole idea is not to panic, and always remember arterial injuries are better than venous ones. So catch hold of the internal iliac artery, get your assistant to take some clips and clip the artery. Now this is when you're trying to separate out your ascending colon from your ileocecal junction, so that you can reach a common iliac node. And I could hear my residents shouting, ma'am, 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 but I had already opened the gut. So then the next step was to see how bad is the injury. Just yes, there you see. You can see the mucosal surface. Now actually the injury is not as much, or rather the defect is not as much as it appears to be, because remember that this is all under magnification. And you can repair this robotically very easily. You can use a 3-0 vicryl or even a 3-0 PDS. Take a continuous suture and this. Now this is where you're trying to separate out the ureter. And instead of separating it out, we've really separated it. We've separated it from the bladder itself. So next thing you do is you repair it. You have to freshen both the edges, spatulate them. You can take a ureteric stent, but you can use a feeding tube as well. So after having spatulated the distal end, freshened it up and putting the feeding tube in there, then you take your proximal end and put the rest of the feeding tube in that. Using 4-0 PDS, 4 sutures, 3 o'clock, 9 o'clock, 6 o'clock, 12 o'clock is generally enough. If you have some momentum lying around, you can put that around that, and you can dissect out the bladder a little more and hitch it to the psoas. That always helps. Next, we were trying to do some aortic lymph node dissection retroperitoneally on the aorta. And as you're enthusiastically trying to remove that, what you think is diseased area, this is what happens. Unrecognized adventitial injury to the aorta. There you are. So again, take a deep breath, just hang on to it, ask for assistance, ask for a 5-0 proline. You would definitely require a certain amount of expertise with the robot to be able to do this kind of a thing. Take a figure of 8 suture, then release it and see if you have you repaired the defect. So hold both the ends of the suture together, release it. No, it's not done as yet. So then take another suture. In all of this, you just have to remain very calm, and subsequently you can develop hypertension, but as of that time, but there you have to be very, very cool. And always ask for blood. Always, always ask for blood. You never know when you just have to quickly open this patient. And from this kind of an injury, there can be a lot of blood loss. Subsequent to that, you can always leave some fibrillar over there, and do not try to catch some very, very small bits and pieces of bleeding that might be there, because many of these small vasa vasuram and all, they close by themselves once the pneumoperitoneum is released. So this is just our experience when I was in Rajiv Gandhi Cancer Hospital for about 19 years, about 512 robotic surgeries, 7 vascular injuries, 5 ureteric injuries, 2 bowel injuries, and 4 cases of trocar site hernia. Thank you very much. I would also like to thank Dr. Subneshwar Rao. He gave me those pictures of the initial pictures for laparoscopic injuries. Thank you so much.
Thank you, madam, for the wonderful session. If you could stay back in the dais, we'll discuss these 2 topics now, because the MIS topics. Amita, madam, could you please be back on the dais? So the topic is open for discussion.
The audience, could we get some feedback or questions? Meanwhile, it was such a wonderful idea to have both of you talk. So is MIS still in or out? So that's what the youngsters want to know.
So I think selection is the key. Okay, that's very important in oncology, especially. And also important that in oncology, the primary endpoint should be patient survival, not cosmesis, not faster recovery. You know, if given a choice whether I want to be in the hospital for 2 extra days versus living for another 2 extra months, obviously I would choose the, later. So that's very important. As long as we are able to follow oncological principles, if at open surgery, if I won't rupture the mass, I shouldn't do that just because I am doing MIS. So if we are able to follow oncological principles, yes, MIS can be used, but in oncology, one has to be very, very careful. And we have the example from cervical cancer. All these years, people without having good evidence, we all started doing MIS for radical hysterectomy. And now we have so much evidence suggesting that the outcome of patients who undergo either robotic or laparoscopic radical hysterectomy, it is much inferior than those who undergo open surgery. So I think one message is oncology is very different as far as surgical principles are concerned than benign, and extremely important to follow and adhere to surgical principles, whichever route you take. So
thank you, Amita.
So just to add to what Amita has said, she said all the important points. Hospital stay and length of incision should not be your deciding factor. It should never be a deciding.
In fact, what we have just point, many of these videos what I showed, what we got, these were young ladies where fertility preservation was otherwise possible. But as a result of inadvertent surgical spillage, we couldn't preserve their fertility. Some of them, in fact, were low-grade tumors or not so chemosensitive. In fact, they kept recurring and we couldn't salvage. So we lost many young girls because of this inadvertent surgery. So all these points we have to really keep in mind.
Also, if I can just answer one query which was there in the previous presentation, that when it comes to endometriosis, there's a high CA125, so what should we do? So to start with, one can always do a diagnostic laparoscopy. Many times that gives you the answer.
And many times you can see these endometriotic spots on the pelvic peritoneum or somewhere else. You can take a small pelvic peritoneum biopsy, send it for frozen. You'll get your diagnosis for certain sure as endometriosis, and you can treat it as endometriosis without actually, doing any invasive surgery and all that.
I think, Dr. Amita, your message is very clear, loud and clear, that I think every case should be properly evaluated preoperatively. And that decision whether you're going in, even if you've got the smallest doubt of malignancy, I will say it is but right to do a laparotomy. Because in that early stage, when you can give us such good results, you will make a mess of it if you go and do an MIS and you'll upstage the disease. So I feel even if you do all the imaging, do all your tumor markers, see that you're completely come to a diagnosis, even if you're in doubt, I think it's better you don't go with the laparoscope, especially for ovarian cancer.
And even if you have decided, always take consent for open surgery.
Yeah,
because
yeah.
many times we
Yes.
actually face problem because we have not counseled the family and patient about the need for open surgery. And then we are, in a dilemma whether to open or... So all of these, I think we have to explain and
Yeah.
also have discussion.
Yeah,
prior
but
to-
what I wanted to ask you was, we as general gynae, what we do, where we do the MIS in ovarian malignancy is normally when we want to give a new adjuvant, I do the FNAC through the pouch of Douglas. Because it's the best side, especially when it is impinging and pushing through the pouch. There is no gut in between, and you can go straight into the mass and you can take the tumor. But when we can't do that, and when it's not accessible from below, then we do a laparoscopic biopsy. I want your take on that.
So before that, just a comment on what Amita has said regarding the consent. When you are taking consent from the patient regarding open surgery, please also take consent regarding hysterectomy. That's very important. And take the consent from the patient, not the patient's relatives, especially for hysterectomy. There was a very long, if you check out on the medical legal books, there was a very long case which went on and on and on. One patient against Dr. Prabha Manchanda in Delhi. So where the patient was educated, everything was all. When she was under anesthesia, it was decided that her hysterectomy has to be done. Her mother gave the consent. And when the patient came out of anesthesia, was recovering, reached home, she put a case against them that how can my mother say that I don't need my uterus? So when you're taking consents, please make sure that the patient signature is also there. I think Amita,
Yeah, very important. In fact, I think a lot of medical legal implications, removal of the uterus until the patient herself consents.
Right. So coming to the point of FNAC or biopsy, if any mass which is upfront operable, let there be ascites, some disease here and there is no need to do a biopsy. We should not do a biopsy just because we want to rule out malignancy so that we can proceed with laparoscopic surgery. Biopsy in ovarian cancer, unlike all other cancers, cervix, endometrium, everywhere we do biopsy before surgery. But ovarian cancer is one where we do not do biopsy or FNAC prior to surgery because there is a real risk of capsular rupture and upstaging of the disease.
No, I'm saying before the neoadjuvant.
So before the neoadjuvant, it doesn't matter. We can take ascitic fluid, we can do ultrasound guided biopsy, it really doesn't matter. At our center, if patient has ascites, we collect ascitic fluid, we make cell blocks out of it. And then otherwise you can do from anywhere. It really doesn't matter if you are planning to give, because disease is already widespread, then only we would give neoadjuvant chemotherapy. Otherwise we don't give neoadjuvant chemotherapy.
Can I say something? The chair, can I say something?
Sure.
Yeah. So you don't need to take it from the ovary. You can take omental biopsies. So there's no need to touch the ovary.
We take even
and
from the
especially
peritoneum.
if it is cystic, the ovary, you don't touch it at all.
Absolutely.
Right? So
It will
you take
rupture
it from the omentum, you take
Yeah,
it
you
from
can
other
take it
nodules
from anywhere, yeah.
rather than from
Yeah, that's what we do normally.
And one more thing about MIS, I think the videos that Dr. Amita showed us, the last video which she showed was very small ovary, which is almost like a risk-reducing salpingo-oophorectomy. So that is okay. But anything, even if you think it's 10 centimeters and you put it into a bag, and when you take it out, you have to morcellate it before you take it out. So the pathologist also doesn't get a full specimen for for analysis. He gets a morcellated specimen, even if it is 10 centimeters. And whatever you do, however well you put it into a bag, it's likely to rupture.
Yeah.
So most of the times I do open surgeries. But there was one instance in a young girl who had a 6-7 centimeter tumor, which was probably malignant. We said we'll do a laparoscopic surgery for this because it's a fertility sparing surgery. When I went in and it looked abnormal, it looked malignant, it looked really bad. We started with it, then at some point when we saw the capsule was looking, we stopped and opened it. So even if it's not only preoperatively, even intraoperatively, if you find something not looking good at that point of time also, you've gone with the mind. This time was the first time I went in that, yes, I'm going to do only a minimally invasive surgery. And because of intraoperative findings also, you have to stop.
No, now that you say that, we have also had an instance which I was 100% sure when I looked through the scope that it was a malignancy. But then I thought, okay, let me see, she's a young girl, and we took a biopsy, it came out as tuberculosis. So I just want to say, many times it mimics.
It does. In fact, we published our experience with the tuberculosis, and morning there were discussion on CA125. So our, the median CA125 in our series was 900 in patients with tuberculosis. So in our country, tuberculosis mimics, it's a great mimicker of advanced ovarian cancer, one has to. And the important point here, there is never start neoadjuvant chemotherapy without confirming the diagnosis of malignancy.
But they wouldn't give it also. The onco people don't give it without
nowadays, yes, they don't. But we still see patients who have received, because many times those mesothelial cells pathologists may report as malignant. So all these things, one has to be very careful. We do see cases who have been given chemotherapy for tuberculosis and other way around. So.
But what was new was that you said after neoadjuvant interval cytoreduction, you can try. That is something new.
So that's, I would say it's experimental. Currently the trial is ongoing in highly selected cases with great expertise to do upper abdomen, to do omentum, to do everything, then only one should try. Outside trial, I would say no, it should not be.
Ma'am, can I just ask? Madam, you mentioned about tuberculosis. What I would like to add is tuberculosis would rather look like PPC. Do you really get so many enlarged ovaries?
In fact, in our series, these were adnexal masses, not PPC. They were adnexal, complex adnexal masses, which is very common in abdominal tuberculosis. Peritoneal disease, omental thickening, ascites, adnexal masses. We used to do, and now also we do ADA levels. So that's one indirect, but again not very confirmatory. So, and interestingly, both AFP, stain and culture, it doesn't come positive in a substantial proportion of patients. Even gene expert actually we have seen is not. So in the context at the end biopsy, we have done biopsies for many patients to confirm the diagnosis of tuberculosis.
Yeah, so traditionally, when we used to analyze patients, a tuber-ovarian mass, we would first of all think of tuberculosis. So a lot of these tuber-ovarian masses are tubercular. And whenever you are putting in a diagnostic lab, do always try to have a look at the tube. It can give you a lot of information.
Dr. Rupinder, looking at all your videos, it gives us all a lot of guts. You can do anything and get away with it, isn't it?
Let me just add to it. Somebody was talking about my valor and stuff like that. See, the thing is, you have to be a little foolhardy to be a fighter pilot. To take your plane up, you might not come down. Similarly, you have to be a little foolhardy to try all sorts of brave surgeries. That's okay.
No, but I just wanted to give you all a small little clue. When you're doing on a person who's already been operated, and when you're doing an endoscopic surgery, just remember one thing. If you want to avoid injury to the bladder and to the bowel, stick to the uterus. Let your dissection be closer to the uterus, then you will not. See that you saw that loose loop which she opened into. I mean, whoever the person who did it. Don't go like that. Stick to the uterus and then dissect the bladder out. Stick to the uterus and dissect the bowel down. That's a little tip which you all can.
Yeah, the basic principle is fat belongs to either bladder or bowel. Whenever we see fat, never take it with the uterus. So that's the safest plane. That's what we practice in difficult open surgeries also.
No, but one thing is there, however experienced a surgeon you are with endoscope, you must always be careful. Read the previous notes, find out what problems the previous surgeons have had, think twice before you go on an operated case, evaluate the case well. I think There are no two ways. You cannot compromise on such values. You have to evaluate the patient very well before you put in your scope. There's no
Yes,
question about
yeah.
it. Plan
And
your
also-
ports.
Yeah, yeah. And also before you finally call for closure, always check the bladder. We always do put in a methylene dye. Always do that, test with the air test for the rectum. Before we close, I think Dr. Bafna has got a very large experience. Maybe he can also add to all of us.
Of injuries.
He's never injured.
Okay.
Madam, there is a question from the audience. It's like, is there an upper limit for the size of the ovarian tumor where MIS can be done?
So yeah, literature suggests 10 centimeter, but as presence of additions and masses more than 10 centimeters are risk factor for rupture. But as Dr. Shalini says, I would say maybe 6 centimeter or 8 centimeter. More than that will be very risky. So, but theoretically, yes, it's 10
No, but I think they should look at all the markers. Look at the size, look at the wall, look at the septae, look at the projections, look at the Doppler. Do everything. Any ovarian mass should be evaluated very well. And if you are in doubt, still you go for the next modality. Go for an MRI. Because many times with paraovarian cysts and endometriotic cysts, which we think is benign, it may turn out to be otherwise. But many times we think it is malignant because they see those nodules on the ultrasound. Ask for an MRI. That's all. You go for the next modality of investigation because they're all young girls. You can't play about trying conservative management thinking, So always go for the next modality of investigation. Do your utmost till you're sure of the diagnosis before you plunge into surgery.
Right. So ideal to have frozen section, but if that's not there, at least send the entire tissue properly to a pathologist. And if malignancy is diagnosed, earliest referral to an oncology center is the next best we can do. If intraoperatively have messed up.
Okay, can I think Dr. Vinodini would like to share a case. No, please. She had managed one case in consultation.
See, me and Michelle were doing the surgery. It was a lady who was just married 3 weeks, and she came with lower abdominal pain. There was an ovarian cyst around 10 centimeter. So she told me, both of us were, 7 to 8 centimeter. We went in with a laparoscope. We didn't have the slightest idea that it would be endometriotic cyst because it was anterior to the uterus on ultrasound, having partial torsion. And with great difficulty, we tried to bag it. At the end of it, it ruptured and it turned out to be a chocolate cyst.
See, that case was, ultrasound finding was a benign, CT wise it was a benign lesion. What happened was CA99 was elevated, and that is why CA125 also, younger. But intra-op, like Madam had said, is whatever you decide pre-op, intra-op you should make a final decision. Intra-op you can, that small deposits, that gives you a clue whether you're dealing with endometriosis. The way the ovary is, it's a cystic lesion. So these were the areas where we saw it could most likely be endometriosis, and it turned out to be endometriosis. But how they approached it was that pathway of following the guidelines of imaging and tumor markers.
So CA 19.9 can be raised in endometriosis and in mucinous tumors as well.
Yeah, the only other point is just to remember that endometriosis can have malignancy. Endometrioid and clear cell carcinomas can be associated. So if we are seeing typical endometriosis on imaging, but if there are solid areas, please keep the possibility of, we do have many patients who malignancy with a background endometriosis. So again, just remember that endometrioid and clear cell cancers can happen in patients who are known endometriosis or where you think overall cyst looks like endometriosis.
That all. Any more questions? Actually, now we have a lot of endometriotic cysts, and even MRI will come back as endometriotic cyst, and CA125 is normal. But as you said, CA19.9 also we should do. That may be raised in mucinous cystadenoma, cystadenocarcinoma, and that's a problem. So which all to do would be the thing. How far to go with all these diagnostic things, especially when the girls presenting to us are either newly married or going to be married, just decided about marriage and they got this. So this is a scenario in Kerala now with lot of ovarian cysts coming up.
Dr. Chitra Kendra is here, how often they see these cases, post-laparoscopic surgeries coming, with the diagnosis of malignancy. So whatever we do, we are going to go wrong in terms of you may open for a benign case or you may do laparoscopy for cancer. So you have to decide which one is better.
We all often come across with this type of cyst, but we have to clinically evaluate completely.
No, what I'm saying, patients after surgery outside come to you after surgery. I don't know if
improper staging and all. That's
yeah,
also is
so
there. An
RCC
operator for
or
endometriosis turned out to be ovarian cancer. Yeah. That
so
is,
how
yeah.
often you see, RCC, you must be getting many patients like
Yeah.
this. So our number has really increased in recent times. We see 4-5 cases per week, if not more. which is
For
really-
me, I'm telling the youngsters should not feel ashamed of by opening the abdomen. But sometimes theatre and all, they have started laparoscopy, now they are going to open. What is this? Because theatre people and other people will think that you are not well. We are opening because we are thinking that that is good for the patient. We should not compromise the.
No,
for
in the
patient.
best of hands, things can go awry. There's nothing wrong with that.
But we should
That's
not
why I said-
compromise on the cure of the patient. That is what Amita is also telling. We should not compromise on the cure of. Even if one extra laparotomy is there, we should not compromise on the cure.
We must have done many laparotomies for benign cases because the diagnosis was not there. But there is, you can start with smaller incision, counseling, all of that. And if many times they turn out to be cyst adenomas, there also it's important to remove them intact.
And I'll say one more investigation which you all should do is AMH, especially in young girls and when you're doing any conservative surgery for.
We always do.
Do an
Always do
AMH also.
AMH.
Can I please disagree with you? See, you start doing AMH. We also used to do AMH. Many times the AMH value is so low that the patient gets so depressed and so dejected. And then I spoke to one infertility specialist where they said that a low AMH does not mean that it is going to remain low. Of its own, it can subsequently recover.
But ma'am, you
So
put it
as
this
of
way
now,
around.
No, just a minute. So as of now, if the AMH is low, are you going to defer the surgery?
No, never.
No.
It is just for
no, we are not going
documentation.
to defer. Then 1 minute. Okay, yes, documented. Then it only serves to counsel the patient in terms of oocyte preservation or embryo preservation or whatever else which it might be. And that in any case you would want the patient to do. Many times, at least I have seen at least 2 such cases where we did the AMH. AMH was so low, the patient just did not come back to us, nor did she go to any infertility specialist. She was just so depressed. God knows what happened with her. So, I just have that viewpoint.
But I think in this medical legal age, it's best to have, because they may blame it to your surgery later.
Usually in all scientific forum we will talk about the not doing the minimally invasive surgery to the doctors. From the other side, especially the well-educated parents will come with their daughters to have minimally invasive surgery, and I don't know, they are insisted to do surgery, minimally invasive surgery, and we will get the after rupturing the tumor, we are getting the basis. So what can we do to prevent? Madam also told there is rise in number of cases, such cases. So as a national authority, what can we do?
So I
Whether
think
any
counselling-
awareness, like cervical cancer awareness, we
So
have to start something.
counseling of the parents is so important. If we tell them that there is a possibility of cancer and these can be detrimental effects, I think they will agree. I tell you one patient, it's an IAS officer's wife who has seen you guys and she wanted CA endometrium, she wanted laparoscopic
No, we
surgery.
know.
I refused that I will not do. I said you can go to any doctor because she had a big fibroid. I knew it was not going to come out this thing. And eventually she agreed. So I think counseling is very important. We have to counsel. The moment you tell them to sign on that consent which says that if it is malignant, there is risk of spillage, all of that, they will never sign. They
So I
will
think-
never ever sign.
yeah.
So
So
counseling
I think
part
the
is
proper counseling part is more important.
counseling, and we have to
And
spend
most of the-
little time with them.
And most of the patient and the parents will understand if you counsel.
Yeah.
So I wind up the session. I think we had elaborate discussion on Thank you. Fourth session. So now we call upon Dr. Elizabeth, madam. So to talk on surgery in epithelial rapid scan of the last quarter of century. I know she needs no introduction, but she's a PhD in gynec-oncology. She established the gynec-oncology as a specialty in India. Over to you, madam.
Okay, fine. Well, I'm supposed to take you all through the development of surgery in epithelial ovarian cancer, a very rapid scan. Oh God, how does this go? Is this correct? Yeah. Now, we start with the Sushruta Samhita, and that documents cancer of the ovary as one of the 16 intra-abdominal malignancies in ancient India. But we do not have any details about what I understand from Dr. B.V. Kumarasamy is that surgery was being done. We do not know what kind of surgery was being done, and we do not have any documents about what is the kind of anesthesia that was used for this kind of surgery. And then you jump to the 20th century. You have Joseph Meigs between 1901 to 1923, that's exactly 100 years ago, who produces his series of 67 patients, and who said that surgery is important. And in 1934, he has a series of 147 patients, and then he comes saying that surgery should be advised early, and 5-year survival of his 147 patients was 16%. He suggested that as much of the tumor should be removed, and he predicted the use of a peritonioscope. Between 1935 and 1943, so the First World War was over, and the Second World War has started. He produces a series of 67 patients where his survival was 27%, which he attributed to aggressive surgery. By 1950s, the nitrogen mustards had arrived, and in 1961, he standardized and he said that hysterectomy with bilateral salpingo-oophorectomy unless preservation for fertility is required, and he introduced exploration of the upper abdomen. And then you came to Thomas Griffith, who finally said that residual disease is important, and that was in 1972. And he came to a figure of 1.5 centimeters by 1975. And during the same time, you had Per Kolstad in Europe, who produces his 990 cases in 1971. All this is experience. And you know, C.S. Lewis says that experience is a brutal teacher, but you learn. My God, do you learn? And so you have the real world experience, which starts to give way to randomized controlled trials. So the real world experience is what establishes that a surgery and is the basis of treatment for ovarian cancer. And so in the 1980s and 90s, you had still single institution retrospective reports. Coven at that time wonders whether, randomized controlled trials is possible in ovary. In 1978, somewhere between 1978 and 1980, omentectomy was introduced, and I was doing my PG in OB-GYN at that time at CMC, and I remember being taught how to do omentectomy by the general surgeon. Then in 1985, the trials of carboplatin versus cisplatin was being conducted by Eve Wilshaw in Royal Marsden, and the trials for lymphadenectomy were also being conducted in Graz by Eric Burgat. By 1988, you had quality of life studies being done, and in 1991, WHO had its first meeting to introduce a questionnaire for quality of life. And then you have the drama starting in ovarian cancer. You have primary disease debulking, and you have interval debulking and RO residual disease. So you have the ERTC studies in 2010. You have these three guys who talk about residual disease, that's Pelreti, Barlin, and Landrum. And they also came out with a thing that overly aggressive surgery may result in an extended recovery or even a postoperative death. Then you had the Chorus trials and the New Zealand trials, which started NACT, and you had the Trust trials and the Scorpion trials and the Japanese trials. By then, it's already 2018, and you have preoperative paclitaxel carboplatin followed by interval debulking or HIPEC. The increase in radicality continued in institutional and at the international level. You know, various kinds of things which are there depicted on the screen. And the idea is that RO is the most important thing. Then you started having the concept of specialized centers for surgery, so that, you know, they felt that if you try to contain it, then you get experienced people, and so you have less problems, and that trial was, I think, is working satisfactorily in UK by 2022. Surgery for recurrent disease started, and you have various studies for that. You have Coleman, who publishes something in 2019, and you have Harter study, and you have the Chinese who get into the battlefield along the Japanese. Then intraperitoneal chemotherapy and HIPEC, and you have various people who come in with that, and all this is combined with radical surgery. There are novel concepts and trends in ovarian cancer surgery, that is standardization and improvement of preoperative imaging to more accurately predict surgical outcome, and that is something which you all just listened to. Introduction of sentinel lymph nodes in early stage disease. You have fluorescence guided surgery. Minimal invasive surgery in advanced ovarian cancer is something which is coming up. Integration of tumor biology aspects in surgery. Standardization of patient selection algorithms. Interoperative tumor visualization techniques. Pairing surgery with systemic therapy and targeted therapy. So the things which have developed in this century is very rapid. Now, where do we Indian gynecologic oncologists stand? As against real world experience versus RCT. Now you have the Economic Times on the 27th of September 2023. You have Dr. Gayatri Sabharwal and colleagues from Bioinformation and Applied Biotechnology, which analyzed clinical trials which occurred in this country between January 2013 to December 2020. And they found that only 62 of the 424 trials by multinational companies were completed, and they observed that more than 60% of the participants recruited in these international trials were Indians. So on what basis was this occurring, and what is the ethics behind it, was the question that they were raising. So what does this mean? During the 20th century, Indians were the unknown and unsung cannon fodder in 2 world wars, essentially indulged in by European powers. 21st century, let not Indians become the clinical trial fodder. We have to remember in history, our own always betray us. You can start with the coming of Alexander, where we saw betrayal. So we have a slogan, Make in India. Can we stand by that and develop strategies for inter-institutional and inter-individual collaboration to produce our own history of gynecologic oncology treatment in this country? And my request to Dr. Chitratara and all of you in Kerala is to try to do this experiment in Kerala. Maybe, you know, God's own country, you may be able to get this through and start and be a beacon to the rest of the country. Thank you.
Thank you, Dr. Elizabeth, for that very wonderful talk. I always tell myself that we appreciate what we have today only by going through the history of medicine. We can respect what we have today only when we go through the history. Thank you for that lovely session.
Why? What question?
So that's a big challenge we got from you, Elizabeth. Very big challenge. So are we taking it up, Dr. Chitradhara and team? All the other centers also should be able to, the medical colleges and the other centers should come together, and then we can really do it.
No, what I feel, what I have seen since I'm out of this rat race of oncology, is that we are working in silos. You know, there are institutions like Tata, Amrita, Rajiv Gandhi, Adyar, who have enough patients to conduct their own clinical trials. But it's the rest of the country you have to take them forward. And in order to take them forward, you have to collaborate, and you have to plan it in a manner that maybe you collaborate for real-world experience, in which case you standardize some kind of real-world experience treatment policies and try and follow that up. Simultaneously, you must start RCTs. I think we need to do that. A small country like Japan has got 3 clinical trial groups. Asia as a whole, especially Southeast Asia, has got 3 clinical trial groups. We in India, we don't have anything for gynae-oncology, and now we have stabilized. The super specialty or subspecialty, whatever you want to call it, has stabilized. From what I heard, there are 40 candidates coming out every year. And if those candidates have to be kept with dignity in this country, you need to set up something like this. And all these countries started out with the national gynae-oncology body starting the clinical trial group, and then when it was strong enough, it separated out. So I request, I mean, I have past presidents, future presidents, current presidents sitting here to please think about it.
Absolutely agree with you, Dr. Elizabeth. And in fact, in Agoy, we discussed this issue, and it has already been passed by executive as well as general body. So the only thing is now we have to implement it.
Thank you.
So maybe before next Agoy, we will implement it.
Thank you, Elizabeth ma'am. Agnes, Dr. Sarina, and Dr. Tony for chairing the session.
Thank
So
you.
we conclude the session and we'll get forward with the next one. So for the next session, let me invite the chairpersons. So we have Dr. Smita Joy. She's an associate professor at Lakeshore Hospital and former at Amrita Institute. She had her training from Whittington Hospital, London, UK. Ma'am, we invite you to the dais. Next, we have Dr. Sankita Menon. She has a career spanning of 24 years in medical colleges, which has been filled with academics and teaching. Yes. Now as a professor at Department of OB-GYN at Government Medical College, Alapura. Next, we have Dr. Praveena Elizabeth Joseph, Head of the Department, Lourdes Hospital, Cochin. Ma'am, please, on to the dais. So let me invite the first speaker to talk from childhood to adolescence, decoding differences in staging. As you all know, I think Dr. Shalini ma'am doesn't need any more introduction. Professor and program lead in MCH Gyneconco program at AIMS Rishikesh. Past president of AGOI with all multiple publications, number. So ma'am, over to you. Thank you, ma'am.
Yeah. Thank you. Can my timer be changed? Because Dr. Elizabeth took 7 minutes. I'll take her 7 minutes more too. Okay. So I think after those exciting talks of Dr. Amita and Dr. Rupinder with all those exciting videos and Dr. Elizabeth's passion, let's come down to adolescents and pediatric population, which who we don't treat as much as we do in adults. And it's a different ball game when you come to pediatrics, pediatric patients and adolescents. So let's look at some definitions. There are no actually fixed definitions for who is a pediatric population, who is a young adult, who is an adolescent. Let's look at that. And the staging systems that are used in pediatrics are different from what we use for adults and adolescents. We look at the background, some principles and techniques, and evidence over the years. So if you look at age groups defined, SEER still talks about young adults as people between 15 to 39 years. Of course, today we'll restrict ourselves to pediatrics and adolescents, but they have one review in which they talked about 0 to 9 as pediatrics and the rest as adolescents, but we know that pediatric groups can overlap. ESGO and ESMO have one definition for adolescents and young adults, that is between 15 to 25 years. And of course, universally, WHO classifies adolescents as between 10 to 19 years. That's a universal WHO classification. And the gap, the adolescent and young adult gap, is actually better defined by a transitional boundary, and the bridge of which is puberty. Young pre-pubertal children with GCTs are different from post-pubertal adolescents with GCTs in many ways. And if you review the data from the MAGIC is a malignant germ cell international consortium, and they have done studies over the last 25 years. They've conducted studies for over 25 years. And when they looked at non-germinomatous GCTs, non-germinomatous we mean non-dysgerminomas. Dysgerminoma is a counterpart of seminomas in the males. So if you look at non-dysgerminomatous GCTs, that is the teratomas, embryonal carcinomas, and there's another one, which was the other one, yolk sac tumors. These are non-germinomatous. 11 years they've taken as a cutoff for prognosis. They've taken below 11 years and above 11 years when it comes to non-germinomatous GCTs, and let's see how it behaves in those children. So children younger than 11 years have better event-free survival compared to the older children. This is from the MAGIC group. And the objective categories of less than 11 years and more than 11 years are surrogates for biologic categories of pre-pubertal and post-pubertal biologies. Then second is a societal transition of when actually children become adults. It varies from country to country. It varies from hospital to hospital. In the hospital that I worked for at UCMS and GTB, 12 years was the cutoff for pediatrics, and after 12 years, 13, 14, 15, they came to us as adolescents and we treated them. In PGI Chandigarh, it's 14 years. Dr. Amita says it's 15 years in TMH, so that's very variable. And in AIMS Rishikesh, it's 18 years. I was very surprised that adolescent girls were going to the pediatric surgeons for surgery, 14, 15-year-old, which I was used to treating at GTB hospital. And the pediatric surgeons are as good as surgical oncologists. They have very little experience with ovarian tumors because it is not a very common condition in, ovarian cancers are not very common in pediatric children, right? So they look at a huge tumor, they look at spread to other structures, and they want to do a complete surgery. And says, ma'am, how can you do a fertility sparing surgery in such a big dysgerminoma? And even after giving NACTs, they were going to go ahead with hysterectomy for about a 10-year-old girl. Then I intervened, or we had discussions, and then how we saved the uterus and the other ovary from being removed. And in Canada, the adult age, they transition to adult hospitals at 18 years. So that is very, very variable. So it's it's kind of a gap that we still have to address. And it depends on hospital to hospital, depends on country to country, depends on each society. So when you look at demography, about 10 to 30% of all ovarian masses in girls up to 17 years are malignant, accounting only for 1% of childhood malignancies and 8% of all abdominal tumors in children. There's a bimodal peak. First peak is in young children is 0 to 4 years. The second peak is 9 years in girls and 11 years in boys. And in boys, the incidence of germ cell tumors are much higher than girls, because in girls, the number of germ cells in the ovary itself is much lesser. It's finite number, and they keep decreasing every year. And it is arrested in meiosis. But in boys, the germ cells proliferate right after birth, and they continue proliferating. So their incidence is something about 11 per 100,000 compared to about 3 to 4 per 100,000 in girls. In prepubertal patients, teratomas are most common. In adolescents, it's immature teratomas and dysgerminomas. And if you look at all tumors, we say about 70 to 80% as stage 1. The SEER data says it's about 64% of patients have early stage disease. So no single staging classification. In the pediatric population, the children's oncology group, which has taken data from the last 25 years, uses a post-surgical classification system. And we, in adolescents and in adults, we use the FIGO staging system. So what is different in pediatric staging? You can look at the column which is marked in red. In pediatric staging, stage 1 is limited to the ovary, no clinical, histologic, or radiological evidence of disease outside the ovary. Stage 2 is microscopic residual disease. Peritoneal evaluation is negative, but failure of serum markers to be normalized to normal. There may be no evidence of disease, but the tumor markers still remain high. The lymph node involvement is similar to adults. The lymph node involvement, stage 3, lymph node involvement, gross residual disease. But positive peritoneal cytology, which in adults is stage 1, is now stage 3 in pediatric population, and its distant metastasis is the same. So positive peritoneal washings, we said, is stage 3 in the pediatric oncology group staging system. And FIGO does not incorporate tumor markers, whereas COG does incorporate tumor markers into their staging system. And FIGO staging, we say stage 2 is disease confined to pelvis with extension to tubes and ovaries, but irrespective of tumor markers. There's similarity in stage 3 and stage 4 when you compare it to adults. So there's given a risk stratification in 2015. We'll look at that risk stratification. And it is attained by merging data of last 25 years from US and the Children's Cancer and Leukemia group in UK. So you look, they give a low risk group, they give a standard risk group, and they give a poor risk group, a standard 1 and standard 2, and they have this thing of 11 years as the cutoff. So stage 1, like in any other ovarian tumor, the prognosis is good. But if you see in standard in ovary, if it's stage 2 to 4 and she's less than 11 years old, versus ovary stage 2 to 4 and she's more than 11 years old, the predicted long-term disease-free interval is higher in girls who are less than 11 years old as compared to girls who are more than 11 years old. So 11 years is kind of a cutoff that they've given in the MAGIC classification. Then pediatric ovarian tumors, I already said that 2 to 3 per 100,000 girls, but boys it is much higher. It's anywhere between 8 to even 15 per 100,000 in boys. Most are benign, and most common are non-epithelial in origin, because germ cells are the cells that are seen, the migration from the yolk sac into the gonads. They can be gonadal, extragonadal and all, and it's normally seen in the pediatric age group, whereas you have epithelial tumors more in the adult age group. And the prognosis is also different, depends on the histological distribution. Majority in stage 1 respond well to surgery and chemotherapy. They are very, very chemosensitive. That's why the staging is different for adults and pediatric population. So the histological types, 85% GCTs, 8% epithelial cell carcinomas, 5% is sex-cord stromal and spheroid cell tumors, and I've described the small cell carcinoma of the ovary, which is very rare, of the hypercalcemic type. Everywhere they describe this. In this particular type, which occurs in the younger age group, fertility preservation is not recommended because they're very aggressive tumors, and these are the ones who require more radical surgery. They may be a small percentage, but they may be, when you see it, you have to decide, she's a young patient, this tumor is aggressive, whether you would like to do fertility preservation or not. In this population, dysgerminomas and yolk sac tumors are prominent. So the staging principles are collection of ascites or washings on entering the peritoneal cavity, examination of all the peritoneal surfaces, and only biopsy of abnormal areas. Like in the normal staging system, we take multiple peritoneal biopsies of even normal looking areas. Examination and palpation of the lymph nodes alone, we don't remove, we don't do a routine lymphadenectomy, it's a limited staging. Inspection and palpation of the omentum. Omentum again may not be removed, or only an omental biopsy taken in children, because the yield in the omentum is very low. I'll talk about it in the next slide. And inspection and palpation of the opposite ovary, again we do that even in the adult patient, and only you biopsy the abnormal ones. And complete resection of the tumor containing ovary with sparing of the fallopian tube. This I did not understand, because you have the tube stretched over the ovary, you have a malignant mass. We normally do a salpingo-oophorectomy. Many groups have recommended salpingo-oophorectomy, but some have asked for preservation of the fallopian tube, which I don't really understand, because I think that it is so close to the tumor, you remove the whole of it, and a fallopian tube hanging there without the ovary present, as gynecologists we know, is not going to be of much help. Anyway, we can argue about that later. I normally remove the fallopian tube with the ovary, not do only an oophorectomy. So staging principles, similarly, we said the yield for lymph nodes and omentum is very low, less than 5% detecting occult disease, so that is not done. So we have a limited surgical staging, and only abnormal areas are biopsied, and omentum is also only a biopsy. Biopsy would be a 10 into 10 centimeter amount, and in fact, somebody answered if it prevents, it's cytotoxic to cancer cells, why should you be removing the omentum unnecessarily? Somebody said that earlier. And so random biopsies are only of abnormal tissue. With an exception to fertility sparing surgery, many cases of dysgerminomas or adult or young patients with the gonadoblastomas, in that you will have to remove the ovaries. You may leave the uterus behind because the chances of malignancy are high in patients with gonadoblastomas. So karyotyping is indicated in a few patients, especially when you suspect dysgerminomas. So in the Italian MITO-9 study, 65% of patients with lymphadenectomy was omitted in 70% of cases. They said while incomplete staging was a risk factor for recurrence, there was no impact on survival, suggesting that salvage with chemotherapy or surgery in the recurrent setting is feasible, and they're very, very chemosensitive tumors. So even if you do a limited staging and there is a recurrence, they respond to treatment. In this year database, neither lymphadenectomy nor presence of lymph node metastasis had any impact on overall survival in a multivariate analysis. So in the pediatric intergroup study, surgical guidelines, that is the surgical guidelines we follow in adults, were adhered to in only 1 out of 56 ovarian GCT patients, yet 95% of patients were long-term survivors. So these are other studies also telling you why you need only limited staging in a pediatric population, because the kind of tumors that we're dealing with are different. They're not the same as the adult population. So that was about GCTs. I have only 2 minutes left. The epithelial ovarian carcinomas in children, again, a limited surgical staging is done, but there is no clear-cut definition on what is the staging system for epithelial ovarian tumors in adolescents and children. That is a gray zone still. But because majority are mucinous ovarian cancers and majority are low-grade serous cancers and majority may be borderline ovarian tumors, you can still do a limited staging system in these patients, but all these patients, even low-grade serous, do present in advanced stages. So small cell ovarian carcinoma, which we already talked about, is a rare entity and has a propensity for younger age group, but fertility sparing surgery is not really recommended in these patients. So just a breakup of GCTs and sex-cord stromal tumors, epithelial tumors in all ovarian tumors over 30 years period. And this is a Belgium study, again showing that epithelial ovarian tumors are around 11% in children. So epithelial neoplasms in pediatrics, there is lack of literature regarding staging protocols for epithelial malignancies in the pediatric population. Current pediatric staging reflects recommendations for adults, although COG staging practices, rather than more extensive FIGO standards, may be sufficient for pediatric patients with low-grade tumors and BOTs. Patients who are incompletely staged at a time of diagnosis should be closely followed for recurrence. And so this another sentence that the Society of Pediatric Surgical Oncology said, that since the pediatricians and the surgical oncologists see these patients so infrequently, they should have consultation with tertiary gynae-onco centers and plan management for these children rather than do it on their own, because they don't have sufficient this thing. And you go to any pediatric surgeon, they'll say there's a big mass, it's spread here, it's spread there, and they do a complete surgery. So I think I will stop here because my time is over and I may have covered both pediatric. Unless you give me 2 or 3 more minutes, I will, can I get 2 or 3 minutes more? Is that okay? Okay. So these will be a few, just a few slides showing various groups and what are their recommendations, especially in non-epithelial ovarian cancer for the ESGO. And SIOP is the Society for Pediatric Surgeons, or pediatric, it's a French term. And the open route is not recommended as a surgical approach. Then even ESMO, they did not discuss it. And the British Society says they actually talked about management of ovarian cysts and, in children and adolescents. So it was not only ovarian malignancy. So that was not discussed. Surgical approach, ESGO and ESMO are very certain it has to be a laparotomy, even in children, not a laparoscopy, though there are some sentences somewhere that MIS may be used by an experienced onco-laparosurgeon, depending upon the size, etc. Median laparotomy, open route recommended. This other group, the expert group, said you can use a fan and steel, but I think all of us know that the approach to the upper abdomen is much better with a vertical incision. You can extend the incision, you can go upper abdomen. Even laterally, I think your lateral pelvic wall is better approached with a vertical rather than a transverse incision, but that's of course your experience. And systemic pelvic lymphadenectomy is not routinely recommended. Not routinely recommended by both groups, ESGO and ESMO. Biopsy, again, not recommended unless it is abnormal. And tumor resection, ESMO, I think, says unilateral salpingo-oophorectomy, whereas ESGO says oophorectomy recommended, tumorectomy, cystectomy to be avoided. You try to remove it completely, except if you have your imaging and you have a nice ovarian crescent sign, which shows normal ovarian tissue, and you're able to remove the tumor with remaining normal ovarian tissue, you can do that. And fertility sparing surgery is recommended if oncologically safe. In both have said, but fertility counseling, oncofertility counseling is very important. And oocyte cryopreservation with ovarian stimulation is recommended. We have a small study, I'll just show you that. And hormone replacement therapy, especially 2 years later, these are young girls who will be without ovaries for a long period of time, especially if you've done a bilateral salpingo-oophorectomy. So consider ovarian hormone replacement therapy, because they'll be, for the next 3-4 decades, they would require hormones. So don't go back with the idea that these are cancer patients and we should not give them a replacement. So this was a small study which we did last year, in which we had 22 patients in whom we assessed their fertility potential. Majority were germ cell tumors. Stage of the cancers was again a majority for stage 1 and stage 2. 10 received neoadjuvant chemotherapy. 12 received primary surgery, and after primary surgery, 8 got adjuvant therapy. So the serum AMH, pre-treatment serum AMH was 1.82, which fell in the post-treatment, either by surgery or by your chemotherapy. The difference was statistically significant, similar to the AFC count also, which was again already lower. Then we compared these values with a normal cohort of more than 1,000 or 1,500, I don't remember the exact number, of girls who were normal girls in the age group, the same age group. And the serum AMH in a normal cohort was higher, 3.48, as compared to the pre-treatment group in our patient, in this group of patients. So probably the fertility potential is already a little lower in patients with ovarian cancers. So I think documentation is important. A lot of patients after germ cell tumor treatment do conceive. We say 70 to 80% conceive, but you have to give them the option of oocyte preservation whenever required. And AFC count you see in a normal individual, it is so high as 18 in that population. This was a study by Dr. Gunashila. And for us, the pre-treatment value, already the AFC count in the other ovary, the normal ovary, was on the lower side. So I think fertility counseling and fertility awareness is very, very important, and fertility preservation is important. You have to give them the option. So open route, we already talked about the surgical approach. I think Dr. Amita stressed on avoiding intraoperative tumor rupture either by open or by MIS, very, very important. And if there's a high suspicion of malignancy, a median laparotomy, try not to do a transverse incision. And a minimally invasive approach is acceptable only by trained laparoscopic oncology surgeon with no tumor morcellation or accidental rupture. And radicality of approach, oophorectomy preferred compared to cystectomy or tumorectomy, because recurrences are more with a cystectomy. And preservation of uterus, or at least part of one adnexa, is the minimum fertility sparing that one would require. And yes, sex-cord stromal tumors are a little different from germ cell tumors, in which only in stage 1 you preserve it. In small cell carcinoma with a hypercalcemic type, radical fertility sparing is not recommended. So it is a demanding, the management is demanding, requiring expertise, precise design, tailored to the specific needs of non-adult patients. Treatment should be simultaneously curative and safe. ovarian function preservation and fertility sparing surgery is important. Open approach again, minimally invasive, only if you think it's possible and by trained surgeons. And rarity of ovarian cancer in children and adolescents further complicates the management of this disease. Whatever evidence we have is level 3 and level 4, and recommended to enter children and adolescents into clinical trials. That's the recommendation. So I come from the city of Rishikesh, where a lot of you all have come recently for the conference. A beautiful city. You must visit it at some point. Thank you. Okay, thank you.
So Dr. Anupama is he's a consultant in the Department of Medical and Pediatric Oncology at VPS Lakeshore Hospital. Over to you, Doctor.
Good morning, everyone. I'll be discussing about targeted therapy in ovarian medicine. As we all know, we are moving away from one size fitting all to a precision medicine, especially so in oncology, and ovarian cancer is not different from that. So decision making in frontline ovarian cancer, in addition to the good old staging, histopathology, timing of surgery, surgical outcome and comorbidities, we are adding genomic profile also in deciding the adjuvant treatment or maintenance treatment. So the first targeted therapy which got approval in ovarian cancer is anti-VEGF monoclonal antibody, bevacizumab, based on GOG 218 and ICON 7 trials, which used around 15 mg per kg and 10 mg per kg different doses for a period of 12 to 15 months, and showed significant benefit in progression-free survival. However, these long-term data failed to show any benefit in the overall survival. So there is an unmet need, because we all know that epithelial ovarian cancers present more than 80%, even in developed countries, present in advanced stages 3 or 4, and around 50 to 70% of them relapse after the initial treatment, including maintenance therapy with monoclonal antibody. So there comes, what are the targets we have in the treatment of ovarian cancer? We know that homologous recombinant deficiency arising from homologous recombinant pathway gene mutations or methylation is common in ovarian cancer, which are seen in up to 50% of the cases. And among them, 25% of them are by BRCA mutations, either germline or somatic mutations in the tumor. So as shown other this thing, and there is a category of possibly HRD which may change in future. And now how we can detect this, because I'll go through why this is important is there are PARP inhibitors are effective only in homologous recombinant deficient subgroup of ovarian cancers. So there are two principal ways to identify HRD. One is looking for the cause, that is the homologous recombinant repair gene mutations or at the effect. So as I mentioned, BRCA mutations, other genetic mutations, promoter methylation and unidentified causes account for the causes of HRD, and the final outcome, that is genomic instability due to inability to repair DNA, is the effect of the effect of all these mutations. So there are NGS panels for assessing the mutations, and genomic instability is usually assessed with the damages caused by this, that I'll discuss in the next slide. So why this is important is, it is shown that the mutation studies, mutation in the gene does not directly affect the outcome of treatment with PARP inhibitors. Most of the major trials have shown that, because there may be other alternate pathways or escape mechanisms which will help these cells to undergo DNA repair. So usually a combination of 3 scores of genomic instability account for this HRD scar or final scar. One is loss of heterozygosity, second is large scale state transitions, and telomic allelic imbalance. And this is mechanism because telomeric allelic imbalance, there is loss of terminal allele, Loss of heterozygosity, as we know, there is loss of gene in one of the pairs. And large-scale transitions involve different mechanisms like duplications, transition, or interchromosomal translocations. So all these are the final outcomes of the gene mutations. As I mentioned, it was shown in the major trials that homologous recombinant repair gene mutations were not predictive of PFS benefit, whereas HRD genomic instability testing was able to predict the PFS benefit from olaparib in Paola study. And now the other problem is even in the major trials, there were 18% of patients where HRD tests were unknown. So in real world data, how can we mitigate this? The problem here is we have to send adequate sample and proper sample. The sample, any FFP sample is acceptable. And as we know, not only in ovarian cancer, primary peritoneal cancers and fallopian tube cancers also will respond to treatment with PARP inhibitors. There are some unacceptable samples. One is brain metastasis, and second, bone metastasis, especially when the tissue has undergone acid decalcification. Endometrial tissues are usually unacceptable, and omentum and lymph nodes are also not preferable if you have a different site of thing like ovarian tumor or other metastatic site. They will be better. These tissues are better for assessment of HRD. And tissue sample also should be adequate, more than 30% of tumor to normal cell ratio, at least 20% of the tumor DNA should be there. So this should be assessed by the pathologist before we send the sample for HRD. And now coming to the trials which have shown benefit for PARP inhibitors in first-line therapy, SOLO-1 was the first trial, even though number was less than 400 patients, but this has shown a significant benefit for those with BRCA mutation, both germline and somatic mutations. And the long-term data showed that after 7 years also, there was a significant benefit even in median overall survival. So for the first time, a targeted therapy has shown a benefit in overall survival in ovarian cancer, that was with olaparib. So these are the other studies which led to approval by FDA by all these PARP inhibitors. That is Paola 1 trial. Prima trial, Paola 1 trial included olaparib along with bevacizumab, and Prima trial which studied niraparib, and Velia trial with veliparib. Veliparib, I think, is still pending FDA approval. Here, in addition to the BRCA mutations, the HRD testing also was considered, and Prima trial, which included niraparib, showed benefit for HR proficient tumors also, even though the margin of difference was not significant as compared to a BRCA mutation positive or a HRD deficient tumor. So this got approval irrespective of the HRD status in treatment of ovarian cancer. As we see, all the patients in BRCA mutation and HRD deficient, there was a significant difference in survival, even though overall survival data is pending. Now coming to second line, these are the drugs approved only in first line treatment. Now coming to second line treatment, the pivotal studies were SOLO-2, NOVA, and Ariel studies, which included olaparib, niraparib, and rucaparib. Here also, the significant difference was seen in germline BRCA mutation or HR deficient tumors, and these got approval. However, the problem is these studies were conducted in patients who have not received PARP inhibitors in first line treatment, so we don't know whether re-challenging these drugs in second line are going to be effective in future. Because we all know the PARP inhibitors are not with side effects, including myelodysplastic syndrome and secondary acute myeloid leukemia, which are reported ranging between 0.8 to 5% in different trials are there. So we have to be careful while using these drugs. And these are approved even in first line only for advanced stage diseases, not in early stage diseases. Now coming to the newer targets which are available, it is shown that targeting folate receptor alpha is an ideal target for ovarian cancer because it's rarely seen in normal cells and it is expressed in cell surface of epithelial cells. and mainly ovarian, endometrial, and triple negative breast cancers overexpress these receptors. And you have a IHC method where we can grade the intensity with which they stain. And usually 2+ and 3+ are considered as positive, but moderate or high grade positivity. And these are the ideal patients who will benefit from the use of folate receptor antagonists. And there was a pilot study, Forward 1 trial, which looked into response rate, overall response rate, and duration of response. And they have they were successful in showing that there was a significant response and duration of response compared to investigator-decided chemotherapy in patients who are refractory, that is from second line to second, third, or fourth line of therapy. And as we can see the plot, there were some complete responses also in this group of heavily pre-treated patients also. And it got FDA approval for platinum-resistant epithelial, ovarian, and primary fallopian tube cancers in platinum-resistant. The drug is mirvetuximab soravtansine, and that's not available commercially in India. Confirmatory trial, which has closed accrual, it is Mirasol study, which included around 450 patients. In this, there was patients who had already received PARP inhibitors, and there were patients who had already received bevacizumab also. And median overall survival was significant in the interim analysis. The final data is pending. Now coming to the next target, that is sodium-dependent phosphate transporter. This is for a change. It's not a oncogene, but it is a sodium phosphate transporter. Upifitamab, rilsodotin. All these are antibody drug conjugates which deliver a chemotherapeutic drug attached to the antibody. And here also, they are broadly expressed in ovarian cancer and adenocarcinoma, non-small cell adenocarcinoma. There are limited expression in normal tissue that makes an ideal target. And there is IHC assay to calibrate, to distinguish between wide range. It is scored depending on the scoring from 1 to 1 and above. Usually the score in epithelial ovarian cancer and lung adenocarcinomas are high. So that has not got any regulatory approval, but still in phase 3 trials. So what are the targeted therapies available for us? In first line and relapsed epithelial ovarian cancer, we have approved drugs, that is bevacizumab. In first line, maintenance around 12 to 15 months. Once it relapses, until progression. And then we have PARP inhibitors, which are given usually for a period of 2 years or until progression in case of relapse. Now, in relapse setting, as I mentioned, approved antibody drug conjugate is mirvetuximab soravtansine, and other drugs like upifitamab, and targeting HER2 monoclonal antibody with drug conjugate. Antibody drug conjugate is also waiting approval. Then we have tyrosine kinase inhibitors like AKT inhibitor, selective glucocorticoid receptor modulator, which is actually studied in Cushing syndrome, is also shown some benefit in ovarian cancer and is undergoing phase 2 and phase 3 trials. Then we have cedaranib, which is a VEGFR inhibitor. Immunotherapy, as we all know, in all other, like in other tumors, has shown some benefit in selected patients of ovarian cancers after multiple relapses. So we have all these targets like the tree. For ovarian cancer, I don't know whether it is clear or not. Towards the end, we have all these targeted therapies, and probably we'll have more in future. Thank you.
Thank you, ma'am, for that very informative session. Now I would like to call upon Dr. Vinota from CMC Vellore to come and deliver the session before lunch.
Thank you. Thank you for making it known that I stand between you and lunch. Let me make my disclaimer right. I'm not a pathologist. I'm not a radiologist. I'm a hardcore gynae oncologist. So when Dr. Chitra Tara called me up and said I have to speak on this, I had initial jaw-dropping experience. And then I made my slides prayerfully, like from darkness into light, please lead me. And now I think I'm not in a lightened auditorium like this, but somewhere in the hallway, so let's start. So before I start, I'd like to describe a few key concepts. We talk about artificial intelligence. That's a broad field, and that's a broad field of computer science in which machines or algorithms are programmed to simulate human intelligence. Now, machine learning is a subset of artificial intelligence in which data is fed in, and based on statistical methods, a pattern is observed, and then it develops its own algorithm. So there is some feature engineering, so there is a human behind this, and it's not exactly explicit programming. We use augmented intelligence interchangeably with artificial intelligence, but that is not so. Augmented intelligence is a subset of AI. It's developed to enhance human intelligence rather than operate independently. This is almost like asking Siri, give me an answer for this, or play me this song. That is augmented intelligence. Then you have representation learning, where it's a type of machine learning in which there is no feature engineering, there is no human involved in it, but you feed the program a set of data, different kinds of images, and then the computer decides as a pattern in this, and it makes its own algorithm and classifies the provided data. Now, deep learning is a further subset, and this is based and inspired by the structure and function of the brain called artificial neural networks. So let me just explain this with a few examples. Now, based on these gray scales, a human might call it a kidney. Or based on the features of a dog, even if the dog looks like a cat, we call it a dog. But the computer attributes certain pixels to the kidney. And looking at the pattern of pixels, it calls it a kidney. Now, this is machine learning. Similarly to a dog or a cat, it looks at the pattern of pixels and calls it a dog or a cat. Now, representation learning is we give data, a set of series of images, and the algorithm learns on its own the best features to classify provided data. For example, we give various images of stage 1 chronic kidney disease, or various images of stage 2 chronic kidney disease, or stage 3 or stage 4 and 5. And based on the images provided, the algorithm decides the best features to classify provided data. So there is no feature engineering, or there is no human engineering in this picture. Same way, you give them different pictures of dogs, various kinds of dogs from various regions, and then they decide that this is a dog. But then you have to be careful. What if the background does not have grass and it's a house? There's a problem, because the computer might decide, the program might decide that this is not a dog because the background is not grass. So you need to give them representative data. Now, deep neural networks is a basis of deep learning, and the inspiration is the biological neural network. For example, if I try to walk to the edge of this auditorium, I have immediate impulses shooting back saying, beware, you might trip and make a fool of ourselves. Similarly, artificial neural networks has input and output, and many hidden layers of neural networks in this, and this is the basis of deep neural networks. Now, deep learning consists of computer vision tasks such as detection. We detect that there's a nodule here, or there's a liver mets here. Then you segment out the lesion, and then we classify it, and these are based on algorithms which are based on features, classifiers, and shape extraction methods, and usage of convoluted neural networks or other neural networks. They decide on shape extraction, regularization, and then they give us a data. So AI now has an accepted role in oncology. We use natural language processing to transform unstructured data from electronic health records and diagnostic or procedural reports into discrete data elements such as progression-free survival or overall survival. There are patient-facing chat boxes with which patients can actually communicate or ask their doubts. Cancer genomics, cancer-related image analysis. Actually, Google sensed that I was doing so much of research on this, and now every time I pop up a question, Google asks me if I want to use AI, but often the answer is really stupid, what Google gives me. So let's go on to virtual biopsy. I'd like to describe a few concepts again here. semantic evaluation. Now, this is qualitative imaging features that are described by an experienced radiologist that describe a tumor shape and internal structure. An example of this is we see an ill-defined hyperattenuated lesion in the segment 7 or 8 of the liver, and therefore we call it a liver met. Now, quantitative evaluation, they use advanced mathematical algorithm to describe tumor shape, the image intensity distribution, the relationship between image voxels in great detail, and this is called radiomics. So radiomics is quantitative imaging as against semantic imaging, which encodes information of the underlying tissue. And we know that different imaging phenotypes capture the pathophysiology of the lesions. So we know that in low-grade serous carcinomas, you have calcified, a lot of calcification as against high-grade serous. So radiomics is different imaging phenotypes capture the pathophysiology of lesion. We give quantity to it. Now, when we marry radiomics with genomics, that's called radiogenomics. And virtual biopsy is an alternative to traditional percutaneous surgical biopsy. We were talking about ultrasound-guided mental biopsy, ultrasound-guided ovarian biopsy, or laparoscopic-guided biopsy. So virtual biopsy is an alternative to these needles being stuck in. And it delivers information on the tumors, phenotypic expression, molecular drivers of disease by extracting quantitative information from radiological imaging, and it's a bridge between traditional radiology, pathology, genomics, and artificial intelligence. So the usual pathway is the patient undergoes imaging, and rather than undergoing an ultrasound-guided mental biopsy or a laparoscopic-guided biopsy, they undergo a virtual biopsy by which we read images, and based on the information derived on it, we come to a diagnosis. So we talk about the virtual biopsy pipeline for anything. Like for you use a test, you need to develop a test, and then you need to validate it. Similarly, in a virtual biopsy pipeline, we need to first develop a model. So we need to acquire data which is multidimensional, multi-institutional, high quality, annotated images, clinical, pathological, and molecular data. For example, now virtual biopsy is used a lot in melanomas, in skin. So you need to have lesions against fair skin, dark skin, black skin, whatever color of skin you have for that, to realize that no matter what the background is, this lesion is still a melanoma. And that you also have to supply them with clinical, pathological, and molecular data. Once we get the data, we need to harmonize the data to reduce data variability. Now, we know how different high-grade serous carcinoma look. You have nodular features, you have infiltrated features, but then you have to harmonize the data. And then they're subjected to regions of interest segmentation, where you highlight areas of interest, as we see in this picture. And now this is fed as input, and we can either use machine learning, where we extract the features from the segmented region of interest, then we select the features so that they are reproducible, they are relevant, and avoid overfitting. So I gave you an example of providing images of dogs against grasses. And then because we have fed only images of dogs against a grassy background, the algorithm cannot identify a dog in a house, a dog against snow. So we have to provide features and select features which are reproducible, relevant, and avoid overfitting or over-adaptation. Then if you have to have this right, only then the model will work right. And then we develop a model based on statistical relationship between features and desired output by using like Cox regression analysis, logistic regression. Or we can overcome all this and just use deep learning. So that is input. And then we get a virtual biopsy output by which we can not only detect the disease, we can also characterize the disease and then do genotypic characterization. So once we develop the model, we need to validate the model. And the goal is, can virtual biopsy detect and characterize tissues in a similar way to conventional biopsy to treatment choice and predict treatment outcome? We heard about Dr. Anupama describing all the various tests we need before we decide a particular treatment is precise for that patient. And for that, we need a robust and a reliable gold standard. We need to validate the different data sets to evaluate robustness, reliability, and generalizability. And we need to assess the model by using accuracy, sensitivity, specificity, negative predictive value, positive predictive value, ROC curve analysis. And then the best that we can have is not retrospectively validated radiomic models, but rather prospectively validated radiomic models, as they are more generalizable. Now, can we apply virtual biopsy to ovarian cancer? Most of our epithelial ovarian cancer are typically high-grade serous. They have high degree of heterogeneity at multiple levels. And biologically, high-grade serous ovarian cancer is solid tumor driven by point mutations in P53 and BRCA1, and many DNA copy number alterations, might be deletions, might be insertions. And we have a varied tumor microenvironment, which is a play between the tumor, the stroma, and the immune system. And we still haven't understood this interplay of these factors. And we have chemoresistance. And this is often due to tumor cell clones with different genomic profiles due to different TME heterogeneity that acquire tumor resistance. So what are the real-time needs we face with ovarian cancer? We need better detection techniques of resistance to chemotherapy. We need evidence-based therapeutic stratification. And the challenge is, when you see a patient as such, there's complexity across tumor regions and metastatic sites. I mean, within the same momentum, we have different nests of cells which have different TME. And it's absolutely impracticable to sample momentum at various sites, because, I mean, even if you just sample in one site, that does not provide adequate coverage of the entire tumor. And here, advanced radiology has a role, because it helps in capturing spatiotemporal tumor complexity in a comprehensive, non-invasive manner. And virtual biopsies can predict the probability of molecular profiles of interest. Radiology can allow targeted real-time biopsy in an informed way. So I have just listed a few publications which have examined the role of virtual biopsy in ovarian tumors. So this was the first one which appeared, not the first one, a recent one, fairly recent one, which is a Chinese study, where they used nomogram models based on radiomic and semantic features to differentiate between serous and mucinous pathological types. And they went through the model development as I described earlier, and they said it could be possible. We also have studies which looked at virtual biopsy in ovarian cancer to identify the biological profile. And this came in 2017, and they described that patients with BRCA positive tumors have nodular peritoneal disease, and they have peritoneal disease in the gastrohepatic ligament. Whereas those with infiltrative pelvic disease or mesenteric disease or supradiaphragmatic disease are less likely to have BRCA mutation. So this is an example of an infiltrative tumor where it is ill-defined, similar to this. Sorry. And this is a nodular tumor where it is dense, clear margins. An example of this is radiologically, and they said that nodular tumors are more likely to be BRCA positive as against infiltrative type of pattern on radiology. So we heard of the TCGA classification of ovarian cancer. This is classification of ovarian cancer called the Clover classification, which is described 3 types. Immune, proliferative, mesenchymal, and diffuse pattern. And they described that the mesenchymal type are more likely to have tumor in multiple peritoneal sites and more likely to have pouch of Douglas implants. Just 2 minutes, can I? So moving on, there's something called habitat radiogenomics and target biopsy. So as I mentioned earlier, an omentum is not all the same. If you have seen them grossly. You have multiple tumor nodules, and each tumor nodule might have a different kind of activity. So using textural analysis, and based on the color intensity, we can know which tumor, which site has got the highest tumor activity. So the concept behind habitat radiogenomics is that we have a complex tumor with intratumoral heterogeneity due to different TME, due to different molecular profiles. So these are described as habitats, like a habitat of a tiger or a habitat of a lion. These are regions within a tumor that present a distinct imaging phenotype. So you can use virtual biopsy to provide radiomic maps, to provide local information for each radiomic feature, and you can help direct virtual biopsy like that. So this is like what we usually do, radiology guided biopsy, whereas when we use radiomic maps. So they even have devised 3D modeling so that they can section resected specimens to get the area of interest. So the challenge is we need to ensure reproducibility of radiomic features have to be ensured. And so far the data that we have is based on limited size, and we need prospective testing, which is mandatory for clinical translation. I would like to thank you. Radiogenomic studies are an important association between radiomics and tumor biology, and they can revolutionize the current clinical practice. Thank you.
Thank you, Vinota ma'am. Thank you so much for simplifying a very difficult topic. I'd like now to call back the speakers on stage because the session is now open for discussion.
Dr. Shalini ma'am, Dr. Anupama ma'am, and Dr. Vinota ma'am. So the topic is open for discussion. Chairs, please.
I think as the questions are coming in from the audience, I thought I'd just say something. Very interesting, Dr. Rajaram, that between so many centers that there are so many changes in the age when they consider pediatrics. I remember taking my daughter to the pediatrician at 15 and asking him when I should stop coming. He actually said, when she starts working, she can stop, and then you bring her. But I thought it was very important that in the young age group, that even gynecologists, I'm a general gynecologist, that we really think that preservation of oocytes is a huge thing in front of us, and we need to refer them yet to a fertility specialist as well for controlled ovarian hyperstimulation and preservation, because sometimes in the the zust to get them better, we forget what their
No, they're very, very important. Is at the beginning itself involve the fertility specialist, especially when you're dealing with young girls.
Absolutely.
Right from the beginning itself.
Yeah, and even this, you were saying that you'd rather remove the tubes and the ovaries at one go. I was wondering why they wanted to leave the tube behind.
I really
Probably
don't
it is
know.
the the migration of the ovum and the possibility of fertility later.
Of ectopic. I really didn't understand why, because we've gone through this oophorectomy versus salpingo-oophorectomy, and we've been practicing for over 30 years now, and you know that the tube is so close to the ovary, stretched over the ovary, and what is the point of just separating the tube and leaving it hanging there for an ectopic pregnancy rather than transmigration? And I feel that it is very close to a tumorous tissue, the ovarian tumor, and it should be removed along with the tumor. Only, of course, if you're doing a cystectomy and all, it's different. But in a salpingo-oophorectomy for malignancy, a salpingo-oophorectomy needs to be done.
Absolutely. Will there be any more questions on that session?
So any questions from the audience?
Dr. Shalini ma'am, excellent talk ma'am.
Thank you.
So what I would like to say is that I am a general gynecologist, and so are many in the chairing the session as well as in the audience. So this talk was an eye-opener for us. We do, when we talk to our patients, we do the staging based on adult staging. So this adolescent gynecology, and where you said more than 30% of the tumors could turn out to be malignant, we should be doing pediatric adolescent staging. And I feel gynec oncologists should be coming out and...
That's what we gynae oncologists do. We do limited staging for adolescents and pediatric
you
patients.
should be giving more and more talks in gynec societies and other forums to, educate
this,
general gynecologists so that, we can pass on the benefit to our patients and their parents. Some of the masses which we deal with, when we open them up or do the laparoscopy is when we suspect this could be malignant. So the protocols as to when to open up, how to do the, the end-bag, like the videos that were shown are so good, where you should not be cutting them, putting them end-bag and taking them out, en masse, rather than fiddle with it. So
I think, practically speaking, a 6-7 centimeter tumor which can be put into a bag and removed, and even after putting into the bag, we do morcellate it to remove it, right? Even if it's an in bag. And what does the pathologist get? He gets a specimen which is totally mutilated. So that also happens. So I think as restricting, if 10 centimeters is also quite large, I feel restricting yourself to maybe 6 centimeters. That's what I said. Now, when I went ahead to do a minimally invasive surgery for that young girl who had a 6-7 centimeter tumor, even that turned out to be malignant intraoperatively, and I went up and opened it because I didn't want any spillage.
And ma'am, what is the age limit to do an AMH when you deal with adolescent ovarian tumors?
According to ESMO and ESGO, it's up 25 years, 15 to 25 years, but the SEER database takes 40 years as young adults. So up to 40 whenever
so
they want.
even a 15-year-old, you must do an AMH before?
I think so, yeah, because it showed that it is lower even from the beginning. So the disease process itself must be reducing the fertility potential. So I think documentation is very important even in a young girl.
Thank you, ma'am.
And I think it was heartening to realize that these young girls respond better and they have better prognosis.
Yeah. Yeah, that's good. Even in the epithelial, germ cell uniformly, it's good. But even epithelial, they say it's borderline ovarian tumors, mucinous tumors which do well, which are more seen in younger people. So,
Anupama's talk was a lot of tongue twisters.
I know.
And it was very, a little difficult to digest. But I was just wondering on a practical basis, how applicable, you work in a gynae oncology center, how much of it do you actually practice?
Now that we are able to practice because Indian companies are coming up with these tests and it's more affordable.
So for the illiterate like us, how many of these tests are available? I know BRCA is, P53, all that, but what else?
HRD is also available.
HRD
is available, HRR gene is available, but as shown, HRD is a preferred choice. HRD is a bit more expensive, but that's a choice of the thing. If you really want to start treatment, HRD is the better test.
So do you tailor your treatment based on
the problem is HRD testing, as I mentioned, it's 75 to 90,000. BRCA is much cheaper. It's ranging between 6,000 to 24,000. It's available, and plus the affordability of a PARP inhibitor is also a problem. So if they are not able to afford a PARP inhibitor, there's no point in going for an HRD testing. The well-affording patient, yes, we do recommend HRD also in addition to BRCA.
Thank you.
Dr. Anupama, with regards to HIPEC, that is hyperthermic intraperitoneal chemotherapy. So does these targeted therapies have a role in HIPEC?
Actually, it should have, because I have not gone through that separately. But nowadays, some of the Western countries are following HIPEC. So these cohorts included HIPEC patients also. Stage 3 and 4, irrespective of the completion of surgery and the type of surgery, they were included in the PARP inhibitor maintenance therapy.
Okay, thank you.
So in HIPEC, it's usually platinum-based chemotherapy, and we're doing it routinely. Targeted therapy, then they put them on the same maintenance treatment as you have for adjuvant treatment for patients. Like even after HIPEC, the same therapy is followed as we follow for ovarian cancer patients without HIPEC. I think Vinodha's talk was very, very good. It made AI very simple, and and I think in fields like radiology, where you have to sift through hundreds and thousands of images, it's very good. AI is very good. But if you say you use AI for colposcopy, then I had a debate with Dr. Walter Prendeville, and he was speaking for AI and I was speaking against AI for colposcopy or cervical screening. And of course, I spoke against it because I said it's good for feature recognition or pattern recognition, like in radiology or histopathology, where you have so many slides to screen, or even in screening. But I said colposcopy has 5, 6, 7 abnormalities, so why do you need AI for colposcopy? So maybe then you put it into the hands of anybody. You don't have to be a gynecologist. Once AI is good for colposcopy, then anyone can do it. Probably
They want to remove the human component. So there's a very good book called Deep Learning by Eric Topol. You must read it. It's Making AI Human Again. In fact, I read that book deeply to talk against Dr. Walter Prendeville. And it's a book I recommend all of us to read. It's a nice book. It gives you a lot of insights into AI and the utility of AI. I think Vinota did a great job. And Dr. Chitra had offered that topic to me first. I said, no, I cannot do that. Vinota would be a much better person to speak on AI. So questions to Vinota? There must be a lot of questions. The youngsters, no? There's so many youngsters who must be so keen on AI.
No, we're talking about AI in cervical cancer screening, not by the hands of a gynecologist, but people out there. There's the same problem. Like you have to provide images across races. Because I think Dr. Partha just talked about how they had programmed based on Western images, and when you brought it to India, it didn't work because the images were not from the Indian population. So how you develop the model is very important in whatever setting you do.
So the database has to be really
Yes.
huge.
Yes, it's multi-institutional, multi-dimensional. Annotated with elements. So that's also a problem because when you develop a model, it depends on what package you buy.
Exactly.
So each package decides on how many images it will take.
Especially in ovary when the disease presentation is so variable.
So varied. So it's not well studied. It's still only developing in ovary, whereas it's being used in pancreas, liver, prostate, especially for Gleason School.
And in fact, I think a few years back, like a lot of radiologists give a diagnosis. They say cystoglandular hyperplasia. How can a radiologist say cystoglandular hyperplasia unless you have a histopathology? But now it's becoming true that they can give a diagnosis based on radiological images because it's gone through artificial intelligence, like thousands of algorithms and images have been fed in. So now that's becoming true that they can give a diagnosis of the histopathology without actually the histopathology being done.
And what would be the actual application in ovary? What do you think? Is it the localization of the disease or because I don't think getting a histopath is that important.
So see, virtual biopsy, it can just leave out machine learning too. As the first one I talked about BRCA, the kind of lesions and they try to attribute to BRCA. That was not machine learning. It's just based on quantitative imaging, looking at the pixels. So it's just not, AI does not mean deep learning. So it's a broad thing. So even I looked at the topics, I was very surprised with this quantitation of findings and attributing to BRCA and non-BRCA. It's basically two radiologists have gone through whole thing and just quantified images and tried to adhere it to this thing.
Especially when you said in BRCA, which ligament was more involved? Gastrohepatic was more involved in BRCA. That must be free from so many images that they saw. So that was, I don't know.
So it's radiogenomics. So it's a link. Virtual biopsy does not mean just radiogenomics and deep learning. It's a whole link.
What will be the application exactly? That would be a little bit.
So application is, I think when the future applications, now we only have small retrospective data sets. That's why we need to get prospectively validated models. This is probably will help in targeting a biopsy, which is the most likelihood. We can use AI, especially one of the images I showed, they merged MRI and PET to decide which site of the ovary or which site of the omentum will give you the highest yield of a particular molecular profile you're trying to get.
Or maybe in those doubtful cases of recurrences where we don't know what
recurrences when you want to decide on precision, further precision technology.
Or where to take the biopsy.
Can I
And
ask
also
a question, chairpersons? Madam. Dr. Vinota, it was a very interesting topic and discussion. So I have this question. Now, most of the gynae people are not that tech savvy. Yes. So does it involve coding or anything which might hinder?
Yes, it does. That's a big disadvantage. But we have people coming up. It does involve.
But that would be for people making this thing. For us, end users, it has to be easy.
End user. So you have to first develop the model.
No, the end user, do we need to?
No,
do coding
you're
or
relying
anything?
on the output, but then the model has to be validated to give you the output that you want and which is relevant to the patient.
Oh, only the production is.
It's like any other app. So like you have, you ask for a song in YouTube. You decide which song you want.
Your parallels are very good. Very good. It's so simple. I feel I'll go back knowing AI. Thank you very much.
Okay, thank you. I think it was a really good discussion. So now we'll wrap it up the morning session and we'll go for lunch. We are a little behind time. So if possible, please try to be back by 2 o'clock. I know it's a short time span.
Thank you.
After the lunch, actually there are few posters put up. So there will be a assessment of the posters for the residents. So the residents who have put up the posters, after the lunch, assemble at the site. The assessors will be coming. Okay, thank you. We have pharma company stalls. Please do visit them also. The lunch is in the other building at second floor. There is a connectivity. There is a connecting bridge in this floor. You can just go in and go one stair down to the canteen.
Check, hello, check.
Welcome back everyone after a sumptuous lunch. Now we will have a panel discussion on germ cell tumors. For this session, I'd like the chairpersons to call upon the chairpersons, Dr. Vinay Chandran Nair and Dr. Rajeshwari Pillai. Yes, ma'am. Dr. Vinay Chandran is Professor of Obstetrics and Gynecology in Malabar Medical College in Calicut. He's also the former HOD of Government Medical College Kannur in Manjeri, and in the former Professor of ONG in Institute of Maternal and Child Health in Calicut. His fields of interest are infertility, gynec endoscopy, high-risk obstetrics, and gynae-oncology. We welcome you, Doctor. And Dr. Rajeshwari Pillai, ma'am is a professor and HOD of Department of Obstetrics and Gynecology in Government Medical College, Ernakulam. And she's fortunate to have worked in various government medical colleges in Kerala. And her areas of interest are teaching, diseases of the elderly woman, and in GTN. We welcome you, ma'am. I'd like to call the moderator of this session, Dr. Rema. Dr. Rema is the HOD of RCC Trivandrum, and she is also awarded the UICC CRET Fellowship, and she has multiple publications and citations to her name. I'd now like to call the panelists. Dr. Vinoda, ma'am, we welcome you back to the stage. She's assistant professor at CMC Medical College. Dr. Fessie Lewis, sir is Professor and HOD of Department of Reproductive Medicine and Surgery, Amrita Institute of Medical Sciences, Cochin. He was Foxy Vice President in 2021 to 22. He is associated with, he has a large number of affiliations, and we're happy to have you here, sir. Dr. Neetu Kunath, ma'am is Assistant Professor at Amrita Institute of Medical Sciences, Kochi, and she was formally educated in Kotte Medical College, Kerala, and she got gynec oncology at Acharya Harihar Postgraduate Institute of Cancer, Cuttack. Next, I welcome Dr. Govind, sir. Sir is current consultant in Department of Medical Oncology in VPS Hospital. He was formally educated with DA Medical Oncology from Madras Medical College, Chennai, and he has multiple publications to his name. And finally, Dr. Deepak Bose. Sir is currently working at Regional Cancer Center, Trivandrum. He received his MCH in gynec oncology from RCC Trivandrum. He's also been a stellar student and has got multiple publications and was awarded the gold medal and multiple papers to his name.
Thank you very much. We'll start the panel discussion. Today morning we had a very informative sessions, and we covered many aspects of germ cell tumors. So we know that malignant ovarian germ cell tumors are rare cancers but very aggressive cancers. They come in stage 1 usually, except in around 20-25%, and they have got very good prognosis. And fertility preservation, considering the age, it's a rule, and surgery, we should do a adequate staging but minimize the morbidity. Being rare tumors, you don't have many randomized controlled trials for germ cell tumors, so they really need multidisciplinary expertise. So today we have an expert panel here, and so we'll discuss a few cases. My first patient is a 15-year-old girl presented with abdominal pain, and she had regular cycles. On ultrasound, she had a right adnexal mass. Tumor markers were normal except for a slightly elevated alpha-fetoprotein. Other tumor markers were normal. This is her CECT, which showed a 20 into 15 centimeter solid cystic right adnexal mass. Uterus and left ovary were normal, and there was no disease elsewhere. So when you get an adolescent with suspected malignancy, it's a very difficult situation. We know that adolescents, even otherwise, are very difficult people to handle. So how do you go about, Dr. Vinoda, when you're counseling a young girl with and her parents about germ cell tumor, how do you go about the counseling?
So we need to talk to them about the current situation and also tell them that it's just not cancer as such, that we will plan on surgery with removal of the ovary, but that does not mean the end of life. She might require chemo, not have chemo. And most importantly, I will use common survivors who have dealt with germ cell tumors and have done well, like Lance Armstrong and our Yuvraj Singh.
Yeah, definitely. There are very good examples of germ cell tumors, our own Yuvraj Singh. And it's a distressing situation, but parents are concerned about a fertility also. Dr. Fizzi, your opinion on fertility issues, not just germ cell. When an adolescent comes with malignancy, what are the fertility counselings? Definitely they need oncofertility counseling. So how do you go about these patients?
I think today morning we had a discussion about the AMH, but I think definitely if the AMH is not at all directly proportional to the fertility, that means even if AMH is less, they can get conceived. But definitely we have to see the AMH, because AMH shows the ovarian reserve. But if the FSH also is high or the elderly patients, definitely the fertility potential will be less. The AMH just means how much reserve of oocyte you have. But the problem is that the standardization of the AMH value, because different labs we have seen the values may be erratic or may not be accurate. That is the thing we have to see, where we have to see. But definitely we have to see the AMH. And as the other advantage with the GCT is that the most of the times when we do the chemotherapy, the survival with the present regime is good. I'm not an expert with that, but and so when we tell about the fertility preservation in those patients, it needed at least few days to at least even if you start the random stimulation start protocol. That means irrespective of the period, we can start the stimulation and do the IVF. Even that need at least 2 weeks for the completion of the process. So that time, patients are always not keen to delay the treatment. That is one problem what we have seen. But in other issues, other conditions where the post chemotherapy, or if they have to take radiotherapy, the chance of recovery of the ovarian function is less. But in the chemotherapy, about more than 90% you can get normal ovarian function. Only thing, we may have to wait for at least 6 months. 6 months is the time where the AMH starts to regain, and ideal time is to wait for 2 years. But in adolescents group, if already the AMH is less, those patients, when we give the chemotherapy, the chance of recovering percentage is slightly bad. And much more worse is the older patients, not the adults and patients where already the AMH is less, plus ovarian function also will be less. So that doesn't mean we have to do the AMH, and with that we have to counsel the patient. Suppose if the patient is can wait for, we have to discuss with the oncologist, and if we can get at least 2 weeks for the treatment, then definitely we can retrieve the oocyte and give. Only problem with that random start protocol, we don't get sufficient number of 8 or 10 embryos. We may get only 2 or 3 embryos. That is one problem according to the period protocol. So definitely we have to counsel and give them option of the what can expect with that fertility, and with that we have to counsel the patient.
Okay, so we get the message that we are not routinely doing AMH for patients with germ cell tumors. Dr. Neetu, your comments?
Yes, ma'am.
Are you routinely doing
Yeah,
AMH for your
no,
adolescents?
to say no. Sometimes when we are really concerned, like both ovaries look, we might have to do a cystectomy on the other side, and one ovary will be removed. Maybe then. Otherwise, when we come with a unilateral, actually, it is mostly they are come with a lot of stress, and when you tell fertility and all, I think that becomes even more stressful for them. We give them an option, go meet the fertility specialist.
Yeah.
But I think we can do that. We
Yeah.
should make a protocol, like we should do AMH for everybody who comes with a germ cell tumor, maybe.
I don't know. Shalini madam, we concluded that we should be doing in more than 15 years, but that's not our practice now, probably. Okay. Yeah. Okay, you do for all patients more than 15. Okay, all young patients, fine.
It's very difficult to tell a 15-year-old girl. The mother is usually one who is shedding copious tears there.
Yeah, but I feel a oncofertility counseling. Probably a oncofertility counseling will reduce the stress rather than increasing it. Not looking into that issue will be creating more of.
Another question what people will ask that, suppose, okay, we will do the surgery, we'll go for one shot of chemotherapy, then go for fertility preservation. But practically that is not justified because the toxic effect of these drugs on the oocyte is not proven. And definitely even there is a study when I referred for this, even after 3 minutes of the first chemotherapeutic dose, the ovarian vascularity is being reduced. So the drug effect will start soon after the chemotherapy started. So that cannot be done, because this is what the concern usually sometimes people will tell, okay, at least one chemotherapy, then we will go for it. But that is not practically possible. That is incorrect. That's what the message must be. So if we are doing, we have to do it before that, or we have to take the chance. If the ovarian reserve is reasonable, we have to take the chance, wait for 1 year and then go for the. Then we have to definitely see the AMH value start from at least 6 months onwards and wait for 1 year. And if it is less, definitely at that stage we have to counsel them to go for an oocyte or the embryo preservation in that patient. Whoever those patients who have undergone the surgery and chemotherapy also, we have to counsel them. Just because we have done the chemotherapy is not the end. We have to do along with that recurrence follow-up, we have to do the ovarian function follow-up also.
If you get a window of around 4 weeks, you can go for ovum pickup and then
no need for 4 weeks. 2 weeks is
should be.
Yes, so
because
2 to 4
random
weeks.
start protocol, irrespective of the period, we can start. But only problem is we may not get enough number of
sufficient egg. But even then you can get it, and we can preserve it and then go for the radical treatment and then come back for
Definitely,
the fertility treatment.
Yes, the oncofertility should be addressed at the diagnosis and probably not applicable for germ cell tumors because fertility regains are very good.
I just want to ask one.
There are some ovarian protective drugs like GnRH. We usually give for other cases. When you give GnRH, there are in the literature we can get like the few protective drugs are there, but we don't have any experience with that. I don't have any experience with that.
They are not
Can you,
100%
madam,
proven,
can you
but
plus tell what are the drugs? Because we have no experience with that protective drugs other than the GnRH analogs.
The medical oncologist can answer what is the current evidence for that.
It is the standard of care. Some people have tried it.
For breast cancer, we routinely use, and there is a randomized.
Yeah, there's a data on breast cancer, but as Madam said, in germ cell tumors, the pregnancy outcomes are good actually, very good. We don't, I mean, we probably will not get a trial in that actually, and we don't have any data supporting that as of now.
Germ cell tumors,
Not that
no.
other fertility protection drugs, oocyte protection drugs, which you have an experience. Can you share with us?
Only GnRH analogs we have an experience,
But
something
in
else.
the literature there are some other drugs like some newer drugs has been mentioned. GCSF, like that, few drugs have been mentioned, but I have no experience.
No,
with that.
even we don't have any experience. I mean, we are routinely we don't use it
only
actually,
LHR
because using a
Congress
GCSF
has
before chemotherapy is again will affect the marrow reserve very much actually. So that will totally hit off the marrow. So using a GCSF before chemotherapy is almost impossible.
In patients with reduced
GnRH analogs as well as tamoxifen
MSH,
also has been tried. Yeah, as a,
can be given or not.
yes, ovary.
Reduced,
You'll have to have
Yeah, but
quiescent
they are not
ovary.
proven,
Ovary
right?
hormone.
Something.
What
Yeah.
guidelines?
Both
Therapies
analogs
can
as
be
well as
given.
antagonists also tried.
Yeah, so coming back.
Again, the risk of gonadotoxicity with the chemotherapy agents.
Telling to
That is,
reduce
I presume it's more with the breast regimes than the
Than with the
bleomycin
chemotherapy
and the
given.
etoposide and paclitaxel. So maybe that is another reason why we are not so concerned about protection of the ovaries during
our
the,
germ cell tumors, right?
there is a good regain of ovarian function also.
Yeah. Yeah. Coming back to my patient, the point Amita madam emphasized, the parents will come and request a laparoscopy. Even some of the doctors may call you, and but we won't do it. Seeing that CT, she's not for MIS. So how do you go about counseling the parents? What do you tell them practically, Dr. Neetu?
This is
All
a
the-
very
yeah.
regular question,
Yeah,
laparoscopy.
yeah.
I tell them that a scar we can hide with a tattoo, but what she needs is more life to enjoy. That's what I literally tell them.
Definitely, that's
Yeah.
a very good answer.
Yeah. So most of them understand. It's
Yeah,
not
they do
difficult.
understand, they do
Because they
understand.
are very concerned about the baby. You know, mothers, they're like, do whatever I want my baby. That's what they say, I think.
Yeah.
It is when 27-year-old and 28-year-old pre-marriage women come that we have a little more difficulty convincing them to do an open. That they become
Yeah.
cosmetic
Yes, yes,
because
yes,
before
I
marriage.
understand.
But adolescents, it's more
Yes,
easy
yes.
to convince. That's what I.
Yeah. The points emphasized by Amita madam, it's minimally invasive only if you are very sure that you will remove it without rupture or mucilation with the full exploration with all peritoneal staging. So, Dr. Deepak, what is the role of staging and what is the role of lymphadenectomy in our patient, this 14-year-old with solid cystic mass and AFP slightly elevated?
Again, the is fertility sparing surgery definitely. So, but we would be removing the entire ovary that is containing the tumor, as it is a unilateral tumor. And peritoneal staging is actually mandated, especially the infracolicomendectomy, peritoneal washings, and the different peritoneal biopsies. Regarding the role of lymphadenectomy, the guidelines don't actually recommend a lymphadenectomy in all cases unless there are enlarged nodes already on imaging or intraop findings. This is basically because this is a very good chemosensitive tumor. So what even different meta-analysis have been performed and even found in MITO9 studies are, if you have done a lymph node dissection and you have found a few lymph node metastasis, you can have an improved progression-free survival, but then finally that also gets tackled once they recur with your chemotherapy, which is very good for these patients. So there is no overall survival difference if you have done a lymph node dissection or not. So you can reduce the morbidity related to the surgery, but the fertility sparing surgery with the peritoneal staging is what is mandated in the adolescent age group.
Dr. Vinoda, your comments should be omentectomy or omental biopsy you should do?
I think we usually do an infracolic omentectomy.
And lymphadenectomy, it's a no, right? Unless there are enlarged lymph nodes and we feel we can easily debulk, it's a no.
I think Dr. Shalini talked about the MITO9.
Yeah, she told about the MITO9, and we have enough evidence that lymphadenectomy is not going to improve her survival, and MITO9 concluded that Omitting the staging, peritoneal procedures increases recurrence rate but with no impact on survival because all of them can be salvaged by chemotherapy. So we'll be doing omentectomy infracolic with peritoneal biopsies and no lymphadenectomy. So this is what the patient underwent. We opened by a midline vertical incision. This was a 10 into 8 centimeter tumor. She had some peritoneal deposits in the subdiaphragmatic area. The histopathology came as immature teratoma grade 3 in a stage 1A, grade 3 immature teratoma. The deposit showed mature glial tissue. So what do we do now? It's a stage 1A, grade 3. Dr. Govind, what will be your plan? Should we go for surveillance versus chemotherapy?
We prefer to go for adjuvant chemotherapy in this group actually. Grade 3, we usually don't omit chemotherapy.
Dr. Vinoda, what is your plan now?
One concern is you mentioned peritoneal deposits showing mature glial tissue. That is one concern when we give chemotherapy, that they end up with growing teratoma syndrome.
Yeah, it'll be.
So in this patient, I would rather take that middle path of, if I can, withhold chemo and close follow-up, because I know she's got a high risk of developing growing teratoma syndrome.
Even otherwise, 1A grade 3, there is a protocol,
Yeah,
upcoming guidelines
True.
showing avoiding chemotherapy, considering the toxicity and the good cure rates. Your comments, Dr. Neetu?
New guidelines are saying the recurrence also can be salvaged as good. So even if they recur, the treatment is the same, and as Deepak was telling, the survival is also not affected. Only the recurrence may be more, but the survival is not affected. So we can, for grade 2, grade 3, there is this thing that we can observe, closely observe, like monthly. And all.
Exactly. That, closely observation is the most troublesome most of the time we are having, because a periodic series of CT scans which we have to do, that again is
6 monthly CT
Exactly.
scans. I don't know in our setup how much feasible it is. That's why we
All-
end up giving.
Yeah, true.
But ma'am, you were telling if there is mature glial tissue, you prefer not to give. Why? If you don't give chemotherapy, they don't. Oh.
They grow after chemotherapy, right?
So they just die off.
No, they just remain same. We are remote now, so something else is there. Dr. Deepak, your opinion on? Yeah. Yes, ma'am.
More conservative guidelines. Pediatric, if you consider this a pediatric, that's okay. But at Tata Memorial, for sure, this patient will get chemotherapy.
Even our place, it's practiced, but I was
So
talking
think
about the
for grade
upcoming.
3, we would give chemotherapy.
But recent ESGO consensus all says that we can try active surveillance for these patients also.
Guidelines are not there, no ma'am. It
guidelines
is
are not
new
there.
this
Consensus,
thing.
yeah.
Not for
grade 2 and 3 we have to give, that is the guideline, but now there is
grade
a
3
consensus.
definitely, grade
But,
2 one can
yeah,
it's borderline.
Yeah, grade 3 we end up giving, even if we wait and watch, actually, ultimately probably we'll end up giving 60 to 75% of the time. Yeah, because most of them
Totally
the only thing is that why we can give is because it's chemo curable at any point. Even at relapse, recurrence, we are able to 95% of the time salvage. So that's the only reason. But eventually, more than 60 to 75% will require chemo in grade 3 only.
But when you... Yes, madam. You can always...
Census between BP and PEB.
We usually prefer BP, ma'am. We either give for BP or we omit bleomycin and give an extra dose of EP. That is based on our experience from germ cell tumor of testis actually. So PEB we don't practice usually. Practice.
Younger children also.
Younger children also we don't practice. We'll either go for EP or BP.
EP for how many cycles?
EP into
EP4.
4. One extra, yeah.
Yeah, we... 2 BP and then 1 EP is what is...
That's like even when we are giving BP, we also follow the same thing
3,
actually.
right.
After 2 cycles, maximum cycle 3 day 1 we'll give a bleomycin. After that we'll never give bleomycin in whatever the case.
So maximum 3 cycles BP or 2 BP and 1 EP.
Up to to be precise on cycle 3 day 1, I think most of the medical oncology centers prefer after cycle 3 day 1 they avoid.
Newer reports talking about lower dose of bleomycin with the
Yeah,
PEB
ma'am.
regime.
Yes, 10 units per meter square on day 1. That is one acceptable regimen actually.
There is
So
a
they reduce
pediatric
the total
regimen
cumulative
with a,
dose.
pediatric
Yeah.
regimen with a reduced bleomycin dose, right? Okay, so
Can
you
I
can...
one
Yes,
doubt?
Michelle.
If you're avoiding chemo in such cases, there is this active surveillance protocol for
Yeah,
that.
that's what we are
But
coming
then,
to that, yeah.
okay, I mean, that follow-up is practically not
It's
possible.
practically possible. We are doing that for
It is
dysgerminoma
possible.
at least.
Okay.
Yeah. I mean, we take for active surveillance depends on the patient. Proper patient counseling and confirming pathology and tumor markers normal for a reliable patient, we can do that. This is the ESGO advised protocol, and actually we are doing it for dysgerminoma. We are not giving them chemo. So it can be considered for this individual patient, but as Govind rightly said, she is at a risk of recurrence at least in 50 to 60%. We have this evidence from MeToo says that you can avoid, MeToo actually concludes that in 50 to 60% you can avoid chemotherapy sticking to active surveillance. So that's an option because all these toxicities are there with BEP. And so about the fertility issues, we don't routinely see this with germ cell tumors, but Dr. Fesi, what is your opinion on oocyte cryopreservation?
I think oocyte cryopreservation, I think we are doing not for much cases for GCT, but routinely we are doing just because of some patients with reduced ovarian function and some patients with marriage issues, if there is doesn't have an husband before planning for second marriage. Like that, just as a perspective of oocyte cryopreservation is a accepted fact now. I think the survival rate is very good. About 10 years back, if you look, the cryopreservation was a rapid cooling technique. Now it is vitrification technique. So almost more than 90% oocyte we can retrieve it, and we can do the IVF ICSI procedure and again freeze it or transfer it. So that is an accepted thing. And regarding the adults and concerns about the ovarian survivors is whether they will have the ovarian function they can recover from that. But GCT, I think the recovery rate is almost good. Other cases only is the confusion. But more than important is that when you tell them there is a gap of two weeks, that is the thing what we were discussing the beginning itself. Then the parents are already, when they have the news, they will be under the state of shock, so they will not be ready to do any fertility procedure, which again, if you are doing IVF, it is additional cost also. It can be done through IVF only. But if you take the similar incidents with the males, where the semen preservation for those patients is just masturbation, collecting the sample, even then we have to collect at least 5 ml, so it will take 2 or 3 times to masturbate, and that may slightly delay the treatment for 2 or 3 days. Even then, the parents are very concerned about delaying the treatment. So here 2 weeks, that is the thing which we have to counsel. And if you can accept the risk, I think not only the GCT, other cancers, if the oncologists across our country will start giving the options, and since there are now a lot of IVF centers are there, almost all the centers will be freezing the oocytes. At least half of them will have the facility. So if you can spread the message, that will be very useful, that fertility option. And with oocyte cryopreservation, that has to be part of the counseling of whenever you first disclose about the about the disease to the parents.
Yeah, definitely. The message is you should continue the oncofertility counseling and follow up during chemotherapy.
One
also.
more thing is that automatically you will be reading a lot of about the ovarian tissue cryopreservation, but still that is under the research. I think that is not accepted as other than the research. So that option must not be given. Only option is to either oocyte the freezing, or the married little more advanced stage means we can preserve his embryo. Embryo retrieval rate is much more better than the oocyte retrieval rate after the cryopreservation. About what? Now, when they're giving the oocyte freezing, we are taking the consent of the parents, plus the adolescent will be signing that, but more than the parents will be signing that. And after that, when they become adult, when they have to renew this oocyte freezing every year, when they cross these 18 years, then automatically we have to get the consent from them, what we will be doing with the oocyte when anything happens to them. There is now there is a form with the
ICMR
new
protocols, standardized things are there, right?
ART Act has come up with a proper consent form. Previously it was not there. To quote one example, not the female, a few years back when this ART Act was not there, one boy had come to freeze the semen, and afterwards we took the consent from the father and from the 18-year-old boy, 18 plus it was, but even then we took the consent from the parent because it was nearing that age. But after 1 year, the father came telling that, okay, I mean, the son could not survive the disease, so we wanted the sperm for the treatment. But it was not written in that part of the time, if anything happens to them, what has to be given to the sperm. So we could not give it to them. Then afterwards, several people came telling that it is his son's sperm you have to give. I told them you have to get in court order, if that we will give that. Then they went to the High Court, got the order that it has to be released to the father. But they could not do anything because to utilize that sperm for unmarried sperm, still there is there is no option. So even though they got a court order to release the semen, but they could not utilize it till now, even after 5 years.
Okay, so coming back, okay, we know that there are new things coming up, microRNAs. But coming back to a patient, she was treated with 3 cycles of BP. On follow-up, she had abdominal symptoms, and this is what CT was showing multiple various cystic lesions, and tumor markers were normal. So, Dr. Vinoda, your opinion seeing this?
Because she had a baseline elevated AFP, and now that the tumor markers are normal, and in the setting of immature teratoma, I will consider a growing teratoma syndrome.
Yes, growing teratoma syndrome was, the markers were normal, so we went ahead with laparotomy. She had multiple nodular deposits, and it all showed mature glial tissue. So it is growing teratoma syndrome, and this entity should be kept in mind when you have an immature teratoma, especially with the post-chemotherapy patient. So we know that growing teratoma, chemo can change the immature elements to mature, and they continue to grow, causing pressure effects, and we have to do surgery for that. Dr. Govind, suppose it was recurrence, markers were high. How do you address that now? Conventional chemotherapy for these recurrences?
Hello. So in the progression free, the interval is the most important thing actually. So if it's a very
this is after 3 years.
After 3 years. So after 3 years anyway. So it relapse in germ cell tumor ovary. Always the thing is that actually germ cell tumors are chemo responsible, but it's not chemo curable. So we'll require invariably surgery and chemo. Both will be required actually when there's a relapse. So again, high dose chemotherapy with stem cell rescue is only when we have all the macroscopic disease eradicated. So again, no clear-cut data on germ cell tumor ovary, but testis and mediastinal germ cell tumor, that's what they say. Unless and until you eradicate all the macroscopic tumor by your surgery, there is no point in a high dose chemotherapy and transplant.
Okay, but the common thought is, this was mature teratoma. I was just, no, not for this patient. I was just asking what are the options for chemotherapy. But the common thought is, when germ cell ovary recurs, necessitating chemotherapy, the outcome is bad compared to.
Yes.
Okay, so you do go for high dose chemo with stem cell rescue.
No, we never. We never do that actually. So most of the time we'll use a salvage regimen with that surgery. So that will be our approach mostly. So we are never transplanted.
Surgery is not always possible.
Not always possible. Not always possible at all.
Vinoda?
So usually recurrence usually gives salvage chemo. I think high dose chemotherapy with stem cell rescue.
Do give
finally a last resort.
Yeah, that's a last resort. Yes, sir. We go for conventional and yes. And the last resort, high dose chemotherapy.
Yeah, second line, there are plenty of chemotherapy use. We use, as I said, actually, second line chemotherapy, we have multiple regimens. So most of the time, after 3 years, we'll be able to use that and salvage them actually.
Yeah, for this particular patient, it is growing teratoma. I was just talking about a patient. And before we conclude, just 2 minutes left. So an interesting case from CMC Vellore, a 19-year-old girl who presented with an adnexal mass in July. Going back to her history, she had amenorrhea in March. That was some 6 months back. She had amenorrhea, and she had withdrawal bleeding initially. Then again another amenorrhea. She was having regular cycles since menarche at 11 years. But then for the recent last 6 months, she had periods of amenorrhea and scanty withdrawal bleeding. She was found to have an adnexal mass, and her secondary sexual characters were all well developed. Ultrasound showed an adnexal mass, and the investigation showed the AMH is done and it was 0.2. Other tumor markers were slightly elevated HCG, others were normal. And so she underwent surgery, right salpingo-oophorectomy or omentectomy. There was a parietic node also that was debulked. Uterus appeared small, and the adnexal mass is 10 into 12 centimeter. Left ovary also appeared small. There was a 1 into 1 centimeter aortocaval node. The frozen section was dysgerminoma. And so the final diagnosis was dysgerminoma with parietic nodal mets, and it came to be stage 3 A11. And finally, the patient went in for chemotherapy. She received EP 3 cycles. After chemo, she had periods of amenorrhea. So she underwent chemotherapy. She underwent karyotyping. She had FSH 90, and karyotyping showed a 46X with duplex X. The fish for Y chromosome was negative. So your comments on the case, Dr. Vinoda? Dysgerminoma in a Turner mosaic and Y chromosome is well known, but this is actually an unusual case.
So it's not Turner mosaic, it's almost like functional trisomy, like triple X. So this is very rare, and when I called up the genetist, he said, even if it is so, please do a fish for Y, which is more sensitive. So that was also negative. We had done the AMH initially not because to assess fertility, ovarian reserve, but because we thought of granulosa cell tumor considering a 1.5 year history. So now with this 46 functional trisomy X, now I have counseled the lady, counseled our nursing student, that if she continues to be amenorrheic, I'm not sure whether she had a germ cell tumor because of the underlying abnormal karyotype, and I've offered her oophorectomy if she continues to be amenorrheic.
Okay, so we have heard about dysgerminoma developing in gonadoblastoma with the Y chromosome. This is one without a Y chromosome with an extra X chromosome. Dr. Deepak, your comments, you have heard literature about this.
Madam, in the literature, this is one of those cases where it is kind of a functional kind of Turner, where you have an abnormal area in the X chromosome which has got duplicated. So, no ma'am, it's the X chromosomes, Q arms 26 to 27, that area.
One
that
X
gets
plus another X. It's a duplication.
on the X chromosome, madam, on
Plus
that
it,
particular area, it is duplicated, not the entire X chromosome.
Not the XI. So in one area, so there's 3 portions of it.
Yeah, but then it's effectively it's actually like 46XX, but that
One
X is actually abnormal. So these are those Turner variants where they'll be like normal phenotypic height, but then they can be going in for an ovarian failure as we are seeing in this patient. But the issue is whether to take out these ovaries without a Y chromosome presence. The presence of gonadoblastomas and later on dysgerminomas have been mentioned in certain rare case reports where these non-Y chromosome abnormal Turner variants can occur like in less than 1% with gonadoblastomas. There have been few cases where they have kept the patient on follow-up without any recurrences, and if only she recurs, but then you need to have a close follow-up because as soon as she develops a gonadoblastoma, that is more kind of an indolent kind of a tumor. Before that goes in for a dysgerminoma, you will have to excise it, or else you can also offer a prophylactic oophorectomy. Otherwise, either intraoperatively, if the ovaries were found to be dysgenetic, totally like fibrous streaks, then there could be another reason why you could be removing the ovaries. Here it was mentioned it was small, so but then that option has to be discussed in detail.
We had to tone down our words knowing that she's our nursing student. The way we put our operation notes also, we had to really be careful.
We have to be careful about documenting that ovary is atrophic and does more. Dr. Neetu, when do we routinely go for a karyotyping in germ cell tumors?
Ma'am, we don't usually
in a premenarchal girl.
Yeah, premenarchal it is all dysgenetic gonads. There is a chance of having germ cell tumors. So ideally, if you see every premenarchal,
when you suspect premenarchal,
you should be doing it.
Bilateral
but that
tumors
will come again 2 weeks later. By the time if they are coming with pain and all, we don't have.
Yeah, we don't have time.
But I don't know if we should do a bar body or something that will come in one day. I don't know.
Okay. So we conclude the cases here, and comments from the chair and. Yeah, definitely. If you're removing both ovaries, we'll keep the uterus, give HRT, and keep the uterus for further fertility.
Yes.
Thank you very much. It's a very, very nice talk. As a generalist, I do get, in medical college, Kalamashri, you get a lot of patients, and most of them can't afford most of the treatments that you have mentioned. Even karyotyping, we don't do in the anatomy department. So they come and they beg us, say, don't tell us to do it, and then again we send, again they come back. So that is the problem I am facing, that we cannot offer the best treatment to these patients because most of them can't afford. And recently, Dr. Fessy, I had a patient who had a surgery and she had a ovariotomy done, young lady around about 26, 27. And as soon as the ovary removed, the report came as germ cell tumor. It was dysgerminoma. She asked me when she could have a ovarian cryopreservation.
No, it is better to wait for 1 year post chemotherapy if you are having chemotherapy.
No, it was stage 1A, grade 1.
No
no
chemo.
chemo.
So I think no need for that. No need.
No. Yeah.
I mean, no, you have to see the AMH value. If the
AMH was 2.
2, I think no need to do
So
anything.
actually I said I think it's okay, but then I sent it to...
just like follow-up of that dysgerminoma, do the AMH also, and if you have facility, you can do the androgen follicle count also.
all these ladies go to the internet and they read everything. And as someone was telling me about the problem with dealing with laparoscopy, doctor, you were telling me that everyone wants a laparoscopy. Things have reached such a way that a 3rd degree prolapse came to me just last week and said, doctor, can you do it with the correlate? That is a tube. So I can imagine
They
what
are doing. They are called pelvic reconstruction surgeries, laparoscopic.
But
They are
that is
doing
not
it.
for the 3rd degree prolapse for the 72-year-old lady.
No, they are doing, ma'am. They are doing. I have seen.
Okay.
I have assisted.
I think I'll send them to you next time.
No, I don't do. I don't do. I
But
have
definitely
assisted.
I would not advise it for a
Pelvic
72-year-old
reconstruction
huge,
surgery, laparoscopic
huge ulcer.
managing pelvic 3rd degree prolapse.
Okay. So that lady, after the surgery was done and the report came as stage 1A, grade 1, I told the lady you only need follow-up. I sent her to Dr. Neeta for follow-up. We are fortunate that we have the RCR, the Cochin Cancer Center in the same compound. And then immediately she said, doctor, what is your opinion about freezing my oocytes? So
No,
I said, I don't
if
think
the
you
AMH
need
is good, no, we can counsel that we will monitor any time. If it is coming less only, we will do, or any chance of any recurrence. Otherwise, if they are worried, we can definitely go for, because even the routine ovarian stimulation can be done. No need for random start, and that is not going to anyhow affect the disease also. If they are concerned, we can do it. Lot of women have started coming compared to 5 years back, not related to this malignancy.
I think most of these celebrities have done
Yes.
it, so I think they read it and come.
And in US, some companies insist that when you give a big CEO job, they are advised that not
Yes,
to get
yes, I know.
pregnant. So
Oh.
they go for oocyte cryopreservation or embryo cryopreservation.
Another indication for cryopreservation.
So,
Okay.
That is known as social egg freezing. That is a word also is there.
So once she had the chemotherapy, we asked him to wait for 2 years before we asked.
No, 1 year.
1 year.
1 year.
1 year. Okay, thank you. Thank you so much.
That is just like when the AMH is less.
Yeah.
I think you have to, just one thing, we have to wait for 1 year. Just like poor ovarian response or like that patient, we can start giving higher doses with growth hormone. Just like that normal poor.
Yeah, some are trying this PRP, etc.
That is all not been proved, sir. And some people I know who have tried for a few cases of ultrasound guided PRP, they stop doing it because when you are doing so, you will be sometimes destroying the ovary also.
So thank you so much, panelists and chairpersons. Thank you very much.
Thank you all. It was an excellent presentation and good deliberation. We now move on to the next session. That's a panel discussion on low-grade serous ovarian cancer. We invite the chair. I would like to invite the chairpersons, Dr. Ajita Kumari, Dr. Georgie Joy Ravi, to come on stage. To moderate the session, I would like Dr. Chitradara to please be there for the session. And the panelists, Dr. Shalini Rajaram. Okay. Dr. Dr. Ajita Kumari is a senior consultant in the Department of Obs and Gynec, Rajagiri Hospital, and a professor and HOD from Government Medical College.
Dr. Georgie. He's professor and head Department of Obs and Gynec at Malangara Orthodox Syrian Church Medical College. Panelist Dr. Shalini. We've all had Dr. Shalini on stage and heard lots from her. Our professor at AIMS Rishikesh, Dr. Ayana Lekha Matthew. Senior consultant in the Department of Pathology, VPS Lakeshore Hospital. Dr. Rameshan CK. He's a gynecologist, gyne-oncologist. He's assistant professor in the Department of OBG, Government Medical College, Manjeri. Dr. Anu Susan George, consultant medical oncologist at VPS Lakeshore. Dr. Sanam, associate consultant and Department of Gynec-Oncology, VPS Lakeshore. Over to Chitradhara ma'am to start the session.
Good evening to all. Welcome to this panel section of low-grade serous tumors, carcinoma. So why I have selected this topic is it usually occurs in younger age group, and relative chemo resistance is there, and there is prolonged survival compared with its high-grade serous counterpart. And molecularly it is characterized by estrogen and progesterone receptor positivity, aberration in MAPK pathway, and wild-type TP53 expression pattern. So there is some definite guidelines for borderline tumors and also for high-grade tumors. But this area is, there is a gray area between this, that is low-grade tumors. And now I have told already that it occurs in younger age, but I am now presenting a older patient with this low-grade tumor. 72-year-old lady with complaints of abdominal distension and bloating sensation with a history of constipation since 2 years, aggravated over last 2 months. She has no comorbidities. She gives family history of brother having affected by colon carcinoma. So shall I start with Dr. Rameshan? So how will you investigate? So how will you proceed with the 72-year-old lady? With the bloating sensation, with the constipation, history of constipation since 2 years. Sure.
In the clinical history taking, we have to ask whether she has any symptoms pertaining to any GI symptoms, upper GI, lower GI symptoms. And in examination, we have to look for whether she has any evidence of distant metastasis like inguinal nodes, supraclavicular nodes, and whether she has any effusion on chest examination. After that, we will proceed with investigations to confirm our diagnosis.
Yeah, this is CA125 and CA routine, but should we do other markers, HE4 or 99 in these patients?
No, ma'am. I mean,
not required.
Not required, ma'am.
Because low specificity. And
other investigations like upper GI, lower GI endoscopy.
If CA is raised.
If CA is raised, or CA125 is disproportionately low.
Low. Okay.
If it is low.
So
and then imaging.
So regarding ultrasound, whether it is an extent of clinical examination. So all the patients we can go for an ultrasound.
Yes.
Isn't it?
Yes, ma'am. Yes, ma'am.
So then we will go for a CT.
Yes, a CT, chest, abdomen, and thorax. I mean, thorax, abdomen, pelvis, to know the extent of disease, and in the CT also we have to really look when there is bilateral adnexal masses and all. Whether we have to look in the stomach, then in the pancreatic area, colon. Is there any evidence of like whether it can be a secondary tumor also? We have to look for any other, other primaries also. So we have to look for whether it is whether it is operable, or is there any evidence of other primaries.
So this is the CT scan, and it showed bilateral adnexal masses with a loss of plane with rectum. Uterus was inseparable from the mass, and also deposits noted in the intersegmental fissure of liver and intracolic omentum. This is the CT. So in these cases, I am asking whether true cut biopsy is indicated, or in what situations you will advise a true cut biopsy. Dr. Shalini? Sure.
True cut, it depends on your PCI index. If you think it's an advanced cancer and you can't operate and you're not able to operate, then probably you would advise a true cut biopsy. Or do you want to go in for an upfront surgery? So basically on the PCI index and her other parameters like her albumin levels and because she's 72-year-old, other predictors of operability, only then we will go for a true cut biopsy. If you think now there is widespread upper abdominal spread, there is
so also if it is quite low in rectum, is it indicated if quite low in rectum and you think an colostomy is necessary?
Low-grade tumors, though they miss...
this is not low, because we haven't diagnosed it.
You haven't yet diagnosed, but then you don't know what it is then. Based on tumor markers, CA125 is normal or raised?
It's raised, both.
It is raised. So you're thinking in terms of an epithelial ovarian tumor. You don't know what is it. You don't know whether it's high grade or low grade at this point of time. But your imaging shows a higher PCI index, right? And then you think that she's not operable and you want to go ahead with chemo. If you want to go ahead with the neoadjuvant chemotherapy, then you would need to do a biopsy from one of the sites.
Another thing I forgot to tell is we have to assess the performance status, whether for more than a good 1 or 2 ECOG status or
albumin levels
formats or whatever is
Yeah, actually this is quite a big mass, and on examination it was filling the this pelvis. It appears to be filling the pelvis. So we have done a patient was also not willing for surgery. So we did a true cut biopsy. So and the IHC and true cut biopsy with the IHC was showing low grade serous carcinoma. So Dr. Iona, so whether should we go always for a true cut biopsy or FNAC is enough for a diagnosis? So should I show you the? Yes, the other.
So so when we are doing an FNAC, we are not sure whether the tumor is going to be high grade or low grade. So initially FNAC, if it's a high grade carcinoma, we can say very clearly on FNAC that's a high grade carcinoma. The problem comes when it's a serous neoplasm of low grade malignant features. That is where we we call it as a serous neoplasm with low grade cytology. So for FNAC is helpful in differentiating high grade carcinomas from low grade, but true cut would be preferred for SBT versus a low grade serous carcinoma. But again, true cut has its fair share of it's quite tricky to differentiate these two as well.
Yeah, you can do IHC from FNAC. Is it possible?
Yes, we can do IHC from FNACs. If in our institute we do it on the cell blocks which we get from the FNACs, and we're quite happy with the results.
Okay, so then how will you differentiate between borderline and low grade tumors? It's very difficult to differentiate between these two category of tumors, because the type of surgery or the fertility preserving for this patient is not that necessary, that indicated, but even then that the management differs between borderline and low grade tumor. So you should know whether it is borderline or a low grade tumor, definitely. So what is the difference?
But in this particular case, you're not thinking of a borderline tumor with such a widespread metastasis. So I don't think a borderline tumor would be classified with this in this particular patient.
This particular patient, it's not indicated.
I don't think you need to distinguish between. You need to distinguish between low grade and high grade, but not between borderline.
No, for the youngsters, for students, we have included this thing to differentiate between serous borderline tumor and low grade tumors. Because next is a young patient, but anyway we'll be telling at this time, Dr. Ayana will be telling at this time.
So the difference between serous borderline tumor, this is a non-invasive, low-grade proliferative serous epithelial neoplasm, whereas low-grade serous carcinomas are invasive serous neoplasms with low-grade malignant features. The criteria to differentiate is basically on architecture and demonstrating invasion, because both of them show low-grade cytological features and both of them have low mitosis. So the WHO says the essential criteria to diagnose SPT is there is epithelial proliferation with the papillary hierarchical branching or with micropapillary and cribiform subtypes. Whereas for low-grade carcinomas, serous carcinomas, there are invasive small nests, glands, papillae, micropapillae or inverted micropapillae, which frequently are seen floating within unlined clear spaces. Next slide.
Yeah. So this is, okay. This one?
Yeah.
SPT.
So this is a serous borderline tumor where you can see papillary hierarchical branching architecture, wherein you have these large papillae which break into smaller papillae and smallest papillae, and these are lined by epithelial cells which show stratification, but the nuclear atypia is mild. There is no stromal invasion. Now when
what is the difference between these two? SPT with microinvasion
so
and
when we have
microinvasive.
SPT with invasive foci, the most important thing is first we have to see the size of the invasive foci. If the invasive foci is less than 5 millimeter in greatest dimension in any one focus, we look at how the cells are infiltrating. If the cells are in nests and dispersed singly, less than 5 mm, these tumors are called as a serous borderline tumor with microinvasion. But if this microinvasive foci, which is again less than 5 mm, resembles that of a low-grade serous carcinoma morphology, these tumors are termed as serous borderline tumor with microinvasive low-grade serous carcinoma.
Also extra ovarian invasive implants. You will get.
Yeah.
Okay. But that is WHO classification.
In WHO 2020, they said any borderline tumor with invasion is a low-grade serous cancer. It wasn't that in WHO 2020?
If there
they
is
say once
invasion,
you have implants with a serous borderline ovarian tumor,
if
it
there is
becomes
invasive
low-grade
implants,
serous.
if there is an invasion,
If the implants are non-invasive, it's still borderline, no?
Yes. See the.
But
So I think
No,
Dr.
invasive implants.
extra ovarian invasive implants.
May I
So
say?
what she was explaining is primary ovarian tumor microinvasion, that is still borderline microinvasive. What you are saying is any invasive implant with. So no, that is different. Low grade. But what she explained is actually primary ovarian tumor with microinvasion within the.
That is the main thing. We've not come towards the
implants.
I was explaining the morphology of low-grade serous carcinoma.
This is this.
No, the previous one. Okay, fine. So the implants coming to is serous borderline implant. An implant is used in the context of extra-ovarian disease associated with serous borderline tumors of the ovary. And by definition, SBT implants are non-invasive. If there is invasion, a diagnosis of extra-ovarian low-grade serous carcinoma is to be made.
And this patient was not willing for surgery, and patient received 4 cycles of single agent carboplatin followed by 3 cycles of carboplatin and gemcitabine. On reassessment, patient CA120 was 80, that is, it was coming down and suggestive of status quo disease. Patient was kept on tablet tamoxifen and then changed to letrozole, because it was initially it was showing a reduction in tumor marker values. But later on, the patient was reevaluated after 2-3 months with SECT, and there is increase in size of soft tissue deposits as compared to previous scan. Patient was referred to surgical oncology, and same thing, the same findings were there. So we have discussed with the patient, and lot of counseling was done, and patient was taken for surgery. Intraoperatively, predominantly solid mass inseparable from uterus, encasing rectosigmoid. So we have done extensive surgery with rectosigmoid resection, ureteric resection and reimplantation, and a covering colostomy was done. And when left ureteroneocystostomy and bilateral stenting were also done. And postoperative was a very stormy postoperative period, and peropop also patient went into extreme hypotension. For these reasons only we usually get a true cut when there is the mass is very huge filling the pelvis, and we usually go for a true cut biopsy to see whether it is chemosensitive. If it's a high grade, we can go for chemotherapy and reduce the morbidity, peroperative and postoperative morbidity. And this was the reduction in the, yeah. But this came as low grade tumor. Deposit. Yeah. It was not mucinous. CEA was normal. CA 120 was high. This was initially 103, later on it reduced to 55, then on tamoxifen it was reducing, then again it was going high, for 98, 106, that time only we did the surgery, then it came down. And then whether tamoxifen or letrozole is effective, any evidence, Dr. Annu, whether which is more effective drug for...
Can I just say one thing? One thing to the house, that low-grade serous cancers also present at stage 3 and stage 4, and they are quite infiltrating. In fact, they're called destructive infiltration. They're not limited to the surface of the peritoneum. It's easier to operate on a high-grade serous cancer. Low-grade serous cancers, though biologically it is low-grade. They have KIS 67 or maybe 10%. They have very few mitosis, but they behave much more differently. It's much more difficult to tackle these patients. That's why you saw the extensive surgery she had to do, even though it's called a low-grade serous cancer. So don't go back. The oncologists would know, but the general gynecologist should not go back with the thought that low-grade serous cancers, they survive. They will do surgeries, but you have to do extensive surgeries. You might have to do colostomies. You have to do LAR. But they survive. The survival is better. But the way they present and the way you have to operate on them, the low-grade serous I have operated on too, were not easier than high-grade serous cancers.
Good
so
point.
That's one thing that I want to go back. Though and surgery probably is a better modality. But I wanted to know why you all gave only carboplatin and not paclitaxel.
No, that is in fact what you're saying is quite right. I quite agree with you on that. And in fact, it's better to have a high-grade disease than to have a low-grade disease, because but then again, if you do a good surgery for low-grade disease, you can do several surgeries. There are a few patients I can count on my fingers who are low-grade, and we have operated on them repeatedly, again and again and again.
No, but we have very bad cases that come to us also with RVFs, with ureters transected, with a low-grade etiology, low-grade serous cancer. We have 23-year-olds, 25 years old being operated outside. The surgery probably not complete, or they were offered fertility sparing when there was widespread disease, things like that. So we have to be very careful with low-grade. We don't encounter them so much, but when you encounter them, and especially if they're operated outside, you do have trouble. I have 2 or 3 such patients waiting who were operated outside with a low-grade serous etiology, but they are now with ascites, with widespread disease. One has an RVF, and a lot of problems. So I just want the house to know that pathologically, biologically, they may be, they're low-grade. But the way they behave
behavior
is as bad as high-grade. I would prefer high-grade cancers.
But for the patient, probably low-grade is much better than
They survive, but a lot of morbidity.
But advanced disease should not be there. But
just one thing.
Once you
advanced stages, their outcomes are as bad as high grade.
And they are seen in 3 and 4.
Right.
Except younger ones. Younger ones may be seen early.
Only they have to accept the morbidity of the surgery. Sometimes we may lose the patient. That is.
Ma'am, if this patient was young and willing for surgery.
No, 72-year-old.
I was thinking, just saying, if the patient was young and willing for surgery, even if we could not achieve a complete cytoreduction, is it possible to do some kind of cytoreduction as the tumor is not much chemosensitive? I mean, whatever is possible.
You have to do complete cytoreduction because whatever you leave will grow back again because they're not chemosensitive.
Yeah, but
so
this big load and small load, like does
even
it make
if
a
it is
difference?
less than 1 centimeter,
they will recur.
But 1 centimeter is enough, they are telling. In literature, they are telling even if you can cytoreduce to less than 1 centimeter, not microscopic, that is enough for low grade.
So we have seen that this patient didn't respond to for chemotherapy at all.
Two questions. One is ma'am's question about why we didn't give chemotherapy. I mean, why we gave chemotherapy only carboplatin. The patient is a little elderly.
Initially carboplatin, then later on.
Yeah, then later we added gemcitabine. So the patient is elderly, 72 years, and I think she might have multiple comorbidities also. So probably paclitaxel adding it would not have been very safe in this patient. So usually what we do is in elderly patients we try with initially carboplatin.
Not the weekly ones, the MITO7 regimes.
No, MITO7 is probably we could use, but I'm not sure. I think she probably had some neuropathy or issues would have been there. That's why we generally start with single agent carboplatin and see the response. And if it's not really responding, then we add the second agent. And more than paclitaxel, probably gemcitabine was chosen for this patient because of her comorbidities. Then the second part about tamoxifen and letrozole, most of the evidence that we have in low grade is retrospective evidence, because it's a very small cohort of patients that we have. We don't have large studies. So most of it is retrospective evidence, and there is no head-to-head comparison between letrozole and tamoxifen in any studies. But there is one GOG 281, which is for trametinib, second-line trametinib. In that, the other choices were between paclitaxel, pegylated liposomal doxorubicin, and tamoxifen letrozole. In that, tamoxifen showed only 0% response rate, while letrozole showed actually 16% of response. So that kind of gives us an indication that probably letrozole may be a better choice.
This patient pegylated doxorubicin
that did not show much of a response.
They have a better response.
No, in this particular study, it didn't show a response, but there are other studies where pegylated liposomal doxorubicin was showing a response. But this one, even PEG doxorubicin showed lower response.
This patient also showed response to letrozole, not to tamoxifen. Next presentation.
So there is actually no data about how long it's actually given maintenance letrozole. So we don't have any, but what we can do is we can actually compare it. It's similar to breast cancers, hormone-positive breast cancers, and these have almost a similar biology or actually a similar course or prognosis. So there is no real evidence about how long you should give adjuvant or maintenance of letrozole, but then these patients usually come back with disease pretty soon. Yeah. Again, I think we cannot extrapolate from the data. I don't know if we can extrapolate from the data of breast and give it like 5 years or 10 years. There's no such limit over here. Then it depends upon whether the comorbidities of letrozole or anything like that, and the patient is having a stable disease or.
Any experience with
CDK4/6
inhibitors?
Yeah, that is there are a couple of trials.
There is a
couple of
study
trials
published.
coming up with that. One is in the neoadjuvant setting also. We have combination of fulvestrant plus abemaciclib. So that is having, it's I think still recruiting and showing some response. The one with palbociclib failed in the second line, that failed. But ribociclib is showing some data. So because these tumors also, like I said, similar behavior to hormone-positive breast cancer. So that is another agent that is showing promise. So with ribociclib,
there are several trials, ongoing trials. We are still recruiting.
They are
and
still
I don't think
recruiting.
we'll get
The one with
results.
palbociclib, it failed, but the ribociclib one is showing
It's showing
benefit.
It was published. I think there is better response
Yeah,
compared
it's showing
to
clinical benefit is there in ribociclib.
Yeah, in fact, some medical oncologists, they start letrozole along with the chemotherapy.
Yes. As maintenance, I think they're giving.
No, maintenance is different.
after
Maintenance is
using
after you have finished with the chemotherapy. But there are some who give it along with the chemotherapy as well.
Shall I go to the next case? This is probably a more interesting one. A 23-year-old presented with vague abdominal pain and bloating sensations since 8 months. She was initially evaluated in North Kerala. So Sanam, how will we proceed with this patient? Very young patient. What are the investigation from previous lectures? Anything we have missed? The investigations.
23-year-old with the abdominal pain and discomfort. So other no menstrual complaints, cycles are regular, all those things are there. So initially, when all this abdominal discomfort comes, first we think of GE causes, so all gastrointestinal causes that has to be ruled out. And As always, initial on examination history and all those things has to go as normal. Then baseline ultrasound might help us to at least localize what is the pathology or what are we dealing with probably, whether it's an ovarian cause or something else that is causing her the complaints.
So then we did all the tumor markers because she's younger than 40 years. So we did all.
Yeah, when it is an ovarian mass, when it comes to younger than 40 years or 23 years, we have to consider all the germ cell tumor markers also. Other than CA125 CEA, we have to do AFP, beta HCG, LDH.
All were within normal limits, and CA125 was elevated to 200 units per ml. All other were. CT abdomen showed 8 into 9.2 into 10 centimeter defined heterogeneous enhancing solid and cystic lesion in both adnexia. Both ovaries not visualized separately. So likely neoplastic etiology, moderate ascites associated peritoneal thickening near pelvis and minimal omental fat standing. So in the differential diagnosis, what all things we should think of in the differential diagnosis? Dr. Ramesh, should we go for some other usual 22-year-old age group, because for these PGs we are talking about. So what are the usual differential diagnosis and what are the investigation? These investigations are enough for 23-year-old. So AMH and all, whether it is indicated or not, because previously people are telling AMH is indicated.
This patient, it's a bilateral adnexal mass, so we may not be able to preserve the ovaries, I guess.
But we don't know whether it is borderline low grade or high grade. So
we have to give them an option like doing a cystectomy on one, which is smaller one, cystectomy on the smaller side, and removing the totally solid other ovary, or do cystectomy on both sides. I mean, these are options to be discussed with the patient.
So should we go for to cut for this patient also? So we can decide whether we can counsel the patient better. So 22-year-old lady should be, but I would like to get opinion of everybody whether we have to go for to cut in the younger age group.
I mean, if surgery, this patient needs a surgery, so I don't think.
Should we go for because we have to counsel her, so whether to take out both ovaries.
The imaging findings have shown just confined to the ovaries and nothing else, nowhere else.
Ascites or mental stranting.
She had ascites and she has omental caking also.
Yes. At least we can do ascitic fluid or cytology or omental biopsy, anything, because we have to surely counsel the patient. So if we get a diagnosis, so this patient under a PET CT also metabolically active lesions involving both adnexia, multiple soft tissue deposits in the pelvis and peritoneal nodulati, and gross ascites.
So it's I think now it's an advance. It's not just confined to one ovary or both ovaries. There is spread to the peritoneum. There is gross ascites. So
should we go for PET CT also younger age group? With a little more advanced,
You went for it, so you have this. I don't know if he would go for it,
because
but
these patients
I would have probably done an MRI, MRI.
These highly educated patients, they will be asking this thing, that thing, and all the genetic testing.
Now you've got more information now. So
and
with more information, I think you will have to go with whatever information you've got now. And I think it's no longer confined to the ovaries alone.
Yeah, both adnexia involved. Should I undergo bilateral oophorectomy? All these things patient will be asking initially itself.
Right.
So can I
mean,
preserve one ovary?
If we don't have frozen biopsy, then it is very difficult to make a decision.
No. Why don't you just do a biopsy from the soft tissue deposits and close the issue?
Yeah, we
did soft tissue deposits. A lot of soft tissue deposits.
So we did a to-cut biopsy. So it has turned out to be low-grade serous papillary carcinoma. So to pathology, Dr. Iona, should we do any other markers in this age group to rule out even any other
biopsy of the
because
biopsy
it
was
is
taken from
biopsy,
the ovary, or was the biopsy taken from the ovary or from
usually they take from the omentum.
Omentum, yeah. So if it is the omentum, see, serous carcinomas have a distinct morphology, low grade, but the other thing which we have to exclude is a mesothelioma. If you've taken it from the omentum. If it's from the ovarian thing, we actually will
So
do
with this-
there are distinct. It has a distinct. Even if we do IHC, WT1, Paxate, and all will be positive. Now, if it is positive, there's no need to go ahead and think of a germ cell neoplasm from if the biopsies are from the ovary. But in case WT1, Paxate, and all don't help, then probably we'll do the germ cell. But it has to be done
minimum IHCs. Will you do minimum IHCs to diagnose this on true biopsy?
Yeah, we do minimum IHC.
So what
we
are
do,
they?
we do
Minimum
WT1, Paxate, and we'll do a P53.
Okay, yeah.
That's the minimum. Yeah, we can do ERPR, yeah.
This is already, you have already told, and WHO defined ovarian tumor. So patient and bystanders were counseled. It was a difficult task, and she underwent fertility sparing surgery, RSO, with the left ovarian cystectomy, total omentectomy, excision of all those things we did, and intraoperative findings. The cystectomy was done. Only there was a cyst in the other ovary, so cystectomy was done. So preserved the ovary. And this was the peroperative. Yeah.
But she had peritoneal deposits and other things.
She was actually they were not willing. So I thought we thought we'll do it later on, but only mainly it was restricted to pelvis and some of this. But this was the picture. When I saw this picture, that is why I preserved the opposite ovary, because it is typically suggestive of borderline tumors. So
what was the frozen section?
Frozen section, and they have reported it as they did not tell it is borderline or this thing, because we already had a low grade biopsy, so we did not ask for that.
Frozen section, once you have a
report is there. So anyway, I have got very little time to do these things. Post-operatively, anyway, patient received 6 cycles chemotherapy. Now the tumor markers came down to 4. And now what next? To take out the remaining ovary, what is the role of fertility preservation in low-grade serous tumor? And the report is majority are borderline, but there is a small area of low-grade tumor is there. Majority tumor is borderline.
See, we have to treat the higher pathology, right? And I think you can put the patient on letrozole, and definitely there is role for removing the other ovary. I mean, there's no excuse why we are not removing. You should counsel the patients and attendants and get a signature that they are not willing for.
So should we go along with the letrozole, LHRH agonist also along with letrozole?
The receptor status.
Patient is waiting now with
receptor status is done. ERPR
ERPR positive. Positive.
Then I think.
What about
BRCA BRCA1 is negative.
Okay, BRCA is usually in this group of patients.
I'm
BRCA
telling
is usually negative,
to
only less than
differentiate between
5%,
these
yeah.
high grade, whether some chance it is there or not, we have done BRCA,
So the
because it
patient
is indicated also.
Because if fertility sparing surgery has been done, I think we can go in for the LHR agonist plus letrozole if the patient wants to preserve the ovary.
What about oocyte preservation and all at this point of time before you go on to, you're going to do or no?
Oocyte preservation they are asking, but we have to wait 1 year. No? Now patient received chemotherapy, so we cannot do it. So what anything, Dr. Ramesh? Yeah. Yeah. Yeah, every visit we are doing now. Now it is 6 months, but whether should we insist the patient to undergo oophorectomy because she is not willing also. She is roaming around with fiancé and she's not coming. That is already conveyed, but
I mean, this all depends on if the patient says like, I mean, that is what, then that's what we have to do.
No, it doesn't depend on the patient. It depends on you. You have to counsel
If the
properly.
patient doesn't want it, you can't remove it, even if it is
No,
this
I
ovarian
said
cyst now.
no. I'm not
No, I
talking
just
of
want
that.
to
I'm
tell
talking
one
of doing oocyte preservation from that ovary, diseased ovary.
I just
Yeah,
want
don't
to project this. Compared with stage 1 disease treated conservatively, the risk of recurrence is increased after conservative treatment of more advanced stages. This is regarding BOT, but they have mentioned little one sentence in in the lower part. These could be ovarian or peritoneal and not so related to the ovarian preservation itself, but to the natural history of the initial peritoneal spread. Furthermore, the risk of lethal outcome is rare in this context if a complete resection of implants is achieved. Fertility preservation could be then considered in selected case of stage 2 and 3 BOT. BOT. Some authors have suggested to extend this strategy even in case of invasive implants. However, fewer than 15 cases have been reported. Even though, otherwise invasive implants should call it as a low grade, no? But here they are telling they've extended, but they cannot, because whatever is natural depends on natural history, whether we preserve or not, the recurrence may not affect the outcome.
The only thing is many times invasive implants are diagnosed only on microscopic examination, and you might not necessarily be able to see them or feel them or whatever else in a what looks like a normal omentum.
Actually, I had so many things to ask. And all. Are we ready to move the needles away from low-grade serous tumor? One or two sentences, then we can.
What do you mean by that? What do you mean by move the needle from LGCS?
That means chemotherapy, and we will be giving targeted therapy or letrozole.
With the upcoming data, there are a lot of options coming up. Trametinib might
so because it is not that chemosensitive,
no,
people are thinking about that line.
So we're just extrapolating the data. Till now, we were just extrapolating from high grade because we didn't have anything better to do. But now we have so many options, like trametinib is there. It's now in the second line, can come into the front line. Then we have other targets of BRAF inhibitors are coming up. Then CDK4/6 inhibitors are coming up. Bevacizumab is also having some response rates. So all of these newer modalities of treatment are there, which are having a better response rates than chemotherapy. So the future seems probably we might be able to, because anyway it's a chemo-resistant tumor. So options are coming up.
So it is research is going on.
Research
probably
going on.
Soon we will be removing chemotherapy or needles
away
from the patients. So thank you so much. And another thing is genetic studies indicated at the diagnosis even for low-grade tumors, isn't it?
It is indicated according to the guideline.
Even somatic tumor, this thing, genetic panel is
but
also
the yield may not be there. It's less
yeah.
than 5%. While it's 15% for the others. BRCA is only less than 5% of low grades.
So I thank all the any from the chairpersons, any comments from the chairpersons?
It's a wonderful discussion which we had with the moderator and panelists, and wonderful interaction from the audience. I think the take home would be optimal cytoreduction with good counseling and probably off needles with letrozole. That is what a general gynae could understand from this.
Okay, thank you.
I hope everyone agrees with that. Thank you.
Thank you, chairpersons. Thank you, the panelists.
Good cases, and I think it's open for thought, and a lot of research needs to be done in this field for treatment, especially because at high grade we understand and we know what treatment, and there are the lives extending. But low grade is an area which is really bad on the table. But pathologically they are very good.
But the problem is that
I just want to say, don't beat up your pathologist if they are not able to diagnose a serous borderline and a low-grade serous, because some, especially on true cuts, it's genuinely sometimes very tricky and very difficult. So that's it.
We don't want to beat you up here. We're saying even the finalist of pathology, you should be able to tell us. It's the FNAC and this thing. Yeah.
The newer modalities of treatment, they are also having the side effects, because trametinib is also having a lot of side effects like anemia, hypertension. So it's not going to be a completely smooth thing, but probably lesser than chemotherapy.
But the only thing, they keep having surgeries and they live, and they keep having surgeries and they live. The morbidity is there, but they live for a long time. The survivals are good.
They may die of the other complications of surgery probably. Yeah, treatment.
But it is locally destructive. What they say that it is locally destructive.
Targeted therapy will be trying probably in future with the recent or the results of recent trials. Okay.
Thank you, Dr. Chitra.
Thank you all for the highly interactive session.
Next, we have an equally interesting session, which is a debate, Battle of the Approaches in Advanced Ovarian Cancer. We invite the chairpersons, Professor P.K. Shekaran, who needs no introduction to this audience, Dr. Emma P., who is the professor and head of the Department of Gynae Oncology, RCC, and Dr. Anupama S. She is associate consultant in VPS Lakeshore, Gynae oncologist. She has completed an AGOI fellowship in Gynae oncology, and her special interests include minimal access surgery. This is a star program, actually. In favor of neoadjuvant chemotherapy, we have Dr. Arun R. Warrior, who is a medical consultant at Aster MIMS. And in favor of primary debulking surgery, Professor U.D. Bafna, former professor and head of the department, Kidwai Memorial, Bangalore. So the first speaker will be Dr. Arun R. Warrior.
Good evening to all. So first, we are not going to have a debate. That's what both of us agreed, because we know each will have its own merits and demerits. We are all aware of that. So we'll be just trying to highlight what are the advantages of each modality, neoadjuvant and primary surgery. So can we have the slides? So I think today we have been speaking for the last couple of hours about ovarian cancer and how to improve. Because whatever we talk, it's finally the systemic failure which happens. So almost 70% of females relapse, and we feel quite sad because any patient coming with ovarian cancer as a medical oncologist, we like to treat because they have very good response. So when we give the first shot of chemo, the ascites goes away, they are happy, the pain comes down, and after 6 cycles, the lady who came with 5 liters of fluid will think that they are cured, and there will be a lot of positiveness, and hope will be there. But we know in our back of our mind that almost everyone is going to relapse in the next 3 years. So that part nowadays now people know more. So like they have been talking about Google and all, they will read up and come back. And we somehow keep that thing somehow in the back of mind and talk to them and counsel them. So definitely we have to think more about systemic therapy. That's what medical oncologists or the systemic scientists are doing. So 5-year survival, we have to improve. And this is from the US. I think India also, it's almost similar. We know that the incidence is going up from 2 per 1 lakh to, in most of the Indian districts, are more than 10. So definitely that we are seeing here. And the prevalence is going up. The mortality is coming down. Maybe better treatment modalities are there, and we have some more targeted therapies are all helping that. But we are nowhere near a cure for ovarian cancer as of today. So a lot of things have to be done. So as gynecologists, all of you are focusing on the surgical aspects. Definitely it is important to achieve a complete response. But afterwards, the problem in any solid tumors, or particularly so in ovary, is that there will be some tumors will be there. Something we call as a minimal residual disease will be there. And after that, 2 things can happen. The body can take care of that, or maybe we may have to give some drugs for that, and we may be able to achieve a cure. On the other side, what happens invariably in ovarian cancer is that they relapse after some period of time. So whether to target this by doing a proper profiling of the tumors, and so that we can improve outcomes, that's the question. So systemic options in neoadjuvant, definitely chemotherapy. In the last maybe 30 years, chemotherapy is there. So in the IV chemotherapy is what most of us practice. Dose dense is there, but still not used commonly. Intraperitoneal has got its own role. And we have the option of giving bevacizumab, a HIPEC, and also PARP inhibitor. So this will be the main 4 areas where the systemic options are there in a neoadjuvant setting. So ESMO, if in 2023, what is there is that's why there is no debate here, because if there is a possibility of a cytoreduction, then you have to go for cytoreductive surgery. If it is not there, then we have to go for the other modalities. That's where the BRCA and all the other things come up there in a neoadjuvant setting. So that is how it is. And over the last 50 years, definitely the cures have improved from 15%, now almost 50% survival of 5-year survival we can achieve. That is because of chemotherapy drugs. But unfortunately, chemotherapy has reached a plateau. There are no new drugs which are being tried in chemo. That is a cytotoxic chemotherapy, no new drugs are being tried. So we have to think further, that's why. So in 1970, starting from single-line cyclophosphamide, Then came cisplatin. So platinum has been remaining maybe for the last 50 years. Various permutation combination has been tried. Like if you see here, the cisplatin, then which platin, whether cisplatin or carboplatin, then they told that if you give carboplatin, it is more tolerable and you are getting good response rate. So we can give carbo also. Then there was maybe 10-year time where the third drug was tried. Adriamycin was given, topotecan was added, and adriamycin they took out. So various things they tried. So maybe for the last 2006 onwards, last 10 to 15 is clear, paclitaxel. So things are very easy for a medical oncologist what to give, paclitaxel, that's all. So and then the dose strengths like Mito 7 and all came, but it is more intensive, like we are giving on a weekly basis the drugs. But then again the toxicities were higher, the peripheral neuropathy part was an issue, so and various trials did not show any gradient. So that's why it is remaining almost the same. And the intraperitoneal also, a lot of hype was there. The GOG, multiple trials were there. So it will come later. So, so that is all about chemo. I don't think paclitaxel we need to discuss much because it's standard for a long time, and I'm not going to the trials which showed that. So that is there. So intraperitoneal, I think there is a lot of interest is there. Maybe for the last 10 years it is there. It makes sense because the largest volume of the disease in the peritoneal cavity. For some reason, we are not able to eradicate all because again patients ask us, everything has been removed, doctor, then why it comes back again in the abdomen? So that's a very difficult thing for them and for us also. So that is why this intraperitoneal things were tried. So pharmacological data also shows that compared to IV, the IP has got a higher concentration there. All the drugs which are using Pacli, Carbo, all have got a higher concentration in when we insert it directly. So drug clearance are also significantly slower. So that's a very good rationale was there. But again, various trials like GOG 114 and 172 again showed that there is not much of a gain, but then people who respond, then the extends beyond 10 years and survival improves with an increasing number of IP cycles delivered. So these were some the things which came out, but there was not much advantage. That's just not, and even I have tried in various centers, we have tried that, and all of us have tried to put catheters in 2010 and all, putting a catheter. It's a very cumbersome procedure to put a catheter, instill the drug, patients have a lot of problems, and then you have to remove it. So I think it is almost gone out of work. I don't think anyone really practices intraperitoneal nowadays. But again, as recent 2019 also, there was GOG 252 which updated that the duration of PFS was not significantly increased with either IP regimen, because here they combined bevacizumab also. So they tried Pacli with Carbo, but then again it did not show any much advantage. So I think it's almost over. The era of intraperitoneal is, or we can tell it's almost over. Like practically also we are not seeing anything for the last 10 years. And OV21 or Petroc was one thing which had to be closed down, which was a good one, which provided some data, but again it had to close because of the poor accrual and some funding issues and all. So that I think it's almost done. Then now I think HIPEC, lot of interest is there. As surgical and gynecologists, you will be knowing. But I will just about neoadjuvant, what is the importance. So I think 2018, that is where this the Dutch trial came, where the good number of cases were there. To standard arm without HIPEC or HIPEC with cisplatin. So it showed that in the HIPEC, the median was 14.2 months of recurrent-free survival, while in overall survival also was maybe 10 months improvement was here. We have a lot of randomized control trials in the last maybe 5 to 6 years, which showed just this, which one showed before had a positive PFS and an overall survival which was positive. So that because of this reason it's not there, but then again we have from India also from the peritoneal malignancy group which is active. They have their Indian HIPEC registry of around 1,500 patients were published recently. So these slides were provided by Dr. Swamshekhar from Bangalore. So will be so he has told that they have tried, and the main problem which everyone was worried whether it was toxicity was more or not. So at least in that part the morbidity and mortality were comparable. And the median PFS actually in the interval, they had two groups of interval and primary. So in this arm of Dr. Swamshekhar's group in India, so they showed that the upfront group had a slightly improved PFS, which was not reflected in the other centers. So that is the data here. So it's a very upcoming thing, and a lot of activities being done in this area of interval HIPEC. In Astro also we have tried for some of the patients, and what my surgical oncology colleagues are telling is that they're able to do that, and we have to correctly select the patient. That's what and as medical oncologists we see them after the HIPEC, and what you've seen is that there is some amount of more myelosuppression is more with them. Because when we again give them adjuvant chemotherapy, they are having problems with marrow recovery. So because a good dose of cisplatin is being instilled. So that is the practical thing which we are seeing with a interval HIPEC. So conclusions in HIPEC is very clear. In relapse there is no data, and in primary also no data, unclear data. So this is what the ESMO says. And for interval surgery, so that's why I brought out the Indian some data also where they have tried, and it is possible, but you have to correct. And the strong recommendation for the ESMO says is that it should not be used outside of a randomized trial. So it individualized. Now coming to bevacizumab is again commonly used in ovarian cancer. As medical oncologists, we don't prefer giving it in upfront setting, although ICON 7 and the GOG 0218, they were all reported maybe more than 10 years back. But still I feel in the practice we are not using it so commonly because we have to give 6 weeks gap before and after the surgery. So if you are doing an interval cytoreductive surgery, then it is not easy, and the chance of bleeding is there. And we all feel that we are getting good responses with chemo, so why to give bevacizumab? Although in a relapse setting, all of us are using that, where it helps to control because being an anti-angiogenic molecule, definitely the control of ascites is much better when we give bevacizumab. So that was there, and this was in a neoadjuvant setting. They have tried that, and after that they have followed it up with the bevacizumab also. So here again, various trials were there, published trials in the last few years, which showed that surgical resection in the arm given bevacizumab and the other arm, there was not much of a change was there. The PFS also remained the same, and it was not a big, the numbers were also not very high. So that is why even if you see the ESMO guidelines, it is an option, but I think practically we are not using that in an upfront setting at least. Now Dr. Anupama morning, she discussed about the targeted therapy and the ovarian cancer. So as medical oncologist, I think we are aware of a lot of molecular alterations which are there in ovarian cancer, but the problem is which one can be targeted is the issue. So neoadjuvant PARP inhibitors have been tried. So neoadjuvant PARP inhibitors showed that if there is germline mutation, there is around the responses are better compared to the other group, and even pathological complete responses can be seen. So definitely neoadjuvant PARP inhibitors like their BRCA, so that their response to chemo and the PARP inhibitors will be better. So that is a known thing. But it is not just the BRCA, but there are various other alterations are also there. So again, they have tried in the neoadjuvant chemotherapy IDS group whether these targets were there or not. They have analyzed. And as of now, I think the next talk is about HRR, so they may speak more about that. But as of today, the predictive and prognostic role of molecular alterations in HRR genes need to be further evaluated. So they are also upcoming thing. Now immunotherapy, so this is about immunotherapy. So what we do, because it is coming up in most of the cancers nowadays. So it looks very simple. We are just giving something to block the PD-L1, and once a PD-L1 or PD-1 is blocked, then the T cells are free to attack the cancer cells. So that's all. So we are giving something to block these molecules, and once we are able to block these ligands, then the T cells can attack the cells. So that is a rationale for immunotherapy. In ovarian cancer also, it is not just the checkpoint inhibitors, but lot of other molecules. That is what we call as the tumor microenvironment, tumor infiltrating lymphocytes, all are there. But particularly in a neoadjuvant setting, how is it important? Because in many, like in lung cancers and all, in an easy way, the chemotherapy makes it more tastier for the immunotherapy to act. That's what they tell, because it somehow stimulates the immune system, and because of that, the effect of checkpoint inhibitors will be more. So this is all the various molecules which are upgraded and all. And systemically, all the inflammatory cytokines were raised after neoadjuvant chemotherapy. So there is a rationale for combining. And it's not just in ovarian cancer. We do this in lung cancers, where even radiation is also being given upfront, so that the immune system is better activated. So strong rationale is there, and people are trying that. So there's an activation of immune cells which happens, and after that the surgery can be done. And the good thing here is that the immune cells attack the remaining ovarian cancers also, and there is something called as an immune memory happens for the cells, so that's why it can be prolonged for a long period of time. So that is a very interesting area. The concept was very interesting, but then the trials we expected good outcomes, but it was released maybe some time back, in which they are combined. It was a combination of routine paclitaxel plus atezolizumab. So atezolizumab is used in hepatocellular carcinomas, lung cancers, and all. We use this drug, and after that they underwent the interval debulking surgery. So the optimal cytoreduction of almost 86% could be achieved. R0 in 53 and R1 in 33%. So there were no new safety signals, but the responses, or if you look at the real advantages, were not high. So that is why it didn't come into recommendation stage. they try to understand whether, because they are all costly drugs, whether there were any specific tumor or blood biomarker, but then they also could not be identified. But definitely that seem to have a synergistic load which is applicable for many cancers. And again, combination of immunotherapy plus bevacizumab. So we are talking about chemo, immuno. Now whether this immuno and bev also can be combined, because there is an increased proliferation of the vascular endothelial growth factors. So whether we can combine both is again a hot area of debate. So immunotherapy is definitely going to create a lot of noise in the future, because that's what you've seen in many of the solid tumors also. Somehow in ovary we are not able to target it, that's what. So that's why a lot of trials are being done. I have 1 minute more, so anyway. They're combining immuno plus PARP inhibitors, cancer vaccines. Most of these trials are in the recruiting phase, and we may see some good results in the coming 1 or 2 years' time. So in the last 30 years, a lot of things have happened, changes have happened. So systemic chemotherapy has become stronger, and I feel that it may become more strong in the time to come. So it definitely requires a teamwork. So definitely the contribution of a surgical gynecologist is important. So where we can think of newer ideas and newer things to optimize the cure for such patients. Thank you.
Thank you, Dr. Arun. Dr. Bafna will be now discussing on primary debulking surgery and giving his valuable inputs on this. Okay.
Good evening. So I'll be speaking mainly on the role of primary debulking surgery versus interval debulking surgery. Can I have the first slide? So as we all of us know, surgery is the main modality of treatment for primary epithelial ovarian cancer, and the main most important prognostic factor is no gross residual disease. And chemotherapy and molecular treatment is mainly adjuvant. Most important thing is good surgery. Okay? Chemotherapy, molecular treatment, all just adjuvant or adjunctive modality. Okay, so we have 2 choices for advanced ovarian cancer: do primary surgery and then give 6 cycles of chemotherapy. That is the gold standard. Okay, or if you are not confident, then you can give 3 cycles of chemotherapy. Then you can do interval debulking surgery and chemo 3 cycles. But this is not standard. This is done only when optimal cyto reduction is unlikely, or patient's condition is not satisfactory to permit a good surgery. So recent data has thrown some challenges, whether we can offer neoadjuvant chemotherapy for all the advanced cancer patients. Should we routinely give chemotherapy first and then do surgery to make it much easier? So now what are the guidelines? NCCN guidelines, if you look at the NCCN guidelines before the year 2012, it was not recommended. Neoadjuvant chemotherapy was not recommended. And after the publication of the neoadjuvant chemotherapy trial, EORTC trial, NCCN guideline 2012, again they have not changed the guidelines. Therapeutic benefit remains controversial. Therapeutic benefit of neoadjuvant chemotherapy remains controversial because this trial, the overall survival were very low, 29 to 30 months only. Okay, for primary debulking surgery versus interval debulking surgery, which was much less compared to 50 months, which was reported in non-randomized studies, in randomized studies in USA. Okay, trial was, the overall survival was very low. So it did not become a standard of care. Interval debulking surgery did not become a standard of care. Again now, recent NCCN guidelines. Again, guidelines remain largely unchanged. So again, what is recommended is primary surgery followed by platinum-based chemotherapy, standard of care. NACT should be considered for poor surgical risk candidates or for low likelihood of optimal cytoreduction. So not that you should not give neoadjuvant chemotherapy, but it should be limited. You should not go on giving it to all the patients with advanced ovarian cancer. So now, both are useful. Primary surgery is useful, interval debulking surgery is useful. There's no debate about this issue. We should ask different questions now. How to accurately choose patients for primary debulking surgery versus interval debulking surgery? And what are the advantages of primary debulking surgery or interval debulking surgery? Second question we should ask is now, is it possible to safely improve optimal debulking rates during primary surgery itself in advanced ovarian cancer? And third, how to interpret all this published data on primary debulking surgery versus interval debulking surgery? That means, why is that despite having double the number of patients having optimal debulking after interval debulking surgery, PFS and overall survival are not improved. Interval debulking surgery, you look at the data, the optimal resection rates are increased tremendously by double, but it doesn't translate into improved PFS and overall survival. Why is that? And one important thing I think which is not asked is how many cycles should be given before interval debulking surgery? Standard is 3. Why not 1? Why not 2? Why not 4? So that question not many people ask. We just blindly follow 3 cycles, surgery and 3 cycles. Then is there any role of interval debulking surgery in those patients who had suboptimal resection at the primary surgery? You have done a primary surgery, you could not do optimal debulking. Again, can you go back and do interval debulking surgery? What is the role? Now let us come back and answer all these questions. How to choose the patient and what are the advantages of primary surgery? So advanced ovarian cancer tumor deposits contain heterogeneous population of cells. They contain different clones of cells. By removing these cells, chemo-resistant cell growth and recurrence is prevented. If you remove large tumor, you are removing a lot of resistant cells, and thereby you are going to prevent recurrence. And removing large tumor increases chemosensitivity as small residual cells are better perfused. This is the advantage of doing primary surgery over interval debulking surgery. Okay. Now, how to choose now patient for primary surgery? All patients stage 1, stage 2, stage 3A, 3B should go for primary surgery. No role of neoadjuvant chemotherapy. Up to 3A, 3B, all patients should receive primary surgery if they are surgically fit. Okay. All type 1 and type 2 epithelial ovarian cancer. And all type 1, whether they are stage 1, stage 2, stage 3, we were discussing about low-grade serous cancer. All low-grade serous cancer, mucinous cancer, clear cell cancer, endometrioid cancer should receive primary surgery first because they are relatively chemo-resistant. Okay, if you have a true cut biopsy, shows low-grade tumor, mucinous tumor, clear cell cancer, no role of interval debulking surgery, no role of neoadjuvant chemotherapy. You should go for primary surgery. Otherwise, you are going to waste a lot of time. Now, again, stage 3, 4, should we do chemotherapy for all the patients? It is a very heterogeneous disease, stage 3 and stage 4. One deposit also, stage 3C. You have one deposit in the abdomen, 3C. 10 deposits also, 3C. 100 deposits also, 3C. So it's a very heterogeneous disease. You have to choose patients for primary surgery and interval debulking surgery. So patients who are truly having advanced disease, the decision whether to do primary surgery and interval debulking surgery depends on many factors which are not absolute. What is possible for me may not be possible for you. So you have various factors which are not absolute. Depends on your surgical expertise and experience. So basically these are the guidelines I think which are given in many textbooks. All of you must be aware. Extra-abdominal disease, root of the mesentery, extensive bowel involvement, unresectable retroperitoneal nodes, parenchymal disease. All these things are not absolute. Again, depends on your surgical expertise. But generally speaking, whenever you have these factors, you should go for primary, should go for chemotherapy first. Now, how many patients in India receive neoadjuvant chemotherapy? Stage 3C and stage 4. Any idea how many patients receive chemotherapy? I think I have seen in Kidwai Institute, in a government institute, the figures are different. In a private institute, the figures are different. My personal experience, in private institute, only 10 to 20% will receive neoadjuvant chemotherapy. 80% will go for primary surgery, even stage 3C and stage 4. And in a government institute, private, public hospital, many patients are malnourished. They come with truly advanced disease. Almost 40 to 50% will receive neoadjuvant chemotherapy. Now, in a surgically fit patient with advanced disease with high tumor burden, primary surgery is generally preferred over interval debulking surgery, as it is associated with improved overall survival if optimally resected. If you are able to do optimal resection during the first time, there's nothing like it. You can give very good prognosis. So don't simply go on giving neoadjuvant chemotherapy. Our aim should be to improve surgical skills and provide best post-operative care and do a R0 resection or optimal cytoreduction. That should be our aim. Now question, improving quality of surgery. Is it possible to safely improve optimal debulking rates for primary surgery in advanced ovarian cancer? It is possible. It has happened also in the last 2 decades. So across the globe, surgical skills and perioperative skills have improved in the last 1.5 years, 1.5 decades, 20 years. Surgical skills have improved across the globe, not only in India, across the globe. And ERAS protocol also is contributing to improved quality of life and decreased hospital stay. Improved optimal debulking rates during PDS have resulted in improved overall survival, not because of your surgery in interval debulking. So good surgery during primary surgery has resulted in improved overall survival. So you can see here figure by Kai, optimal resection improved 41% to 80%. Here 48% to 76% over a period of time. So many studies. And once you do optimal resection, it has translated into improved overall survival. You can see here survival rates have improved tremendously. So how much? Survival rates have improved from 62 to 106 months, up to 106 months survival you can give if you are able to achieve R0, CC0 tumor resection in stage 3C. So again, there are many studies, several recent reports have shown that primary upfront cytoreduction improves overall survival. Now, what are the reasons? Why suddenly optimal resection rates have improved? In the last 2 decades, there has been consistent improvement in upper abdominal debulking surgery. What is the measure? See, once you start doing upper abdominal surgeries, diaphragm resection, liver resection, splenectomy, pancreatic tail resection, once you start becoming expert in these areas, your overall survival will improve. Overall survival in PFS will definitely improve. Again, recent paper, ultra-radical surgery, to certain extent it can overcome tumor biology. Tumor biology cannot be overcome, but certain extent you can overcome tumor biology by doing a good ultra-radical surgery. Now criticism, many people say, no, I can't do it, okay? Optimal cytoreduction can be done only by few. But no, it is not true. See, you can see many authors have shown up to 97%, 97, 98%, 85% in stage 3 and stage 4. They have achieved 97 to 91% optimal cytoreduction, Now question 3, how to interpret what published trials on neoadjuvant chemotherapy. So we have 3 older trials, EORTC trial, Chorus trial and Japanese trial. 2010, published in 2010, 15 and 16. But patients were recruited much earlier. Patients were recruited about 10 years back. Okay, now you look at the survival here in the EORTC trial. That's 29 months, 30 months. This is not good survival. 29 to 30 months. Okay, you can't accept this kind of survival these days. And look at that, how many had optimal R0, 21%. Very, very less than contemporary standards. Raises doubt about these surgical aspects about these trials. Again, if you subset analysis, you should not do it, but subset analysis shows trend towards better survival in primary debulking surgery. Subset analysis you do, they found that always survival is better with primary debulking surgery. And if you take patients with metastatic tumors, which are less than 5 centimeter, overall survival is definitely better with primary surgery. If tumor metastatic deposit is less than 5 centimeter, so the overall survival is definitely better with primary surgery, not with neoadjuvant chemotherapy. Okay. Now Chorus trial also see it's a very poor survival. And mortality was 5.6% mortality. Out of 100 patients, 6 patients are dying. This is not good surgical care. Japanese trial failed. This is a failed trial. This is a statistically a failed trial. It failed to show that inferior interval debulking surgery was not inferior. So this is a failed trial. Now all these trials recruited patients nearly 15 to 20 years ago. Since then much water has flown under the bridge. Okay, around the same time of these trials, we have NCDB data, we have CA data, and we have many large single institution trials across the globe. We showed better survival with primary surgery. So we have a solid proof, although retrospective and non-randomized and randomized proof we have in favor of primary debulking surgery. But again now, this is a recent most trial of interval debulking surgery where we had a good surgery. Primary debulking surgery, CC0 was 47%. This is a good trial, okay? But this trial was what happens, it chose patients with very high tumor load. PI score was 8 to 12, and these patients had diffuse carcinomatosis. So probably, if at all you are doing interval debulking surgery, should do it for only patients with very high tumor load of PI score of more than 8 to 12. Only those patients should go for interval debulking surgery. Now morbidity and mortality we say it is reduced. Definitely morbidity and mortality is reduced if you give chemotherapy, but after 30 days everything is same. After 30 days everything is same, whether you do primary surgery or whether you do interval debulking surgery. So why is PFS and overall survival is not improved in interval debulking surgery even though optimal resection rates are improved? During interval debulking surgery, very difficult to point out which is the residual tumor. You have a lot of scarring, you will not know where exactly you are left behind the disease. So this scarred tissue may contain chemo-resistant cells, which you may not remove. So you think that you have done optimal debulking, but actually you have not done optimal debulking. That's why survival rates have not improved, even though you have achieved so-called optimal resection rates. Now, how many chemotherapy cycles should be given before interval debulking surgery? One of the main problems with neoadjuvant chemotherapy is development of acquired drug resistant if more number of chemotherapy cycles are given. So you should not delay chemotherapy more than 3 cycles. Preferably do it after 1 cycle or 2 cycles or 3 cycles. Don't delay, don't go on giving 4 cycles, 5 cycles, 6 cycles, then do surgery. Because chances of developing chemo-resistance would be much higher. This I think study has shown that if you give more number of cycles, the chances of developing chemo-resistance is much higher. So don't go on giving chemotherapy before surgery. And again, these patients who recur after interval debulking surgery, the recurrent tumor is usually cisplatinum resistant more often. Recurrent tumor after interval debulking surgery is cisplatinum resistant more often compared to primary surgery. So I think whenever you are doing interval debulking surgery, you should think twice. And is there a role of secondary cytoreduction in patients who had suboptimal primary debulking? You are a gynec-oncologist. You have done a surgery, you could not do it optimally. Should we go back again and do optimal resection, try to do after 3 cycles? No. No study has shown that if a surgery was done by a gynec-oncologist, you have put maximum effort. After 3 cycles of chemotherapy, again you go back, you will not achieve anything. You will not achieve anything because you are dealing with a bad tumor biology. You are dealing with bad tumor biology. So if an oncologist has done surgery for the first time, put in maximum effort, no point in going back and doing surgery second time. So this is the conclusion. No good evidence that interval debulking surgery is superior to conventional debulking surgery. Primary surgery followed by platinum-based chemotherapy remains standard of care in patients with less tumor burden. Neoadjuvant chemotherapy plus interval surgery is preferred for bulky stage 3 and stage 4 disease with carcinomatosis when optimal cytoreduction is not possible. So I think with this, I'll conclude my talk. Thank you so much.
Thank you both of you for giving a detailed account of the surgical treatment as well as the medical as well as the
Sir, Dr. Bafna sir and Dr. Arun sir, please be on the dais.
Yes. Now we know that the problem starts with the natural history of the epithelial ovarian cancer.
Please be seated, sir.
Most of us are seeing these cases, 80 to almost 80% are coming in the stage 3 and stage 4. There they start the problem. And how to treat these patients in these advanced cases. As with the evidence of so many studies, it has been reported that the optimal cytoreduction was better after neoadjuvant. As you said, what is the result? It didn't improve the overall survival. Now, what we could understand was the primary surgery, primary debulking surgery in very advanced stages can have more of morbidity and even mortality. That is one of it, which may be avoided probably by giving neoadjuvant chemotherapy. Is it the conclusion, isn't it? And on to the chemotherapeutic agents, we have gone up to immunotherapy. All are effective to improve the situation. So we could learn many things on the chemotherapy front, from the standard treatment to immunotherapy and even HIPAC following neoadjuvant therapy. You are telling about the benefits of doing a complete surgical eradication of the disease by primary cytoreductive surgery. But our problem is, in all cases, we may not get the optimum, which is less than 1 centimeter. That is the crux of the point. It is finally the stage and other things, the final outcome is on to the how much of the residual tissue is remaining. That is going to determine the overall outcome of the disease. And as per the chemotherapy, we said that we can remove it better in a very advanced case, and hence neoadjuvant therapy has got a role in such cases. You said put certain indications, but only in the cases which are not possible to have this, achieve this optimum cytoreduction, probably there is a place for neoadjuvant therapy. That is what we try to understand. And the point of doing the primary cytoreduction surgery is always good to have a better result, barring the immediate morbidity and even mortality of such advanced cases. So that is we could understand, and if you got some more points to clarify, we are all here to listen to you.
One thing was that the post-neoadjuvant, what the fibrosis which happened. So actually a lot of studies they have done, neoadjuvant to assess the chemotherapy response score. So I think, I don't know whether sir was pertaining to that, because CR1 score, CR1, 2, 3, 3 scores are based on the responsiveness, mixed response or no response. So the patients who have a bad response actually relapse fast. So I think that was what sir meant when they may become platinum resistant, because if they don't respond, they will fail badly. And that is this, the CR score has actually been, they are trying to tailor the treatment based on the CR score. So that is one more advantage. I just thought about it because the fibrosis was highlighted. So I don't think fibrosis is a negative thing, rather than it's a positive thing, because we can see the how response it is going to be. So that was one more positive thing. And one other thing about the bad tumor biology also, there was a comment in the last, because if you don't do a good surgery upfront, nothing else is going to help, because you are dealing with a bad tumor biology. I think the understanding of that is very important, because once you see the tumor, you should understand it's a bad tumor and then subject them to some other treatment.
You are also mentioning about the immune response, improvement the immune response by chemotherapy, isn't it? The tumor response or that host response to this malignancy is better probably after chemotherapy, or that is what we should?
Yeah, actually it's a, I don't know, because the biology is very complicated, means no one really knows, lot of molecules, cells and all they're telling, but it's a known fact across many solid malignancies that in breast and all, neoadjuvant is coming, all the tumors it is coming up, because we are getting systemic control better. Because if you do surgery, definitely that 4 to 6 weeks in a high-grade tumor, that itself is a very simple thing that we are losing that much time. So I think from there onwards, the time advantage is there. And definitely there's a change, altered thing in that tumor milieu and all, which are even I don't think anyone has really comprehend that. But that is all very much there in the literature.
For highlighting the future coming things. It was just chemotherapy few years back. Now it is all immunotherapy, and not just PARP inhibitors and bevacizumab, we have immunotherapy also. But I would like to highlight a few points Bhavna sir has pointed out. Neoadjuvant surgery is there to stay for ovarian cancer. The question is when to do, and it should not be decided just based on the patient's frailty. Is she fit for surgery? We definitely go for surgery, but Other factors like tumor biology, like ovarian cancer is a group of disease. So non-serous histologies, mucinous, endometrioid, clear cell, we need to do surgery upfront. And the stage of the disease, sirs pointed out, anything less than stage 3C, a big pelvic tumor infiltrating rectum is not for neoadjuvant chemotherapy. It should be for surgery. So neoadjuvant chemotherapy should not be due to lack of surgical expertise. That's why we want to highlight the surgical training programs. So just because you can't do a primary surgery, the morbidity and mortality will definitely come down once the expertise increases. So that point should be highlighted. Thank you.
So I just wanted to ask, Bhavna sir. So like in surgery, like the limits are being pushed constantly as to how much we can remove. But in practice, it's limited by a lot of factors. So what's your experience with, sir, VATS or like removing suprarenal lymph nodes and things like that? The areas which are not absolute contraindications but are very tricky to deal with and high complication rates.
No, usually what I have seen is that tumor biology can be overcome to a certain extent. Okay, if tumor biology is good, surgery also becomes good. Even if you have a tumor in the upper abdomen, you'll be able to remove the tumor easily. Suppose you have a celiac node. It just comes out easily if tumor biology is good. If tumor biology is bad, then it will be very badly stuck. Like she said, low-grade tumor infiltrating very badly. You cannot remove it. So tumor biology also is, you have to balance between tumor biology and your surgical skills. And I can't give definite rules for everybody that you must do primary surgery for all the patients. Again, ultimately, it will depend on your surgical experience, surgical expertise. Not only your expertise, also your hospital's expertise. Yeah, the hospital is geared for all these things. And cost is going to go up, whether patient is going to bear the cost. So all the factors should be considered.
Especially our patients are very poor nutritional status. They come with such low albumin levels, it's impossible to operate. Most of our patients who come to public hospitals, like I have low-grade serous tumors with 2 grams hemoglobin, albumin, serum albumin, not hemoglobin, serum albumin, and ascites, and they are low-grade serous. I can't operate because their general condition is so poor. So a lot of, I think, Indian patients, at least people coming to public health hospital, Kerala is a rich state, you must be having all better people coming to your hospitals, but we face in the north, we do face patients who are poor nutritionally, especially their protein content and all. So it's difficult operating on all cases, although of course theoretically primary upfront surgery followed by adjuvant would be better, but not possible in majority, at least 40% of cases.
Yeah, they'll have a low albumin and a large BMI.
Thank you, both the speakers. It was an impressive performance by both the speakers in the debate. And it was fully loaded with well-reasoned data and arguments too. The ultimate aim of both the speakers was generally to improve the survival rate and to enhance the quality of life of those brave women who are battling this insidious disease. Well done, both of you. And that was a fantastic, smooth debate. Thank you.
Thank you.
Very soft-spoken by one, and very, very, no, not aggressive, but yeah, a surgeon speaking in one, and a very soft-spoken medical oncologist on the other hand. It was very good.
Next, we have an online session by Dr. Santosh Kuriakose. He is the professor in the Department of Gynecology and the in charge of the Division of Gynae Oncology, Government Medical College, Calicut. He's had his fellowship in Gynae Oncology from Amrita Institute, Kochi. After that, he even had a UICC technical fellowship. He is the principal investigator for the extramural project by SERB, and he has several publications to his credit. Dr. Santosh will be speaking online about the topic genetic testing in ovarian cancer eradication, worth a shot.
Thank you, Amrita. I'm honored actually to present this topic. Thank my teacher and mentor, Chitradhara madam, because she is the one who taught us to dream, or who made us realize our dream of becoming a gynecologist. And she has still not stopped dreaming. And she has her final dream of making the Kerala chapter of has come to pass. So it's a very beautiful day. And unfortunately, I could not be there. So today, there is a lot of debate on what is the biology. So I'm going into a very special, a topic very dear to me, the genetics of cancer. So I'll be talking on, my voice is slightly bad. Please forgive me if there is, I'm just recovering from an illness. Shall I share my screen? My screen is visible. Amrita? Amrita, screen is visible?
The screen is visible, Santosh. You can start.
Okay, so I'm just going through the genomic landscape of an ovarian cancer. So I will start with the precision prevention of ovarian cancer. The point is, if we have a patient who come with ovarian cancer or a breast cancer as in the younger age group, or a combination of breast with a family history of pancreatic cancer, male breast cancer, certain multiple family members, all these things, we know that there is a gene that is involved. And it has been very perfectly quantified. What's the risk of getting an ovarian cancer? Like BRCA1 and 2, it is like 50 to 25. Then it coming down to MSH2, it's around 11 to 15%. So here these are definite patients. These are not patients, but there are people who can be identified as possible candidates for ovarian cancer. And intensive surveillance, chemoprevention, and prophylactic surgery is indicated. So my question is, how many of us have actually insisted that our patients should undergo a genetic testing so that their daughters or their relatives can be prevented from getting this disease? I have done only a few times, and I have a handful of success stories also. So why we are not doing it? So who should undergo genetics testing? That we already discussed. We all know any ovarian cancer, any triple negative breast cancer. We all know that. So the question is, what is the genetic test to be done? So we have a medical genome company who comes to us and tells us we will offer a multi-gene panel, 80 gene, 100 gene, 1,000 gene. Last one is my addition. So these multi-gene panels have got a lot of low penetrance genes, which actually are there for almost every human being, and there is nothing actionable about it. But at the same time, they will have some risk assessment also. So, and also a lot of variants of unknown significance. Basically, the one who is handed over this result is left with the dilemma. Even the doctor is left with the dilemma. There is no clear guidelines how to deal, how to communicate with these patients. Now, what actually we need is not an 80 gene panel, but an 8 gene panel. But I don't know any company that offers it, because that is more sensible. because next generation sequencing offers the advantage of giving hundreds of genes. But the problem is we do not know how to deal with it. So we need tailored panels. And more importantly, we should start with the proband. Proband means the patient who comes, and that patient has to undergo testing, maybe extensively, but the subsequent family member, only that abnormal gene need to be tested. That is very important. So counseling before testing, counseling after testing. For busy gynae oncologist or a surgical oncologist, this time is not there. Medical oncologist, this is not a problem, but we need good counselor, genetic counselor for that. Now we all know the what happens to this ovarian cancer. Now we have the TCGA genomic typing of high-grade serous cancer. Now, this is in 2011, and we all know there are 50% are homologous recombinant deficiencies. What is more interesting is that this is a BRCA gene. We all know about this BRCA gene. This is a BRCA. I'm just pointing to this BRCT. Just keep this in mind. I will come to that. So these are all mutations. So this is a 185 deletion A gene. So you can see this whole protein is now only this much. And if you have a BR61 CG alteration, it is the same, but it is non-functional. But BRCT is available. Okay, I will come to that. So this is, even though it looks like a stick, this BRCA is nothing but a protein that allows this broken DNA to be mended. So now this we already discussed about the use of homologous recombinant pathway and also the PARP inhibitors. And I'm not going into this. Yes, this is an important slide. TCG has made a fundamental new classification with regard to high-grade cancer, ovarian cancer. It is based on histopathology and mRNA expression. I will go through one by one. It's not difficult. One is immunoreactive. I will go to the slides and then come back. One is well differentiated. It contains glands and papillary pattern. Solid pattern, where there is poorly differentiated cells. The third, please note this point, mesenchymal type, mesenchymal transition, where there is very few glands, the entire slide is filled with fibroblast. This is the tumor that Dr. Bafna was talking about. Poor biology tumor, that is a poor biology tumor, it will be difficult to remove. Why? Because there is full of fibroblasts. This tumor is a killer disease. This is an immunoreactive, because you can see the tumor is filled with WBCs. Now, what is the difference between these two? Because these four types, these are all high-grade serous carcinoma for us. But now these are different, because if you have an immunoreactive, it has got a platinum resistance of only 23%, whereas mesenchymal transition has a platinum resistance of 63%. Looking at the survival, what is the survival? Again, the survival is 46 months for the immunoreactive or differentiated variety, and only 23 months for a mesenchymal. So it's all based on certain markers in this. So basically, we need to go into this type of classification. Why? Because it is actionable. For example, this MT mesenchymal transition has been found to be very much to be treated with dose-dense paclitaxel. Not in all cases, but if you have an MT, you can treat it. There is enough evidence for that. So, bevacizumab in proliferative type, you can go for bevacizumab. It has got a reasonably good evidence. So, PD-L1 inhibitors in immunoreactive, because as we all know, the pole-mutated, hyper-mutated, it is the tumor cells. The tumor is filled with the tumor infiltrating cells. So these are situations where we can act upon it. So that is why we need to go back and find our own data and see how much of our patients belong to each of these groups. That is what Pavitran sir was talking in his introductory remark, that we need to have our own data. So that should be one of the mandate of this new venture. Now, looking at the endometrioid cancer and clear cell cancers, most of them are MSI type. So they will be rich in, they will be responsive to anti-PD-1 antibodies because of the pole positivity, because of the high hyper mutated type. So that also is important, because endometrioid, most of the endometrioid and clear cell is now going to be classified under high-grade cancer. And I'm not going into the PD-1 concept because it has already been dealt with. Now, very important question. You have a recurrence. The question is, do we have a driver mutation? So what is a driver mutation? So my question, many a time we will think that our geneticist will help us. But we should have a primary idea regarding certain things. That is why I'm bringing this to our knowledge level. Why the TCGA has categorically stated that ovarian cancers targeted driver mutations are very rare. But it is not always like that. There are situations, there are driver mutations in ovarian cancer. So let us just take an example of a comprehensive genomic profiling of a patient. And let us see how we can interpret it. So this has a tumor burden 5, not high, microsatellite not detected, BRCA detected but not very relevant. It is relevant, but this is not a driver mutation. You can treat with olaparib, no problem, niraparib, no problem, but that is not a driver mutation. Yes. This has a FGFR2 Kia fusion gene. So, you know the Kia, new car. So, FGFR, Kia mutation. So, what happens? This is a fusion protein. And what happens is, this FGFR2 is intrinsically active. And it is always switched on. Basically, FGFR is a, yes, this is FGFR. This is always switched on. Once this Kia activation occurs, so all the downstream proteins are active. So this patient actually was treated with sorafenib and she had a lasting response because it was treated by identifying what is the driver mutation. So there are methods to identify the driver mutation. So this is the gene. FGFR Kia. So now 2 drugs from our backyard are important. Statins. Statins can be used to decrease the peritoneal spread of ovarian cancer. There is reasonable evidence for that. NSAIDs, aspirin, also has an anti-inflammatory effect on the peritoneal spread. sorry. So the the last slide. The presence of folate receptor alpha. Drug which is with OTL38.
Sir, if you're finding it difficult, can you hear me, sir?
Oh, yes, yes.
Sir, are you able to continue, or are you almost done?
This is the last slide.
Okay, sir. Okay, sir.
Okay. This patient actually is a patient who underwent neoadjuvant chemotherapy. So we do not know whether there is any disease in this area or not. Now we have used a folate plus this particular drug, OTL38, which has been integrated into it and made into a single drug. And once this has been, which is now given to the patient, it will be lighted up with our near infrared light, which we use for sentinel lymph node. So basically the advantage is that you will be able to do a precision surgery rather than the last talk also they were talking about what to do if there is difficulty in identifying the lesions after neoadjuvant therapy. This is our next era is going to be era of precision surgery rather than surgery based on a gross appearance. So this is to conclude. So most important pillar of preventive oncology is actually the genetic testing of the patients, find out who is at risk in the family, and that remains underutilized, which we need to do again and again. And instead of traditional chemotherapy, we can in turn go for immune damage, less immune damaging approaches like targeted therapy, and look for actionable mutations. And of course, there are a lot of challenges actually. So some drugs are promising in vivo, but not very useful in the practical sense. But the future is definitely bright. Thank you. I'm sorry, I had a very severe cold. Thank you.
Thank you, sir. Thank you for your sportsman spirit, and even though you're not feeling well, you did it online. So thank you so much. And we got delayed, the sessions got late, that's why.
No problem, thank you.
Thank you so much, sir.
So I talked about that BRCT. Actually, that BRCT gene, and if it is not there, that part is missing, your olaparib is going to be less effective. Okay, so I have showed you the BRCA gene. So in that BRCA gene, if there is mutation that resulted in BRCT part getting deleted, your efficacy with olaparib is likely to be less.
Okay, sir.
So there are a lot of things that we need to know as a oncologist before we approach because this is going to come up in a very big way. So, and it is unless we know in depth about these things, it's going to be, then again, if you have a FGFR2 mutation where the extracellular receptor binding site is already mutated, no amount of drug that is going to act at the level of receptor is going to affect. Okay, so a lot of things are there in this, and everybody is in the learning phase. So basically, it's a very important topic.
Yes, thank you very much, Santosh. I'm reminded about that particular talk you had in Calicut regarding genomic analysis in ovarian cancer. So very sporting of you, even with the URTI, you are here. Thank you very much.
Thank you.
It was a very nice talk.
Pleasure. Thank you. Thank
Now we have a session by Mrs. Divya Uchil, exploring into the HRR pathway, a world beyond BRCA 1 and 2. She's a senior genetic counselor and scientific affairs manager.
Hi, a very good evening to one and all. So firstly, thank you to Dr. Santosh. I think he's set up a great platform for me to start with. As we're aware, I think since morning, all of us must have heard a lot about BRCA1, BRCA2, and that's what we generally even see in our practice, that BRCA1, BRCA2 is always the showstopper. Not taking away credits from BRCA1, BRCA2 at all. BRCA1, BRCA2 is one of the pioneer genes in the setup of hereditary cancers. So it has to be something which has to be given the importance that it deserves. But what we are seeing recently is that there's so much more than BRCA1, BRCA2. And in the next 10 minutes, we'll be speaking about what are these different genes and how they're basically changing the era of genomics, especially in the HRD deficient cancers. So as we are aware, cancers, you can briefly categorize them into sporadic, familial, and hereditary. We're going to speak more about the hereditary aspect of cancers and which are the different genes that are associated with them. BRCA1, BRCA2, as we know, got all its fame from what we call the Jolie effect, which happened in May 2013, when Angelina Jolie, a well-known Hollywood actress, underwent prophylactic measures because she was identified with a deleterious BRCA1 mutation. She was not affected. She did not have any kind of cancer, but she had a very strong family history of her mother and grandmother being affected with ovarian cancer. That's when she went for the testing, and she was identified with the BRCA variant, post which she also took steps for prophylaxis. Not just that, she was brave enough to actually go ahead and publish about it, talk about it to the people so that the masses become more aware about this and they too start taking actions in case they are at risk of cancer. So as you can see in the pink diagram that I've represented there, you can see almost 40% hike in genetic testing was seen both in affected as well as healthy individuals post the Jolie effect. And of course, when PARP inhibitor therapy was approved for ovarian cancer, prostate cancer, breast cancer, pancreatic cancers on having a BRCA1, BRCA2 mutation, all the more popularity was gained for both BRCA1 and BRCA2. But when we look beyond, we see that there are more genes, there are so many other genes which lie in the same pathway as BRCA1 and BRCA2, and which now have been showing to show increased incidence in mutations with the onset of multi-gene panels that we've been doing. Most important out of them are the HRR genes. The HRR genes are basically the homologous recombination and DNA repair genes which are required for genome maintenance. As we know, they function just similar as BRCA. When there is a DNA damage, these genes are basically responsible for repairing the damage. And here are some evidences which show us that now and then we have studies, we have papers, these are very recent publications, 2019, 2021, which have been coming up showing that beyond BRCA, these genes also can have mutations, and these mutations very much can help us prevent cancers in the family, prevent family members from further getting cancers. So more evidence about the same. And here we have some case studies to back these up. Basically, we used the HRR panel, which is available at 4Base Care, and here we have some case studies wherein we present how a family which typically represented basically maybe as a hereditary breast and ovarian cancer syndrome, or didn't even need testing at that point in time, but surprisingly we did have some pathogenic variants which came up then. So the first case is of a 67-year-old female with breast cancer. As you can see, quite a strong family history, but not at very early ages of onset. What we generally think of when we're talking about hereditary cancers, we talk a lot about cases which happen at early ages. Here we do not see a lot of early age cancers being presented, and quite a diverse history. Typically, we would have gone ahead for a BRCA1 and BRCA2 test here to check if BRCA1, BRCA2 is positive. Unfortunately, BRCA1, BRCA2 is not the culprit out here. It's a pathogenic splice donor variant in the PALB2 gene. As we know, PALB2 is the next upcoming BRCA1, BRCA2. We have a lot of incidences coming up for prostate cancer. We even have approvals coming up for PARP inhibitor therapy with PALB2 mutations. 66-year-old female, breast cancer. We had a family history of paternal grandmother having breast cancer, again at very late age. Definitely she wouldn't have made to the genetic clinic because looks like a case due to age and population risk. No immediate relatives being affected with any kind of cancer. Genetic testing was advised for her, especially HRR testing by the clinician, and again we find a PALB2 mutation here. So we see how we've been able to help the family, basically her sons and her brothers, to further screen for prostate and pancreatic cancer because she has a PALB2 mutation. This one is quite interesting. 48-year-old female with a sister who had breast cancer. She had already undergone a BRCA1 and 2 gene testing, which was negative. Further, she was referred to 4-base care for a much in-depth test where we opted for an HRR test for her, and not surprising, we found something which was not BRCA1, BRCA2. We found a BRIP1 mutation. If you see the recent NCCN guidelines, NCCN has beautifully given how these other genes, especially PALB2, BRIP1, ATM, has differing risk figures in comparison to BRCA, and they have also beautifully given a management plan for these individuals now. A case of ovary, 68-year-old, again, whose sister was diagnosed with breast cancer, but pretty late at 70 years of age. Again, here we would have thought a BRCA1, BRCA2 would have been more ideal so that we avoid the VUS that we generally encounter in the other multi-gene panels. The results were quite surprising. We did not find one but two mutations here. She had a RAD51D pathogenic and a CHEK2 likely pathogenic variant. So that definitely immensely helps the family further. We don't screen just for one but for two mutations now to check if, because both of these mutations predispose both hereditary breast and ovarian cancers. So we need to check the family members for both the mutations particularly. 59-year-old female with CA pancreas, and then there was a history of CA liver in the brother. So here we are trying to show that it's not just breast and ovarian cases which basically have these HRR mutations present. Here in a case of CA pancreas, we came across an ATM mutation, looks like quite pathogenic and deleterious splice site variant that we identified in the ATM gene. Further management along with genetic counseling was offered to the family. 64-year-old female, CA ovary, history of CA lung in the father at 70 years of age. Again, someone who wouldn't have made it to the genetic clinic or for genetic testing. Doesn't look like quite a history of hereditary cancer. Yet she was referred for HRR testing by her clinician, typically to check for PARP inhibitor therapy, and we did find a RAD51D variant in her. 47-year-old female, CA breast, esophageal cancer history in the father at 70 years of age. Again, here we found two variants, but one of them turned out to be a VUS. It was a RAD51C variant which was identified, as you can see. She also had two sisters who were tested after her to check for predisposition, and hence they were helped to give a management plan which could basically help in prevention of cancers in them in the future. So this is the panel that I've been talking about all this long. It's the HRR gene panel. Here you see around 15 genes that we have. It's both in the germline and somatic setup that we do these 15 genes. From where do these 15 genes come? They're taken right from the Lin-Perza trial which happened for olaparib, the exact same 15 genes that we test for. And of course, as Dr. Santosh was mentioning, there are cases where doing maybe a panel which is just restricted to certain genes would not be enough. So in that cases, we also have a multi-gene panel. It's called the Germline Plus panel, wherein we offer 163 genes. These 163 genes typically are associated with all different kinds of hereditary cancer syndromes, whether autosomal dominant or autosomal recessive. This does include the 15 genes, the HRR genes that we were talking about, alongside genes for Lynch syndrome, Leaf-Romney syndrome, Cowden syndrome. All of them are part of it. Thank you so much.
Thank you, Mrs. Divya, for the wonderful talk. So now we'll have the remaining 4 WIGOG papers. So those 4 candidates, please be ready.
Good evening, everyone. I'm Dr. Karen from
No,
CMC.
wait. Let the judges come. Wait. Shalini madam will join us soon. Meanwhile, we have prizes for the e-poster. First prize, Dr. Anjana. Is she here? Is she here? Dr. Anjana from RCC? No. And second is Dr. Sindhu from CMC. Is she here? Okay, ma'am. Please. So, second prize in poster presentation. So, for the rest of the WIGOG paper, Shalini madam, please join us on the dais. Dr. Michelle and Dr. Amrita will join Shalini madam to judge the rest of the WIGOG paper. Please join.
Please tell us this.
So this is Dr. Karen. You can start.
Good evening, everyone. So I will be presenting a retrospective study on the characteristics and prognosis of ovarian clear cell carcinoma. So we know that it is a rare subtype of epithelial ovarian carcinoma, and it has a different biology. Because of the rarity of the tumor and the limited number of studies that are available, this retrospective study was undertaken. So the aim of the study was to observe the clinico-pathological profile of these women and the oncological outcome by the stage of the disease. So this was a retrospective study. This was conducted in the Gynae Oncology Department in CMC Vellore between January 2011 and December 2020, and a total of 57 patients were included in this study. So women
who had a histopathological confirmation of ovarian clear cell carcinoma were included in the study, and women who came to us with recurrence who were treated outside with initial presentation were excluded from the study. So the clinical characteristics and the outcomes were analyzed with SPSS, and survival analysis was based on the Kaplan-Meier method. So going on to the results, so we found that the median age at presentation was 46 years, and about 1/3 of the women were less than 40 years of age, and 1/4 of the population were nulliparous, with 6 of these women with history of infertility and 12% of these women with endometriosis. We found that almost half of these women were postmenopausal, and 1/3 of these women had endometriosis. 10% of these women had previous ovarian surgeries, and only 2 women had family history of cancer. 3% of them had synchronous endometrial cancer, 1 had CA breast and 1 had CA colon. We also found that 29% of these women had normal CA125 levels, and only 12% had a very high CA125 above 1000. And based on the demography profile, 1/3 of the women that we treated were from the South India, 1/3 from the East India, and about 10% of these women were from Bangladesh. Going on to the surgical characteristics, staging laparotomy was done in 38 of these women, and 20% of these women had completion staging, and 2 women had a fertility sparing surgery, and IDS was done in 6% of these women. Lymphadenectomy, which was pelvic and para-aortic lymph node dissection, was done in 38 of these women, and 2 women required bowel resection. So the resection was complete in 82% of these women, and R1 resection was in 12%, and R2 resection in 5%. So we also found that majority of these women were stage 1 at presentation. This was followed by stage 3, and stage 2 had the least number of women. And in stage 1, stage 1A, majority of these women were at. And adjuvant chemotherapy was given in 85% of these women, and 7% required neoadjuvant chemotherapy, and the most common chemotherapy regimen that was given was carboplatin paclitaxel combination. And most of these women received 6 cycles of chemotherapy, and the mortality rate was found to be 16, that is 28%, and the median follow-up period was about 46 months. And 45% of these women recurred, and the mortality rate was 28%. Breaking it down based on the stages, in stage 1, 31% recurred and 17% had died, whereas in stage 2, it was a small subgroup, and 4 women had recurrence and all 4 died of the same. In stage 3 and stage 4, it was almost the same, around 60% recurred and 30 to 40% had mortality. So the median disease-free survival interval was about 15 months. And recurrence, most of these women had distant recurrence, and most of them had multi-site recurrence. Most of them were treated with only chemotherapy, and only 5 women were eligible for a secondary cytoreductive surgery. And 8 of these women did not follow up, or they had a palliative treatment after recurrence. Second-line chemotherapy was given in 8 of these women. So this is the Kaplan-Meier curve analyzing the survival outcome based on the type of resection. So we can see that in R2 resection, the curve is steeping down below, showing that there is a significant adverse survival outcome in women with R2 resection. So going on to the overall survival, we found that in stage 1 disease, the overall 3-year survival was about 86%. Whereas in stage 2, it was only 25%. This is because we had less number of women in stage 2 disease, and this was followed by stage 4 disease. So the overall 3-year survival was about 66%. Disease-free interval was also similar, with stage 4 disease having 50% survival rate. So clear cell carcinoma constituted to about 4.6% of the total number of cases that were operated in our department over a period of 10 years. We found that 1/3 of these women had endometriosis, and majority of them were stage 1 at presentation. And primary debulking surgery and complete cytoreduction was seen in more than 80% of these women, and the median overall survival in months was about 46. And we found that R2 resection affects the survival outcome. And 43% of these women had recurrence, and the median disease-free interval was about 15 months. So to conclude, It presents in early stage more often, and early stage of the disease and complete cytoreduction were associated with better survival. We found that advanced stage affects the survival rate and it tends to be chemo-resistant. Molecular markers and targeted therapy are needed to improve survival in these women. Thank you.
So what do you think, these women are better survivors than high-grade serous, or they are worse survivors? Is the prognosis good? Is vis-a-vis literature and vis-a-vis, do they do well?
Compared to other types of epithelial, they are they have a worse prognosis.
Clear cell?
Yes, ma'am.
Even stage 1?
Stage 1 is better. Among the clear cell carcinoma, stage 1 has a better overall survival, especially if it's early stage and if there is complete cytoreduction.
So in fact, I think they do better. Early stage clear cell carcinomas, though we say clear cell carcinomas have a worse etiology. In ovarian, they do.
Stage 1, they do well.
Yeah,
yes,
they do well. Okay. And what is the, you didn't compare your 57 number with literature series. So what is the highest number in literature which you could compare your series with and the survival outcomes in those various stages?
Yes, it was kind of similar, except for the stage 2 disease that we had. We had a lesser number of population in stage 2.
Okay. You showed your Kaplan-Meier curves.
Yes,
what were the vertical lines on the Kaplan-Meier curves? There were several vertical lines. Can you go back to one of your... okay. There are a lot of vertical lines. So what are the vertical lines
so
on the graph?
Every time a patient is censored, so the survival rate will come down. So as the steep
There
comes
are a lot
down,
of censoring right from the beginning.
Yes,
So I saw a lot of censoring. So that's why I was wondering, how is your survival rate so good when there's so much of censoring?
Yeah, ma'am.
You saw those curves? Yeah. Go. See, your censoring is there right from the beginning.
Yeah, ma'am.
It keeps going down, but then how is your survival rate 86% and 81% when you have so many censored?
So as it drops down, it represents the survival in months. So the more steeper it is, the more adverse the outcome is.
Yeah, but your blue line, which shows good, shows a lot of censored, lot of vertical lines, right?
Yeah.
The blue line, which has gone up to
and
120 ones. So that was a little ambiguous.
What is the range of your survival?
It was survival range. We followed up 3-year survival I had calculated, ma'am.
Yeah, okay. So the range of, you're talking about events or
10-year
deaths,
data.
right?
Yeah, ma'am.
The deaths are the events that you have shown.
Yes, ma'am.
So why didn't you show 5-year survival? Why did you show 3-year
Ma'am,
survival
it
if you
was,
had follow-up till 2020?
So 2011 to 2020. So some women...
No, but you presented this in 2023. So why didn't you have 2012 to 2022 data? Why did you stop at 2020? You understand? You're presenting it now, right? In 23. So your data should have been... So this is some old data you're presenting, right? So that's the...
How do you explain the lower survival in stage 2? What could be the reason?
What I found was 3 of the women in stage 2 disease had a optimal cytoreduction. So that could be one of the reasons. And the other thing is this is a small population, like only 4 women we had in stage 2 disease as compared to slightly higher rate in stage 3 and 4. Maybe if there was a bigger population in stage 2 disease, maybe we could have analyzed further.
Does the total number affect survival? No, I don't think so.
Only in stage 2.
So I just want to ask you, when you looked into your data and saw the advanced stages, what is the difference in the spread of the disease and the resectability when you compare to a serous carcinoma with your clear cell?
Yeah, ma'am. Resectability rates.
Not rates. How yeah. Was it same? Is it worse? Is it easier? When you, is there any difference?
Yeah, this study R2 resection was seen only in about 8%. So it was comparable to high-grade serous rates. So I didn't find any significant difference between the two.
And the spread of the disease, do you find out any difference in the way it spreads in the intra-abdominal, or is it same?
Same. But the recurrence-wise, when they presented with recurrence, most of them had a distant recurrence.
It was not in, there was a difference you
Yeah.
saw there.
Yes, ma'am. Thank you, ma'am.
Next presentation, Dr. Divya.
Yes.
Divya, madam. Dr. Divya.
Yeah, Divya, you can start.
Good evening, everyone. I'm Dr. Divya from Amrita Institute of Medical Sciences. Today, I'm going to present a study on a comprehensive analysis of staging differences between endometrial cancer FIGO 2009 and 2023 and its clinical significance. This year has been very exciting as we know FIGO has updated its endometrial cancer staging after nearly 14 years. This is because of tremendous growth in the molecular findings and identification of other prognostic factors since the publication of the Cancer Genome Atlas data. This data has shed light on the behavior and response to treatment of various subtypes, and hence FIGO has integrated them into the new staging. The aim of the new staging is to better define prognostic groups and to create clinically relevant substages for treatment and future data collection. The aim of our study was to analyze the stage shifts between the two new staging systems and to determine the stage-wise 3-year overall survival and disease-free survival between the two staging systems. It was a single institution retrospective study done in the Department of Gynecological Oncology and Pathology. All endometrial cancer patients who underwent surgery in our center between January 2015 to June 2021 were included. Exclusion criteria were cases who underwent primary surgery or incomplete surgery elsewhere, and histological types not included in the FIGO staging. Statistical analysis, we used Sankey diagrams to describe the stage shifts, and we use Kaplan-Meier curves for the overall and disease-free survival, and a p-value of less than 0.05 was considered significant. Coming to the results, a total of 381 cases met the inclusion criteria and were included in the study. The mean age of our study population was 59.8 years and BMI was 28.5 years. Majority of our cases, that is almost 80% of our cases, underwent minimally invasive surgery, that is inclusive both laparoscopy and robotic. When we analyzed the histology based on FIGO 2009, we saw that the endometrioid category comprised of 74% and non-endometrioid was 26%. But whereas according to the 2023 staging, the aggressive histology was increased to 33.4%. This is because of inclusion of grade 3 cases also in the aggressive histology. This table here depicts all the cases being staged using both the systems. To understand the staging shifts more clearly, we have represented them in the graphical manner using Sankey diagrams. Here you can see that according to FIGO 2009, this is the stage 1A cases. Most of them are reclassified to stage 1A2 here. A few of them are upgraded to stage 1AC and 2C here because of their aggressive histology. A similar thing is seen in stage 1B, where a few cases are upgraded to 2C. Thus, in the new staging, the number of cases in stage 2 have increased dramatically when compared to the old staging. When we analyze the advanced stages, most of the cases in stage 3 and 4A cases have been reclassified to their similar stages, except one case in stage 3A where it has been downstaged to 1A3. And coming to 4B, here we can see that 8 cases have been downstaged to 3B2, that is cases having pelvic peritoneal mets, and 8 cases have been staged to 4B for abdominal peritoneal disease, and 9 cases have been upstaged to 4C for distant mets. Coming to the survival analysis, our study population had a median follow-up period of 32 months and a mean 3-year OS of 34.5 months, that is 92%, and a mean 3-year disease-free survival of 33 months, that is 86.3%. We also analyzed the 3-year OS and DFS stage-wise. Coming to stage 1, we know that the 2 new substages added are 1A3, that is for low-grade limited to endometrium and ovary, and 1C, aggressive histology limited to the endometrium. Here we found the 3-year OS and DFS to be similar and not statistically significant. Coming to stage 2, here we know that the 2 new substages added are for substantial LVSI and aggressive histology. Here also the 3-year OS and DFS were similar, but when we see the DFS graph here, we know that we can see that the lines begin to separate here, and we know that we can see that the latest classification has a lower DFS. This might be because of the inclusion of the aggressive histology to this group. Coming to stage 3, here the new substages added for uterine subserosas and serosa, pelvic peritoneal mets, and a separate group for the micro and macro mets in the lymph nodes. Here when we compared the 3-year OS and DFS between the 2 groups, we did not find any statistical significance. Coming to stage 4, here the new subgroup was for abdominal peritoneal mets. Here also the 3-year OS and DFS between the 2 groups was not statistically significant, but when we see the DFS graph here, the DFS for the new classification is lower. This might be because of the cases of 3B2 being downstaged or removed from this group and making the DFS lower. When I compared the study to other studies in the literature, there are only 2 studies done on this topic. One is done in Europe to verify the prognostic precision of the new FIGO staging in 3 ESGO accredited centers. This study was presented in the ESGO Congress in Istanbul recently. We have compared our results to this study. When we saw the stage shifts, our study and their study had similar trends in the stage shifts. Total upshifts and downshifts were very similar. Coming to the prognostic impact, in their study, they found among stage 1 cases a higher PFS and a similar OS. Among stage 2 cases, the same 5-year PFS and a higher OS. And stage 3 cases, a lower PFS and a similar 5-year OS. In our study, we did not find any statistical significance between the 2 stagings in all the stages. To conclude, we found that all stage shifts occurred either within the early stage group or within the advanced stage. In early stages, majority were upstaged due to the aggressive histology, that is to 2C, and in advanced stages, majority were downstaged due to pelvic peritoneal disease. We did not find any significant difference in the stage-wise 3-year OS or DFS between the 2 staging systems. This might be due to the low number in certain subgroups, the lacuna in the LVSI classification in our data, and the adjuvant therapy received. In our institute, most of the high-grade cases received POTEC 3 protocol. This might have an impact on the DFS and the OS, and the robust use of SLN mapping in all cases, which will help us detect occult lymph node metastasis. Thank you. These are my references, and this preliminary analysis has left us with some unanswered questions. These are a few things we can ponder upon, and with time and more studies, most of them will be answered. Thank you.
Again, the same question to you. Why did you choose 3-year survival instead of 5-year survival? Why did you choose only 6 years data instead of 10 years data? Because you have the data. So 3-year survival, we talk about 2-year survival only in aggressive cancers. We don't normally talk about 5-year survival. When you're doing a retrospective data and you have, you could have evaluated 10 years and given as a 5-year survival, why did you do this 3-year cutoff?
Ma'am, my data started collecting from 2015.
So why couldn't you collect it for a few more years?
The number of cases and the pathological reports for the LVSI and SLN mapping were not available for the cases before that, ma'am. We in our institute from.
But we don't need SLN mapping. No? You would have been doing lymphadenectomy.
Yes,
it's not necessary that you have only SLN mapping. You would have done pelvic lymphadenectomy earlier.
Yes, ma'am. But the number of cases also were less. And our last data collected was till June 2021. So to give and now I'm collecting the data in 2023. So the 3-year survival.
No, I mean, Amrita has been there for 2 decades at least.
Yes, ma'am.
So the reason you did not collect it because you were not doing SLN biopsy. That was not this is a retrospective data on stage shift.
Yes, ma'am.
Right? So that should not have affected your collection of data.
And also my median follow-up period for this group was 32 months, ma'am.
That's what I'm saying. Why 32 months? Why not 60 months? When you have a 10-year data. You understand what I'm saying?
Yes.
It's not that yours is a new institution and you have only 3-year data or a 4-year data. When you could collect it from 2016, it could have been collected a little earlier also. So there has to be some valid reason of why you didn't do earlier data collection apart from Sentinel node.
And also number of cases were lesser.
It doesn't matter. It would have total number would have increased,
yes.
right? So why did you? Is 381? How did you decide on sample size collection, whatever in your retrospective data, is sufficient for analysis? How did you decide that those numbers were sufficient for statistical analysis? Because when you want to publish, these are the things that people will ask.
Ma'am, I have taken whatever was all the consecutive cases who undergone surgery in our institute.
So but even for retrospective studies, there's a way of calculating sample
yes,
size.
Yes, ma'am. The new study which I've compared my data to theirs has been it's in.
How many years did they study?
They have studied for 10 years, ma'am.
They've studied for 10 years, no? So normally people would present longer.
But this sample size was lesser, ma'am. 200.
No, but you showed 560 in the ESGO study, 5 something.
Yes, ma'am. That was done
ESGO?
in 3 centers, but the survival analysis was done only for 200 cases, ma'am. It was done 2 in Vienna, 2 centers in Vienna and 1 in Italy, ma'am. The Italy center was only 6 months. 2021 only they had. So those cases they have excluded from the survival analysis, but included them for the stage shifts.
Okay. Otherwise, some of your slides were very good, especially the stage shift ones. So what did you call those slides?
Sankey diagrams.
What diagrams?
Sankey.
Sankey.
Yes, ma'am.
Okay, those were very nice.
A good presentation, but as ma'am said, because of the time frame, you were not able to give us a conclusion on how valuable the new staging is. Was there any change in the would you have made any change in the management had you used the new staging prior?
No, ma'am, that is what. So one of the main drawbacks of this is you have to, with the new staging, you also have to change the risk category for adjuvant treatment, which in the ESGO they have said that next year they are going to update it and the latest one is going to come. Because most of our plan and treatment for the patient on adjuvant is based on the risk stratification which the ESMO guidelines which we follow. So even if now for the past few months, even though we are staging the patient using this new staging, we are still using the old one to decide the adjuvant treatment what they require. So with both change, then we will be able to see if the clinical impact, like downstaging to 3B2, will it have any from changing to from palliative chemotherapy, they will now receive non-palliative intent, maybe POTEC 3, depending on that. So that will have an impact on the clinical outcomes. Or if 1A3 cases don't need any adjuvant treatment, so we will be preventing them from a lot of other side effects, but we will be able to see if that will actually keep up the same overall survival. So
and also you haven't looked into the quality of life also, right?
No.
You've taken only survival.
Only survival and the stage shifts.
So whether the treatment would have affected the quality of life, you will not be able to give with this.
This treatment was what was based, it is retrospective.
No, even if you had changed the treatment, we would need to know also regarding the quality of
yes,
life.
Then
only we'll know whether this is really beneficial for us.
Yes.
So that also has to come in future when you are looking into not just survival but the quality of some parameter for that.
With the latest update next year, the risk stratification, then prospective studies can help us to tell us the quality.
Thank you, Divya. Thank you.
Next, we have Dr. Neetu George.
Good evening, judges. So I'll be presenting my paper on combined fundal ICG and cervical radiculoid injection versus cervical radiculoid injection for sentinel lymph node mapping in early stage endometrial cancer, a prospective interventional comparative study. NCCN Guidelines 2023 recommends sentinel lymph node mapping as an acceptable method for lymph node staging in uterine confined endometrial cancer, and meta-analysis has showed that overall and bilateral pelvic node detection rates are better for cervical compared to fundal injection. but para-aortic rates are higher with fundal injection compared to cervical injection, and ICG is a preferred dye for SLN mapping for better overall and bilateral sentinel node detection rates. There's a lot of lacunae in literature regarding a combined fundal, cervical and fundal approach in sentinel node mapping. And our research question was, is combined fundal ICG plus cervical technetium injection better than cervical technetium alone in lymph node staging of early endometrial cancer? And we hypothesized that there is a difference between these two techniques. So aim of the study was to compare the two techniques, combined fundal ICG and cervical radiculoid injection versus cervical radiculoid injection. The study was conducted in the District of Ernakulam. It was a prospective interventional comparative study conducted in EPS Lakeshore Hospital, and the duration was from April 2021 to December 2022. 60 patients with biopsy-proven endometrial cancer, stage 1 to 2, were included in the study. Extrauterine disease was ruled out by higher imaging. The 60 patients were allocated to Group A, n equals 30, and Group B, n equals 30. Group A received cervical technetium and fundal ICG. Group B received only cervical technetium. We followed an open SLN mapping according to the, and we followed the MSKCC protocol for sentinel node biopsy. These were the primary outcomes: overall, bilateral, pelvic, para-aortic, and aberrant sentinel node detection rate. Secondary outcomes were sensitivity, specificity, positive predictive value, negative predictive value of sentinel lymph node mapping, and correlation of risk factors for a positive node as per ESGO guidelines. So this was a study schema. 60 patients with biopsy-proven uterine confined endometrial cancer, allocated 30 in Group B, 30 in Group A, and 30 in Group B. Both groups received intracervical technetium, followed by a midline laparotomy. Group A received fundal ICG after a test dose, and within 30 minutes, SLN mapping was done in Group A with near-infrared imaging and gamma counter, with Group B with gamma counter. A sentinel node was defined as a fluorescent and hot node in Group A and a hot node in Group B. In Group A, bilateral detection was seen in 28 out of 30 patients. In Group B, bilateral detection was seen in 22 out of 30 patients. Para-aortic nodes were detected in 9 patients in Group A and 1 patient in Group B. TH plus BSO and staging procedures were done in all patients, and in patients with unilateral sentinel detection and opposite side pelvic lymphadenectomy was done. This was a subgroup analysis done for calculating sensitivity, specificity, positive predictive value and negative predictive value of SLN after ruling out comorbidities. We had a subgroup of 30 patients. Statistical analysis was done by SPSS software. Coming to the results of the study, the mean age of the study population was 57.67 years. Most of the patients, 95%, were multiparous. Postmenopausal bleeding was the most common symptom. 61 patients belonged to stage 1A, and most of the patients were low-grade disease. Coming to sentinel node detection, pelvic nodes were seen in 50 out of 60 patients, 83.33%. Combined pelvic and para-aortic was seen in 16.67%. Bilateral pelvic node detection was seen in 83.33%. Coming to distribution of nodes, most of the nodes were found in the external iliac basin, 71.3%, followed by obturator node. We found 3 metastatic nodes. All 3 were seen in Group A. One was a positive para-aortic node, and 2 were positive pelvic nodes. We came across 3 complications. One was a bronchospasm and 2 hypertension, and all were dealt with conservatively. Coming to group comparison, Group A versus Group B, we found that Group A and Group B were matched with age, parity, symptoms, stage, and grade. Coming to sentinel node detection rates between Group A and Group B, a sentinel node was detected at least in one hemipelvis in both the groups. Bilateral pelvic node detection was different. It was 93.33% in Group A versus 73.33% in Group B, but this did not attain statistical significance. P-value was 0.08. Para-aortic nodal detection was seen in 30% in Group A and 3.3% in Group B, and this was statistically significant. Comparing sentinel node METs between Group A and Group B, all 3 were seen in Group A. Coming to association of grade, stage, tumor size with nodal METs, we found that grade, myometrial stage, myometrial invasion or stage or tumor size did not attain statistical significance for nodal METs. However, LVSI, perineural invasion, lower uterine segment involvement, and cervical stromal invasion was significant. LVSI, lower uterine segment involvement, and cervical stromal invasion was significant for nodal METs. However, in multivariate analysis, none of these factors were found to be significant. Coming to sensitivity, specificity, positive predictive value, and negative predictive value, in Group A, all were found to be 100%. In group B, we didn't have a positive metastatic node, so we found the specificity and negative predictive value, and both were 100%. Coming to discussion, so the overall sentinel node detection rate in our study population was 100%, and bilateral sentinel lymph node detection was better with combined cervical technetium and fundal ICG versus cervical group, 93.3% versus 73.33%, and this combined cervical approach covers both the upper and lower cervical pathways. And according to Kizis et al., a combined technique yielded unilateral SLN detection of 97.5% and bilateral detection of 81.25%. Coming to para-aortic node detection, it was higher in the combined group, 30 versus 3.33% in the cervical group. And this can be explained by the fact that the fundus of the uterus drains through the infundibulopelvic ligament to the para-aortic nodes and can be better picked up with fundal injection of the dye. And this was evidenced by studies by Jeppert et al. And Giza et al., which found 47 and 8% para-aortic node detection with fundal injection respectively. Coming to SLN Mets, the incidence of SLN Mets in the index study was only 5%, and this is relatively low compared to the previous studies, Senti, Endo, and FIRES. And this could be explained by the fact that majority of the study population had stage 1A and low-grade disease. To conclude, combined fundal ICG plus cervical technetium has promising results in bilateral and para-aortic sentinel lymph node mapping, and it can be used as a comprehensive technique for SLN mapping in centers where facility for the near-infrared imaging is available. However, we encountered 3 complications in the study, so ICG has to be used in the correct recommended dose. And risk factors on univariate analysis were LVSI, LUS involvement, and cervical stromal invasion. These factors were not significant on multivariate analysis. Thank you. These are my references.
So ideally, we give ICG into the cervix.
Yes.
Why have you decided on giving it on the fundus? Any particular reason?
Yes, ma'am. So we wanted to do a combined injection technique, cervical plus fundal injection. In our institute, we give cervical technetium, which is a protocol followed in our institute. So in order to do the combined analysis, we had to choose between a technetium or ICG. But we chose ICG because as per meta-analysis, ICG gives better detection rates.
No, but it's already proven that cervical injection is better than fundal. So what reference did you get apart from one reference that you gave, that fundal injection? Because nobody in the world now does fundal. Because
Yes,
it's the cervical injection which goes through the your pathways, pelvic lymph nodes. But you gave the cervical for the para-aortic mapping.
Yes, ma'am. Yes, ma'am. For detecting para-aortic nodes.
Yeah, but I think even MSKCC or nobody else uses fundal approach now, but you gave a fundal approach.
Ma'am, an isolated para-aortic node can be detected. I mean, it is anatomically speaking, it is detected better with a fundal injection than a cervical injection. Although the deep stromal cervical injection does detect para-aortic nodes as well.
The superficial and the deep. So once you do the deep, that will go into your stroma, which will go to the fundus and then go into the para-aortic nodes. That's why I think people, there have been a lot of studies on fundal and cervical. So what you could have done is given technetium alone in the cervix and ICG alone in the cervix only, and then compare the 2 groups. But
but studies have already proven this, that ICG is better than technetium as per meta-analysis, ma'am. So, and then in India, not so many studies have been conducted on a combined technique. Most of the studies were
and you used laparoscopic method or open method?
No, ma'am.
Okay. What is the equipment you use for the open ICG detection? Sentinel node detection?
Ma'am, we use the same Stotz camera with the near-infrared imaging. So we opened up the patient and turned off the lights in the operative room, and then focused on the, did the fundal injection, and then focused the scope on the nodal basins. So it was a laparoscopic scope only that we used.
But is there anything available for an open technique?
There are handheld probes available, ma'am.
Okay.
But we don't have it here. No.
Laparoscopic.
Yes.
Because I don't know, in my experience, if you give it in the fundus or if there's any little bit of cervix is good because that's out of your field. You're injecting there. But any injection into the abdominal cavity, especially the fundus, your near infrared camera picks up whatever spill is there. I think you also would have encountered that. When you give it in the, when you give it in the cervix, you're away from the peritoneal field, so your camera will not pick up. Here, any little bit of spill outside will also be picked up by the near infrared camera.
In a couple of cases, ma'am, where we had a unilateral detection, the opposite side was completely fluoresced.
Yeah, so it just because we're doing it for open sentinel nodes for ovarian cancer. We are trying it. So the problem, it's very good for endometrial when you inject ICG into the cervix. But when you go into the abdomen and try to inject it into the ovarian ligament or in fundopelvic ligament, there's you pick up more of the fluorescence. So anyway, good study. I think you presented well. It was gone into depth and it was a good study. Yeah.
Thank you, ma'am.
So next we have the last presentation for the day, Dr. Megha Priya.
Good evening all. My topic for today's presentation is survival analysis in SGO intermediate risk group of endometrial carcinoma. Thus MRH elevates the need of VBT, a retrospective observational study. In 2016, SGO ESTRO published an endometrial carcinoma treatment guidelines based on clinicopathological characteristics of the patient. SGO ESTRO ESP updated these guidelines in 2020, integrating molecular markers to define the prognostic risk group. The 4 prognostic risk groups are low, intermediate, and high, with molecular classification known and molecular classification unknown. The current study highlights the EEE's intermediate risk group with molecular classification unknown. The main aim of the study is to determine the overall survival and disease-free survival in SGO ESTRO ESP intermediate risk group population and to analyze the pattern of recurrence in VBT, that is vaginal brachytherapy received versus no adjuvant treatment group in the study population. This study is a single institutional retrospective observational study conducted in the Department of Gynec-Oncology at Lakeshore Hospital, and the study period is 84 months from January 2014 to December 2020. Inclusion criteria: the patients who fits into EEE's 2020 intermediate prognostic risk group with molecular classification unknown included in this criteria. These patients are stage 1B endometrioid low grade with focal or negative LVSI, stage 1A endometrioid high grade with focal or negative LVSI, stage 1A non-endometrioid without myometrial invasion. The exclusion criteria are the patients who belong to low, high, intermediate and high risk group. The results: in the study period, total number of endometrial CA operated is 294. Among them, 275 were endometrioid and 16 were non-endometrioid and 3 were mixed tumor. Among endometrioid, 205 patients belongs to stage 1A and 2 were high grade stage 1A and 42 patients were stage 1B and 34 were stage 1B low grade. And non-endometrioid, 1 patient with serous carcinoma was stage 1A without invasion. So the total study population is 37. The mean age at diagnosis is 61.6 years and 25 patients were above 60 years of age at the time of diagnosis and 12 patients were below the age of 60 years at the time of diagnosis and 34 patients were postmenopausal women. The most common presenting symptom is postmenopausal bleeding. All the 37 patients underwent MRH plus BSO plus lymph node dissection or sentinel lymph node biopsy. Pelvic lymph node dissection was done in 31 patients and SLNB was done in 6 patients. 4 were external iliac lymph node sentinels and 2 were obturator sentinels. The mean vaginal cuff length was 14.5 mm plus or minus 5.3 mm. The enlarged paralytic lymph node sampling was done in 8 patients. None of the patients had intraoperative complications. 6 patients had post-op complication clamidendo grade 1. All 6 had fever. Rest 31 had uneventful post-op recovery period. The average duration of hospital stay was 5 days. Among the 37 patients, 36 had endometrial adenocarcinoma and 1 patient had serous pathology. Among the 36 patients, 40% were grade 1 endometrioid and 51% were grade 2 endometrioid. One patient had endometrioid grade 3 and none of them had LVSI. Regarding the treatment, adjuvant treatment received, among the 37 patients, 12 patients were less than 60 years and 1 patient received VBT among this less than 60 years group. Rest 11 haven't received any adjuvant treatment. And in more than 60 years group, among this 25 patients, 5 patients received VBT and 20 patients haven't received any adjuvant treatment. The details of VBT received group: less than 60 years, 1 patient received VBT and the patient had tumor size of 8 cross 8 which involving lower uterine segment. 5 out of 25 patients in more than 60 years group received VBT. 1 patient had endocervical gland involvement. 1 patient had associated breast carcinoma So she received VBT along with RT for chest wall and axilla. One patient had a tumor size of 6x6 with high mitotic index, and 2 patients had lower uterine segment involvement. The median follow-up is 82 months. Only one patient out of 37 patients died after 86 months. The 5-year overall survival is 100%. And the 5-year overall survival in both NAT and VBT group is 100%. As mentioned, only one patient had lung metastasis, which was after 86 months. Among these 37 patients, 3 patients developed recurrence. 1 patient developed vault recurrence. She was more than 60 years, haven't received VBT, and recurrence was after 24 months of diagnosis. She was diagnosed during follow-up examination, and she received EBRT plus VBT after this recurrence, and she was doing well at present. The other patient had pelvic recurrence. She was less than 60 years. The recurrence is after 73 months, and she had sigmoid serosal deposit. She underwent systemic chemotherapy plus EBRT. Now she is also doing well. The other one had distant mets. The patient was more than 60 years, and the recurrence is after 78 months, and she had lung mets. She died after 8 months of chemotherapy. Coming to disease-free survival, the mean disease-free survival in the study population is 76 months. 5-year disease-free survival in the study population is 97.3 years. In NAT group, it was 96.8%, whereas in 5 years, disease-free survival in VBT group is 100%. Discussion: the recommended treatment in the study group, EE's intermediate risk group with molecular classification unknown, is if the patient is less than 60, omission of VBT may be considered. If the patient is more than 60 years, we want to give VBT. The NCCN also says the same, except in serous and clear cell, where we want to give VBT compulsorily plus or minus systemic therapy based on the peritoneal wash. So I compared this study with PORTEC 1 style and included the patients who fit into my criteria. Among the 714 in PORTEC 1, I included only 448 patients, and I compared this 448 patients with my 37 patient population. And the patient who haven't received NAT in the PORTEC 1 is 220. In my study, it was 31%. The vaginal recurrence in my study is 3.2, whereas in PORTEC 1, it's 11%. The difference in between PORTEC 1 and 2, 1 and my current study is that all the patients in PORTEC 1 underwent simple extrafacial hysterectomy. In my study, all the patients had MRH plus BSO. I compared the same with PORTEC 2 with my study. I included the patients who fit into my criteria. There are 224 patients. Among them, 191 patients received VBT. I compared these patients with my group adjuvant chemo received, VBT received versus VBT received and no adjuvant treatment group. The recurrence was more or less same. In my study, vaginal recurrence was 4%. In PORTEC 2, it's 3.4%. The role of MRH in endometrial carcinoma, there was one trial in Japan, which was conducted in 2009, which showed there is no difference between class 1 and class 2 hysterectomy. The local recurrence, overall survival and disease-free survival are same, but they concluded like class 1 extrafacial hysterectomy should be considered as a standard surgical approach provided adequate colpectomy. In PORTEC 2 trial also, they concluded like VBT reduces the risk of vaginal recurrence, but still it's a over treatment. Only one patient need to prevent one patient's vaginal recurrence, we are treating 8 patients. So limitation of the study is it's a single center study and it's very small population, and molecular classification is not included in the study. There is no pioneer study to compare. To conclude, along with these standards like stage, grade, age, LVSI, molecular classification, other gray areas demanding the further studies like demographic pattern, radicality to achieve adequate colpectomy, mitotic index, and some other factors to be included to tailor our procedure and treatment. Thank you.
In your study, what is the conclusion? Does modified radical hysterectomy actually alleviate the need for vaginal brachytherapy? What is the conclusion?
Ma'am, actually we want to tailor our treatment. I'm not supporting MRH, but we want to give adequate vaginal margin resection. Not the parametric radical.
Statement, you're not supporting something, but you want to do something. Can you clarify?
Not a typical MRH kind of, but we want to provide adequate vaginal cuff. The adequate margin, we can do TAS.
What were the stages included? All stages were included?
No, ma'am, I included only ESCOs intermediate risk.
Sorry?
For this study, I have included only ESCO's intermediate.
Intermediate.
Those intermediate risk only,
ma'am,
the 37 intermediate. You think 37 number is enough to draw conclusions
No,
on
no,
your
ma'am.
conclusions?
I agree with that. No, actually, but we want to consider this as a point, and we want to do further studies based on this.
So you think vaginal brachytherapy, your colpectomy can replace vaginal brachytherapy? Is that what you're trying to say?
It alleviates the severity of. Anyway, all the patients are having the overall survival equally, but the disease-free survival is the thing which matters.
Were the recurrences, were vault recurrences? They were distant recurrences. You said lung recurrence and somewhere else. So colpectomy you will probably reduce, and vaginal brachytherapy will reduce vault recurrences.
Yes.
So, but you didn't have any vault recurrences.
I had one vault recurrence.
But you did a colpectomy in that patient also.
Yes, we did.
So you did. So it doesn't really. You understand what I'm saying? So, is colpectomy really required?
It may help.
But you'll have to study larger numbers then.
Yes,
in a small number, you will not be able to see.
That's the limitation of the study. It's very small population to conclude.
Okay.
But we can consider this as a point.
What was the duration of your follow-up?
80 months, ma'am, median.
84 months.
84 months. So 84 months means something like the POTEC trial also you would have had the follow-up. You should have been able to, yeah.
And POTEC 2 is 82 months, more or less equal.
Ma'am? Yeah, I think, thank you.
Thank
you so much. Thank you. This one, last one, overstepped. No. After the buzzer rang also 3 minutes before. Okay, even then she overstepped. Then you make it 10 to everything. If you think that nobody has this thing, because when the buzzer rang, no, but this last one overstepped, definitely. Second buzzer also. Anyway, if you think you have, then give everybody, if nobody overstepped, give everyone the same. Okay? Is that okay? Yeah, we're giving 10. In time management, everybody gets the same, because you say nobody has overstepped. Put everybody 10. Put it 10. Make it 10. Make it 10. Then let it be equal to everyone. So I thank the youngsters for their presentations. I think a lot of hard work would have gone into it. And you've done quite an extensive, in-depth analysis. So thanks. I think we should congratulate your mentors also and guides, because I have to keep pushing my boys. I have some boys, I have to keep pushing them. Do, Nikalo statistics, ye karo, wo karo, all the time I have to be pushing them. So I think that's good work from you all and your mentors. Good work. Yeah. Thank you. Don't go and tell my boys this, that your madam was saying that you all don't work. You'll announce the results now.
Thank you so much, Shalini ma'am, Amrita ma'am, and Michelle ma'am, though even after such late hours for staying back and judging the papers, we are extremely grateful and we appreciate it, ma'am.